Good morning, everyone, and welcome to day 3 of the NIH Pathways to Prevention workshop, Advancing Research to Improve Health During the Menopausal Transition. My name is Keisha Shropshire, and I am the P2P workshop coordinator. I will serve as your master of ceremonies today and help guide us through the final day of this important workshop. On behalf of the NIH Office of Disease Prevention, I'd like to thank our workshop co-sponsors, the planning committee, our independent panel, today's speakers and moderators, and all of you for your continued engagement throughout the workshop. Before we begin, I'd like to cover some brief housekeeping reminders. As many of you know or now know the flow, please remember, let's see, I'm trying to adjust my slides. Oh my goodness, hold on one second. Sorry. Apologies. All righty. So as a reminder, we have our website, NIH Prevention website for the actual workshop webpage where you can find the agenda, the independent panel bios, panel draft report, and also any workshop recordings. And please remember to engage respectfully and in accordance with the NIH Office of Disease Prevention event guidelines. Thank you in advance for helping us maintain a productive and inclusive discussion space. And as a reminder, please use the Q&A feature to submit questions for speakers and panelists, and use the chat for comments only. Closed caption are available and can be turned on using the Zoom toolbar. And there are 3 opportunities that the public has to share input and perspectives. So each day of the workshop, we will pose a brief engagement question that's tied to today's theme, and they're designed to capture your perspectives, highlight key issues, and help inform the panel's understanding of the gaps, challenges, and opportunities discussed during the workshop. The second is the draft systematic evidence review, which is prepared by the RTI-UNC Evidence-Based Practice Center, which is available for comment now on the ARC's website. Finally, the independent panels report, draft report, will summarize the workshop findings and future research priorities, and that will be available for comment in June. At the end of each workshop, we will send around our email, and you'll receive a Zoom link after you close off, an opportunity to provide your feedback on how things went throughout the workshop. So to get us started, I'm pleased to turn it over to Dr. Cheryl Anderson, our workshop and panel chair, for opening remarks and a recap of day 2. Cheryl, you have the floor.
Hello, everyone, and thank you so much for joining us for our 3rd day of this workshop. We are delighted that you are with us and hope you'll find it as exciting, engaging, and instructive as our committee has found it. So I'm going to provide a recap of what we went through yesterday. As you know, we are here to talk through advancing research to improve health during the menopausal transition. And yesterday we talked about when we're trying to look at the effectiveness, comparative effectiveness, and harms of treatments for menopausal symptoms in perimenopause and early menopause, we looked at what does it mean to see variation by timing and type of menopause. We also talked about variation that we can find in individual and system level factors and what it means to age healthfully. And within the Healthful Aging Symposium, we heard really insightful presentations on perimenopausal related sleep disturbances, perimenopausal effects on memory and brain health, the mental health perspectives on the increased use of mHealth technologies as well as wearable sensors. And then we closed out the day looking at our key question and the impact of individual and system levels factors on the receipt of treatment for perimenopausal and early postmenopausal systems. That included factors such as educational attainment, patient engagement in the healthcare system, lifestyle factors, comorbidities that patients may experience, and provider bias, access to care, and social determinants of health. So today we'll move into our day 3 agenda, which likely you have in front of you. But without further ado, the first thing that I'd like to do is to introduce our NIH leadership. We have two speakers today from the NIH leadership team. We heard already from leaders in other institutes, but today we're going to add to that perspective list that you've already seen. On Wednesday, we heard from the Office of Research on Women's Health and the National Institute on Aging. On yesterday, we heard from the National Cancer Institute and the Eunice Kennedy Shriver National Child Institute of the National Institute of Child Health and Human Development. And this morning, we're going to hear from the National Institute of Mental Health and the National Heart, Lung, and Blood Institute. So our first speaker is Dr. Andrea Beckel-Michener from the NIMH. Dr. Beckel-Michener is the acting director of the National Institute of Mental Health, the lead federal agency for research on mental disorders. Dr. Beckel-Michener joined NIH in 2004 and has led multiple leadership positions within NIMH. She has overseen several large programs and collaborative projects, including management of the Functional Neurogenomics Program, the Single Cell Analysis Program, and the Brain Research through Advancing Innovative Neurotechnologies, or BRAIN Initiative. She continues to serve as Deputy Director of the BRAIN Initiative. Our second speaker is going to be Dr. David Goff from the National Heart, Lung, and Blood Institute. Dr. Goff is the acting director of the National Heart, Lung, and Blood Institute. He's also the deputy director for precision medicine on data science at NHLBI. He serves as NHLBI's executive sponsor for the Transomics for Precision Medicine, or TopMed program, and the Biodata Catalyst program, NHLBI's cloud-based data science ecosystem. From 2016 to 2024, Dr. Goff was the director of the NHLBI's Division of Cardiovascular Sciences. While in the division, he led to the launch of several new strategic initiatives, including HeartShare and the Accelerating Medicines Partnership for Heart Failure. What we're going to do is I'm going to turn the mic over to Dr. Beckel-Michener, and then we'll hear a video from Dr. Goff, who is unable to join us in person this morning. So over to you, Dr. Beckel-Michener.
Thank you. Thank you so much. Special thanks to all of the organizers, and a shout out to Tamara Lewis-Johnson, who helps coordinate women's mental health research along with other program colleagues. I'm really excited to be here today to highlight a few advances and opportunities that NIMH is supporting in mental health research focused on the perimenopause and early postmenopause periods. First, I'd like to start by highlighting a paper from NIMH's Menopause Research Portfolio by Schmidt et al. Called The Effects of Estradiol Withdrawal on Mood in Women with Past Perimenopausal Depression. This landmark randomized trial conducted by researchers within the NIMH intramural program demonstrated that withdrawal of estradiol can trigger depressive symptoms in women with a history of perimenopausal depression. The study provided some of the strongest experimental evidence that hormonal fluctuations during the menopausal transition can directly contribute to mood disorders. An additional investigator-initiated study, there are many investigator-initiated studies in our research portfolio, and they examine a variety of impacts on menopause, including mood and cognition, brain health, sleep, and hot flashes. In one NIMH-supported study, researchers from Michigan State University are investigating how hormonal fluctuations during perimenopause influence brain function and a risk for psychiatric symptoms, including mood disturbances and psychosis. Another example is a project funded at the University of North Carolina, Chapel Hill. They're examining how hormonal changes during the menopausal transition affect brain systems involved in motivation and reward. with a goal to explain why some women experience new or worsening mental health symptoms such as depression, loss of pleasure or anhedonia, or psychosis during perimenopause. These researchers recently published a paper that identified a broad range of perimenopause onset distress symptoms beyond depressed mood, including anxiety and maladaptive temperament. NIMH is also supporting a study led by researchers at Penn, University of Pennsylvania, that focuses on how hormonal changes interact with circadian and behavioral rhythms. This group just published a paper and found that sleep disturbances, particularly difficulty sleeping due to feeling overheated or experiencing night sweats, may serve as an early physiological indicator of hormonal change affecting sleep and our circadian rhythms. This is just a flavor of some of the studies that we're supporting. I also want to highlight how NIMH collaborates with other NIH institutes and centers and offices to expand and advance the research in different ways. For example, you may have already heard this in the last couple of days, the NIH Sleep Research Coordinating Committee, which includes several NIMH staff, is planning a workshop titled Sleep and the Health of Women for this fall to examine how sleep and circadian rhythms influence women's health across the lifespan. This workshop will bring together researchers, clinicians, and federal partners to review the current state of the science and identify key research gaps related to sleep and health outcomes in women. So stay tuned for more information, including how to register for that meeting. Lastly, and maybe most importantly, I want to encourage you to check out some ongoing funding opportunities. There are 2 active NIMH program announcements related to mood and psychosis symptoms, specifically during the menopause transition. I'm going to read the announcement slowly so you can Google them. It is PAR-25-282 and PAR-25-281. That is an R21 opportunity and an R01 opportunity. These funding opportunities are designed to support research across the discovery pipeline, from exploratory studies to more developed investigations, more mature investigations. These follow the typical NIH submissions. So the next receipt dates are in June. And for those of you that is too soon, there are receipt dates again in October. Also, be sure to regularly check simplergrants.gov for new and forecasted funding opportunities, as well as the new NIH highlighted topics dashboard to stay informed about research opportunities and interest areas, including around the menopausal transition and menopausal period. So thank you so much for your interest in and commitment to improving women's health and women's mental health. We look forward to working with all of you to help women and their healthcare providers effectively navigate the menopausal transition. And I hope you have a wonderful third and final day. I've enjoyed the parts that I have been able to join over the last couple of days and enjoying today also. Looking forward to that. So thank you so much.
Thank you for the opportunity to speak today and for your commitment to improving the health of all women. I want to begin by expressing my appreciation to the Office of Disease Prevention for spearheading this important workshop. ODP's leadership is instrumental in closing critical scientific gaps in perimenopause and menopause research. The National Heart, Lung, and Blood Institute is committed to improving women's health across the life course. We view perimenopause and the menopausal transition as important windows when rapid biological changes create opportunities for disease prevention and tailored interventions. The urgency is clear. Women 45 and older are projected to bear the greatest burden of cardiovascular risk factors and disease over the next 30 years. And the menopausal transition offers a unique and timely opportunity for intervention to promote cardiovascular health and prevent cardiovascular disease and other chronic conditions. Menopause is more than a milestone. It's a cardiovascular inflection point. It accelerates arterial stiffness, and drive shifts in the gut microbiome and inflammation, all of which heighten cardiometabolic risk. The impact goes beyond the heart. Up to half of women experience sleep problems during this transition, raising metabolic and cardiovascular risks. And lung function also declines during the menopausal transition. At NHLBI, we're focused on solutions, not just observation. Findings from the OPATCH study showed that even light physical activity is associated with lower cardiovascular risk in older women. And now the WISH trial is testing a light touch intervention to promote low intensity activity to improve outcomes. Our multi-level approach intentionally pairs biology with context. We're advancing research that examines how behavioral, sociodemographic, and environmental factors interact with menopause-related biology to shape heart, lung, blood, and sleep health during midlife. To make this possible, robust, comprehensive data are essential. Our cohort of cohorts integrates behavioral, molecular, environmental, and clinical data from over 200,000 participants, enabling holistic and personalized research. Our new AI-enabled Precision Health Initiative leverages advanced artificial intelligence to analyze these rich data resources, uncovering new patterns and developing more precise prevention and intervention strategies, especially during key transitions like the menopause. In summary, we recognize that menopause is a pivotal stage for women's health. With ODP's leadership and our shared commitment to integrated, data-driven, and personalized approaches, we are poised to make meaningful progress in preventing chronic disease and improving quality of life for women in midlife and beyond. Thank you again for all you are doing to improve the health of all women.
Thank you both, Dr. Beckel-Michener and also Dr. Goff, for his remarks. We will now move into our first scientific session for today for key question 2A, which focuses on the impact of individual level factors on the receipt of treatment for perimenopausal and early postmenopausal women with symptoms. To frame this session, we are joined by Dr. Genevieve Neal-Perry, who will provide moderator perspectives on how individual level factors influence care. Dr. Neal-Perry, welcome.
Thank you. Good morning, everybody, and thank you to NIH for really putting this program together and talking about this important topic. Just want to start with just a few comments about who am I and you know what is my interest. I am the chair of the Department of OBGYN at the University of North Carolina. And I've been in the space of reproductive aging and the interaction between hormones and the brain for over 25 years, bridging both basic science as well as clinical research. And so today we have a wonderful lineup and really just understanding how individual and system levels as well as policy impact both the experience as well as treatment of menopausal women. Now, before I do that, I just want to step back for a minute and ask a question of each one of you that's here today. And that is, how many of you, just with a clap, are actually menopausal or perimenopausal? Just use the clap emoji. Okay. All right. Awesome. How many here today know someone who's menopausal or perimenopausal? Use the clap emoji. Okay, so I asked you that question because while we talk about menopause and perimenopause today, it's so important to appreciate that it impacts the lives of all of us. So this is something that as we think about the outcomes, as we think about the medical consequences of those with severe and debilitating menopausal symptoms, it's not just that individuals who's impacted, but it's literally the family, the village, the country. So important to keep that in context. And when we also think about menopause, while it is a natural process, and not everyone has symptoms that's debilitating, we have to find that balance. And how do we find that balance around conversation to ensure that those who need help receive the help and those who don't are able to move forward, have their questions answered without being without the sense or feeling that medications or interventions that they don't need are being pushed upon them. And that is really the goal of today. Now, you will hear some things that will be repeated, and the reason that is because it's so important that we repeat it so that you remember that. And that is that 1.3 million women in the US enter menopause, okay? And that is, when you think about menopause, it could be half of the life lived by many women today. We're living longer, and so as we live longer, we want to have a healthier life. We know that from the previous reports, previous presentations, in some cases, heart health, bone health, brain function are all impacted, as well as overall daily wellness. And so as we think about this, we want to think about how do we bridge the gap and improve these outcomes. And it's not just about the symptoms. There is a tangible cost to these symptoms, the lack of treatment, the lack of access. And when we think about healthcare, it's at least 1.5 million additional healthcare visits annually, about $330 million is spent in healthcare each year, and $1.8 billion lost due to missed work days. So really something that we want to keep in mind. So what constitutes the menopausal experience? And it's so important to realize that it is a complex biology. The experience is not the same for everyone. So we can't approach this in a monolithic way, thinking that there's a one fixed solution for all. Your environment, your race, your socioeconomic environment can have a huge impact on your experience. And equally important, it's often underdiagnosed. We have situations where care is fragmented or absolutely absent for those who are seeking it. So it's really the perfect storm where patients, providers, and the systems feel a shortfall. And that is that there are gaps in education. There is delay in care seeking, as well as misdiagnosis. There are concerns around trust. Can I trust what I'm hearing? There's unregulated digital information. More than 60% of online menopausal claims are outside guidelines. And there's a real need for trusted, accessible pre-midlife education so that women and their families can understand what to expect. And then understanding that, you can understand what you need to do and how to prepare for it. In addition, when we think about our clinician and workforce, there's a gap. Only about 7% of clinical clinicians feel prepared, and there's a reason for that. And how do we bridge that gap? There's no standardized menopause training or understanding of what women may experience, and understanding that there are ethnic and racial differences as well as cultural expectations. And when we think about the workforce, it's so important to understand that there are physicians who want to spend time, but they don't have time because of the way that it's set up in terms of the way that insurance companies may pay for visits, that they're not really allowed to spend the time that may be needed to take care of women. So there is work ahead, and we really need to create an even playing field, a level playing field, and that we need to approach this using evidence, ensuring that evidence is reaching patients as well as our clinicians. We need to understand the importance of advocacy and implementation, and use this as a way to do research to ensure that we're providing recommendations that actually apply. We need to think about how do we scale the interventions. We need to think about how our communities can actually be integrated in these care models and help us move this forward. So bridging the gap for menopausal care really demands strategic alignment of patient empowerment, clinician preparation, as well as creating accountable systems and policies that take into consideration what women need in order to make the transition and really live a healthy menopausal life. So with that, we're going to move to our first speaker. And our first speaker for today is Dr. Rajita Patel, who will be closing the menopausal care gap and workforce issues. Thank you, Dr. Patel.
Thank you. So yes, my name is Rajita Patel, and I am an assistant clinical professor in the Department of OBGYN at UCLA. And I am the director of the UCLA Comprehensive Menopause Program. And today I'm going to be focusing on a specific and under-recognized driver of the menopause care gap, which is the workforce issue. I have no disclosures. So in this talk, I'm going to be focusing on the clinician-level individual factors contributing to the national menopause care gap, additional clinician-level barriers that influence treatment receipt, workforce development strategies, and an integrative multi-system whole person model that we built at UCLA that shows how modifying clinician-level determinants can expand access to evidence-based care. We are at a critical national moment for menopause care. More than 50 million women in the United States are in the menopause transition or in postmenopause, and yet half of those symptomatic women receive no treatment, and fewer than 5% of eligible patients receive menopausal hormone therapy, despite meeting criteria and likely benefiting. That is not because women are declining treatment, it's because clinicians are not offering it, because they were really not trained adequately. In 2019, a Mayo Clinic study found that only 7% of recent OBGYN and internal medicine graduates felt prepared to manage menopause. 1/3 said that they would not offer hormone therapy to a newly menopausal woman with no contraindications. This gap did not emerge in a vacuum. It reflects decades of institutional neglect and underfunding, the fallout from the 2002 WHI misinterpretation, and an educational void that persists today. In 2019, that same study, 20% of residents reported receiving no menopause lectures. In 2023, a study came out showing that 31% of OBGYN programs had a menopause curriculum, only had a menopause curriculum, and despite 93% of program directors agreeing that all residents should have one. Fewer than 30% had dedicated menopause clinic time. And a 2025 multi-specialty survey found the most frequently reported barrier to providing menopause care was a lack of training, and the most frequently requested solution was training. At this current state, if clinicians want to learn about menopause care, they must do so on their own dime and time. And the result is a workforce that is unprepared and a population that is greatly underserved. And layered on top of this are cultural narratives, silent stigma, and the idea that menopause represents decline. And these narratives not only shape patient experience, but they also affect clinician perception of this care as being important and worthy of their time during their clinic visits. We are now facing a true bottleneck in access to menopause care. Public awareness and demand for menopause care has risen sharply, but the supply of clinicians who feel knowledgeable or confident has really not kept pace. And the result are long wait times, limited availability, and a system that cannot absorb the volume of women seeking help. When the medical system cannot meet this demand, women turn elsewhere. Influencers, celebrity doctors, supplement companies, direct-to-consumer platforms, and much of this care is not evidence-based and at times can be unsafe. By the time a woman reaches a clinician, visits often begin with correcting this misinformation, which is quite time-consuming, emotionally taxing, and not really reimbursed. And even when clinicians want to provide menopause care, they face a clinical reality that makes it extraordinarily difficult. Visit times are short and time limited, sometimes 15, 30 minutes. In that time, clinicians must address a multi-system transition affecting thermoregulation, sleep, cognition, mood, sexual health, metabolic function, bone health, often competing alongside preventative care needs or unrelated concerns. Menopause also intersects highly prevalent comorbidities like hypertension, diabetes, depression, anxiety, obesity, autoimmune diseases. And these require clinicians to be able to differentiate menopause from aging, comorbidities, or something else completely entirely. And this is a critical window of prevention with long-term implications for cardiovascular disease, osteoporosis, cognitive decline, metabolic health, and mental health. And therefore, care requires nuanced risk discussion, shared decision-making, and an integration of evidence across multiple disciplines, all while attending to a patient's psychosocial and cultural factors. Clinicians must gather extensive information repeatedly throughout the day. Operational load like prior authorizations, medication issues, patient messages, referral coordination, and really adds further burden, none of which is really reimbursed. And because menopause care is non-procedural, clinicians, especially OBGYNs, often face a financial disincentive to provide it. This cognitive load is enormous and why many choose to not address menopause at all. And that is why training alone is not enough. Delivering this level of care in short visits is nearly impossible without tools that support clinicians in real-world practice. So how do we build a trained workforce capable of delivering evidence-based whole-person menopause care at scale? A first solution that I bring up is education percolation. This is a strategy that we developed at UCLA to embed menopause training directly into the workday and diffuse competence across the system, minimizing need for clinicians to use their own time and money. No health system can meet population-level demand if menopause care depends on a small group of specialists who get special training. A sustainable model requires a distributed care approach where primary care clinicians and general OBGYNs manage most of that menopause care and specialists focus on complex or high-risk cases. Most of menopause care is low risk and manageable by generalists with the right foundation. But as we just discussed, this is missing. This foundation is missing. Education percolation addresses this gap by using multiple reinforcing channels. So number one, embedding education during the workday, brief didactics, noon talks, morning sessions before clinic, protected teaching time. Having accessible CME, so virtual or local in-person CME offered in and outside of the workday. Peer-to-peer diffusion through champion providers. As clinicians gain competence, they become local champions who reinforce menopause principles within their teams, and then that trickles down. Having standardized documentation templates, which double not only as clinical decision tools and support, but also on-the-job education and teaching tools. And then having tiered triage pathways, they evolve with workforce growth so that low-risk patients are managed by newly onboarded menopause providers or generalists, and complex cases are triaged to specialists. Education percolation trains the workforce we already have during the hours they're already working. It builds capacity quickly and expands access without requiring new FTEs. We also cannot underestimate the importance of investing in the future pipeline. And this is really important to by them receiving regular didactics and access to the same CMEs and online training modules, hands-on experience through rotations, and board examinations that meaningfully assess menopause care. These are the mechanisms that really normalize medical knowledge around menopause rather than as an optional enrichment. And they are essential for building the future workforce capable of meeting population-level demand. Now, training provides that foundation, but as stated previously, clinicians need more support in real-world practice. Clinicians need multidisciplinary support and clear referral pathways because menopause is inherently a multi-system situation, and no individual clinician can manage all those domains alone. They need standardized workflows to reduce this cognitive burden and reduce unwanted variation, mitigate implicit bias, and create reliable, equitable care. Clinicians need embedded decision support tools like structured notes, risk stratification pathways, order sets, prevention prompts to reduce this cognitive load and make complex decision-making faster and more accurate. And they can benefit from flexible care pathways like group care to decrease cognitive load again from repetition, repeating themselves over and over again, and streamlining access issues from the clinician end, both for general menopause providers, but also for specialists. And then being able to provide patient-facing education to offload some of that foundational teaching and counter that misinformation, something that takes a great deal of time to discuss in the visit. So what does this look like when it's operationalized into a real clinical workflow? So at UCLA, we developed MAPS, the Menopause Assessment and Pathways Support System, a standardized whole person assessment and care pathway framework designed to specifically support clinicians in real-world practice. MAPS was built using the combined expertise of our menopause clinicians and collaborating specialists across many disciplines, including cardiology, bone endocrinology, sleep medicine, GI, psychiatry, oncology, and integrative health. Together, this group created 11 organ-specific algorithms that triage symptom burden and health risk into a clear red, yellow, green structure. MAPS begins before the visit, so it integrates a detailed online patient questionnaire with EMR data and runs it through these algorithms to generate a whole person snapshot. Clinicians walk into the visit with this snapshot already known, already understanding the patient's symptom clusters, health and genetic factors, lifestyle practices, and patient preferences. And this shifts the visit from data gathering to interpretation and shared decision-making. And during this visit, MAPS provides personalized evidence-based recommendations, risk stratification cues, prevention and early intervention opportunities that might otherwise be missed, structured notes, and order sets that standardize care across the providers. These tools reduce the cognitive load, improve consistency of recommendations, and support equitable evidence-based care even in a 30-minute visit. And importantly, MAPS is a dynamic learning system. Each use reinforces best practices, teaches pattern recognition, and builds proficiency. MAPS has been utilized for over 3,000 patients in our system thus far. Over time, MAPS has become both a care pathway and a training pathway for our clinicians and trainees. To make this system like MAPS work, the surrounding clinical infrastructure had to support it. So at UCLA, this CMP was intentionally built using these core elements. The menopause clinicians partnered with the 30 specialists across multiple disciplines and created a clear referral pathway system. The standardization of workflows across all the collaborating clinicians really ensured that we were using the same evidence-based framework and that every clinician approached menopause care through a consistent lens. And we offered multiple care pathways for flexibility for patients, but also for clinicians, traditional one-on-one, telemedicine, and group-based models, as well as hybrid models. And then we utilize that education percolation system that we talked about. With all of these elements in practice at UCLA, we have been able to expand our workforce. We began with 6 core OBGYN menopause providers at 3 UCLA sites. Over the past year, 8 new general OBGYNs at 2 additional sites joined us as low complexity CMP providers, and 10 PCPs across multiple UCLA sites will join next year. They did not join because of interest alone. They joined because the system has given them the education, the tools, the structure, and the support to feel competent. And these clinicians have become local champions at their offices, carrying their menopause expertise to their own practices, accelerating that education percolation across the system and increasing the number of physicians that want to join our team. But our long-term vision at UCLA is clear. The CMP will only serve as a referral hub for complex high-risk or multi-system cases, while every OBGYN and PCP in the UCLA system, this is our goal, should feel competent and supported to provide baseline menopause care. This type of model needs to be studied across diverse systems, a major opportunity for implementation science. Just one more quick plug for the benefits of standardized workflows for clinicians. It really lowers cognitive load and it supports care under time pressure. It improves safety, reduces unwanted variation, mitigates clinician bias, and enables dynamic training and education. It ensures patients receive consistent, equitable care across the clinics and clinicians. It creates transparent, reusable care plans that function as real-time teaching tools. And it provides structured, research-ready data, giving all specialties a shared clinical language. It is the mechanism that transforms individual clinician behavior into system-level capacity without sacrificing quality. So when we looked at clinicians at UCLA CMP who used MAPS, The two bar graphs show clinicians' before and after ratings of how comprehensive and individualized care they felt that they were giving. Before MAPS, most clinicians rated their comprehensiveness of care as only fair and good. After MAPS, the ratings shifted sharply towards great and excellent. The same improvement appeared for the individualized care. Clinicians reported they could better account for genetics, lifestyle, health status, preferences, and symptom patterns once they used MAPS. And providers reported improved documentation and strengthened collaboration with specialties across the board, and they would not want to return to pre-MAPS care. While MAPS standardized the one-on-one visit pathway, I want to highlight one additional pathway that supports clinicians in real-world practice, and that's group care. When clinicians care for midlife, they quickly realize that they repeat the same foundational education, the same questions, the same misconceptions, the same uncertainties across many individual visits, adding to their burden of cognitive load. So to address this in menopause, we adapted the Centering Pregnancy model and created the Centering Menopause model with the Centering Health Institute, a structured group pathway that brings 8 to 12 women together for 10 two-hour sessions focused on different menopause topics. And these sessions are co-facilitated by a CMP provider and a rotating specialist. For the clinicians, the benefits were substantial. It reduced repetitive counseling. It shifted clinician role from lecturer to facilitator. It brings specialists directly into the room, strengthening collaboration and reducing the burden of coordinating multiple referrals and increasing access. And it increased efficiency. 10 women receiving specialist input in one session, much more scalable than 10 separate visits. After our pilot, clinicians described Centering Menopause as restoring meaning to a clinical encounter through community and shared lived experiences, and they felt overall a lower cognitive load and for those 2 hours in a group setting than they would have felt if they had 10 individual visits. As I've shown you, the UCLA Comprehensive Menopause Program is built on these two clinician-focused pillars. The first is educational investment, using the education percolation model. The second is supporting clinicians in real-world time-limited visits through infrastructure we outlined. And together, these pillars have produced measurable impact. So after going live in 2023, UCLA, shown in green, saw a 55% increase in menopause patient volume over 2 years, far outpacing every other UC site who does not have a structured menopause program yet. And importantly, this reflects increased capacity, not increased demand, because demand has risen across all of California, not just LA. 5 other UC sites are now partnering with us to build similar programs, creating an opportunity to study how these interventions perform across diverse contexts. Here are the key research priorities that I've outlined moving forward. We need to study and define clinician-level determinants that shape menopause care quality. We should test targeted interventions across diverse settings. We need to study how multidisciplinary input strengthens clinician decision-making. We should evaluate group-based models as strategies to reduce clinician cognitive load. And finally, we must use structured clinical data to understand variation in assessment, treatment selection, and follow-through. Clinicians can deliver high-quality, equitable menopause care when they are trained and well-supported. And with that, I'd like to thank you and now turn it over to our next speaker, Dr. Irene Inouye.
Thank you so much, Dr. Patil. And thank you for having me. My name, as she mentions, is Dr. Irene Inouye. I have been charged this morning to talk about gaps and opportunities in patient education concerning menopause and the transition of menopause. 100% of women will experience menopause if they live to a certain age, yet menopause is not funded, discussed, or clinically treated to the extent that it impacts the health and posture of 6,000 plus women that enter it every day. My work in the women's health space spans cardiovascular, gynecologic and reproductive health, autoimmune disease, and many other topics that play significant roles in the health of many women and have distinct intersections during and after the menopause transition. During my presentation this morning, I will share insights from the Impact Menopause study that I led as a PI at the Society for Women's Health Research, as well as broader patient engagement, and education programs that I've stood up, and key studies in menopause research and healthcare. As I highlight what we know in the field, I will also discuss gaps in the research and patient education, and with touch points on broader impacts in this space. I have nothing to disclose. First, what we do know, and I cannot drive this point home enough, menopause is a hormone-driven life stage, not a disease. And while menopause transition typically occurs in a woman's 40s or 50s, 5 to 10% of women will enter menopause before age 45. This early estrogen depletion is characterized as early menopause if it occurs between the ages of 40 and 45, or premature menopause if it's younger than 40. And on the other end of the spectrum, up to 5% of women will enter menopause after the age of 55. Menopause that is onset due to medical procedures or surgery, such as an oophorectomy or certain chemo or radiation therapies, is iatrogenic and can occur at any age. There is no right or wrong way to enter menopause. However, 45% of women don't know the difference between perimenopause and menopause prior to experiencing symptoms. Now, unawareness is definitely not a good way to enter menopause. But this confusion surrounding menopause stages and transition causes many women to delay reaching out for support and others to make misinformed generalizations about menopause and aging. Limited understanding about the role of estrogen in the female body further contributes to misunderstandings about symptoms and misaligned expectations about the menopause experience and potential changes in a woman's health as she ages. What else do we know? We know that estrogen has many functions in both the male and female body, some that are similar and others that are uniquely different between the sexes. However, in women, it is most known for its role in reproduction. The areas that are often referred to as bikini medicine, breast health, egg cell maturation in the ovaries, and menstrual cycling in preparation for pregnancy and menses. Okay. Estrogen is also keen for cardiometabolic functions. In the heart and liver, it plays roles in cholesterol production and metabolism, and studies have established that after menopause, there is an increased risk for cardiovascular disease. This concern is valid and important to communicate to women to engage in appropriate preventive care. Structurally, estrogen supports the integumentary system, where it promotes collagen production in the skin, as well as hydration and elasticity. It also promotes bone density and strength, which is a key contributor to 80% of osteoporosis patients over the age of 50 being women. Last on my very abbreviated list of estrogen functions in the body is its role in the brain. Because of estrogen's role in body temperature regulation, its menopause-dependent decline results in 80% of women experiencing hot flashes. Estrogen also promotes cognition and brain health, as well as sexual desire and function. All of these estrogen effects are key across a woman's lifespan, and when estrogen declines during menopause, we observe a wide array of symptoms and a wide array of symptoms and different severity of symptoms associated with this hormone transition. From hot flashes to brain fog, there's genital and urinary symptoms, mood and sleep disturbances, weight gain and redistribution. Almost every system is affected by this fundamental sex hormone. Without full awareness of the roles of estrogen, women are less likely to associate these changes in their body to menopause, potentially delay care seeking or treatment. And according to a survey published by Bonafide, 20% of women delay more than a year before seeking treatment for their menopause symptoms. Moreover, the seminal study of women's health across the nation, or SWAN, reported variations in vasomotor symptom duration and severity across racial ethnic groups. Asian American women, on average, experience the shortest duration of VMS, whereas African American women experience symptoms more than 3 years longer than the average. Studies have also shown that women of color are more likely to begin perimenopause earlier, experience a longer menopause transition, and have more severe symptoms. Yet there are gaping holes in our understanding of these disparities across age, genetic ancestry, health status, and other important determinants of health. With system-wide roles of estrogen throughout the body and the even more vast range of consequences that result from menopausal estrogen decline, symptoms are too often missing a diagnosis or misdiagnosed in midlife women. Menopause has not gone completely untouched in the clinical space, as there are treatment options for almost every symptom associated with menopause. Vasomotor symptoms, or VMS, have the well-known hormone therapy option of estrogen with or without uterine protective progesterone. To avoid redundancy from the previous day's sessions during this workshop, I won't go into too much detail about the Early Women's Health Initiative study report about hormone therapy and chronic disease risk. But I will say that we have seen decades of competing schools of thought and interpretations of WHI study data that have left patient populations conflicted, scared, and underinformed about the full range of hormone and non-hormonal options, systemic and local therapies, and complementary approaches to address symptoms. A better understanding, for example, of why a patient may be given an antidepressant or an anticonvulsant is also important education to promote confidence and comfort during the pursuit of symptom management. The genital urinary syndrome of menopause is a chronic progressive condition that affects up to 90% of women, of postmenopausal women. If not treated properly and in a timely manner, GSM can have irreversible impacts on a woman's health. There are a range of hormone-based and physical therapies available, some of which are listed here. And certain impacts of estrogen decline can lead to associated health conditions that actually have established diagnostic and treatment pathways. The diagnosis of depressive disorders, for example, increases 2.5 times during perimenopause. Medications and behavioral therapies are used for treatment, among other options. And interventions to address cardiovascular disease and metabolic changes also span pharmacologic and lifestyle approaches. There are also a plethora of over-the-counter options and remedies. However, there is conflicting data and limited data concerning many herbal remedies and dietary approaches. Systematic reviews may conclude that there are no significant benefits or outcomes for certain remedies, but then anecdotal evidence may compete with this published literature, leaving patient populations grasping for something to provide an effective relief, especially when medical options are not viable, whether this is due to access or hesitancy. This is by no means an exhaustive list of options, but just a glance at a wide array. And so when we think about this, how many treatments do you think the average premenopausal woman could name? Could they explain their importance? Do they have a reasonable expectation of the outcomes for that treatment or sufficient understanding of the potential side effects? Despite all these different treatment options and more that aren't listed here, up to 73% of women are not treating their symptoms. We have to invest in resources and efforts to understand why and to mitigate these barriers, because there are very present barriers for many women. Is the data that they are presented with the result of rigorous testing and reproducible by others in the field? Are women able to navigate to a knowledgeable provider who can then help them navigate diagnosis and treatment plans, and then require navigating insurance processes to obtain their desired treatments? I do want to take a moment, because in this little barriers pocket, I want to highlight the imagery that I used, that I included here. And on the left, you'll see a fence. And this is for those who can see a path to menopause wellness, but they have issues scaling their particular barriers or fully reaching through and accessing the education and care they need. On the right side, there are others that are facing a brick wall. They can't even see over or through the barriers that they're facing. And these unknowns are too many for these women and can often be overwhelming. So we have to approach these two scenarios of patient populations very differently, and with the sensitivity that is needed for their current situation and their individual needs and desires and health goals. The strategy to get menopausal women over, through, or around their barriers must be personalized. And so women are looking for solutions to be well in their body. so that they can continue to be productive members of society. This is often actualized in their work life. 75% of women in their mid-40s to their mid-50s are actively working. And this is during those typical menopause transition years. The resulting menopause toll or tax on the US workforce is over $1.8 billion. I charge us to think beyond white-collar office jobs with salaries and comprehensive leave plans where someone can work from home or take off with leave bank to spare, and consider the hourly paid worker who has a physically demanding job or works outdoors or with children all day. This individual experiences presenteeism. Their circumstances may not allow them to always take off, so they have to push through. Effective treatment or not, symptoms managed or not, waiting for a doctor's appointment in another 6 weeks. The employee perceptions and challenges concerning the transition of menopause, or the Impact Menopause study, showed that 26% of women considered not pursuing or did not pursue leadership opportunity due to their menopause symptoms and experience. 32% considered reducing or did reduce their workload. And even more, 38% considered finding or found a new job because of challenges they experience in their current workplace while navigating this life stage. Sleep disturbances and brain fog were selected as the most bothersome menopause symptoms while at work, with almost 80% of respondents. Weight gain and fluctuations in mood came in at just over 23%, came in on just over 2/3 of menopausal respondents. We need to identify solutions to support menopausal women, not only to promote health, but also to maintain high quality of life and even economic stability into older age. And the marketplace is here for it. Flow Health released a report in 2025 that estimated a market opportunity of $22 billion that women spent to address their perimenopause through treatments, education, and community. Individuals with mild symptoms spend an average of $1,978 annually, while individuals with severe symptoms spent up to $16,700+. Older women are finally seeing their issues addressed. However, the content and products available to the public is rising exponentially, and regulation and tracking are inconsistent. The vetting can be overwhelming, and it can be difficult for an individual patient to know where to go, which source to trust, and how much is reasonable to invest in their care. We as experts, stakeholders, and stewards of women's health have a serious mandate to ensure that women are empowered during this vulnerable transition in their life and in their health. So what does a menopause patient look like? This is menopause, stressful and tiring, right? Well, menopause can also have you swirling down online rabbit holes, researching symptoms and treatments and lifestyle hacks. But this is also menopause, a chef in a hot kitchen all day with her VMS well controlled. Or maybe it's someone delivering a talk to a large audience. They're navigating brain fog or maybe even joint pain while standing in their heels on stage. Menopause is also the younger woman who had a hysterectomy and oophorectomy in her 30s and has been postmenopausal for 10 years now. There are many faces and experiences for menopause. And again, I will say it, menopause is not a disease, but we have to safeguard the language and conversations surrounding this moment for menopause so that we don't stigmatize this inevitable life stage and experience. In summary, there are multiple pathways to menopause, and we need to increase patient awareness of these different pathways and how they affect symptoms. The symptoms are vast, and there is a need to have clear and defined recognition criteria to support patient-provider communication and to better understand the factors that contribute to differences and disparities across subpopulations of women. We must call out and address gaps in updated and trusted evidence and education on the vast array of treatment options, which are needed to support informed and shared decision-making in clinical and community settings. Given menopause's impact on workplace wellness, policies are also needed to support individual work-life health harmony. This is critical. And as technology and media rapidly evolve to engage the menopause space, data to understand their influence on patient perceptions and behaviors are key to protecting and better serving women during this life stage. Finally, reiterating that menopause is not a disease, but a hormone-driven health transition will promote investing in menopause research and education while reducing stigma and fear for many entering this life stage. And finally, I want to highlight 4 key areas of recommendations to support individual patient education and readiness for menopause. The first one, developing menopause preparedness resources and getting them in the hands of women before midlife. We have extensive models for menarche and for pregnancy, but we need to continue this along the lifespan into menopause. The second one is to invest in clinical trials to elucidate symptomology and disparities and identify more effective treatments and treatment approaches and therapies. The third one is to provide decision tools that can assist patients and their providers to identify menopause earlier in the transition. And the last one is to establish evidence-based strategies to increase public trust and trustworthiness among sources that are disseminating menopause education and care. And so with that, I will turn it over to our next speaker on the panel. Thank you.
Okay, well, that was a fantastic presentation, and all the speakers this morning have been amazing. So I'm Dr. Jen Gunter, and I've been tasked with talking about awareness and communications. And I think about this as kind of this space between the care that we deliver in the office and the patient experience and the patient knowledge. So the flow of information, that information ecosystem that we all live in. And I think it's very important for us to remember that science is very slow and we have many, many gaps, but the information ecosystem is lightning fast and it has many implications for how we deliver care, the perceptions people have about their bodies, and maybe even shaping the care that people are willing to take or the information that they're willing to receive. And I always think it's good to remind people that just a single bad case series on the MMR vaccine, before the information ecosystem that we now know, before that existed, back in the day of just lay press, has had all of this catastrophic impact that, we're in just a completely different time. So I just want to give my disclosures. I don't have any association with pharma or supplement companies. I am the author of the Menopause Manifesto and owner of thevagenda.com, which is a health information and advocacy platform. So I feel that there are, kind of 4 different kinds of knowledge gaps if we think about it. So we have training gaps, which we've heard about. We have research gaps, which of course contribute also to our training gaps. We have knowledge gaps, but we also have a big gap in how all of that is connected together in this information ecosystem. And when we know that women feel unprepared for the menopause transition, and certainly if their physicians feel unprepared to meet them, when we have this massive gap, it is no surprise that people go elsewhere. And of course they should. The internet is a library and everybody should have access to it. And I just went and pulled some data from the menopause subreddit just to look at the change in subscribers over time. And you can really see this exponential increase. And anybody who has spent any time talking with anybody about menopause, has spent any time online looking at menopause content, certainly, or read anything in the lay press about menopause, would have noticed an absolute increase as well. And this is fantastic. People should have more knowledge about their bodies. And I always think that when we see this increase in seeking information, that's fantastic. That means people are interested and they want to learn. And so we have to figure out how to meet the moment and meet their needs. So what's the current landscape that we have? We know that women widely use social media and apps and podcasts for menopause information, but really how they engage and interpret that content is really largely unknown. And I think that this is really important when we think about the current health information ecosystem is really this model of the illusory truth effect, that repetition breeds accuracy. So it isn't just that you might listen to a podcast, but you might then see clips of that podcast multiple times over the next 24 hours on a social media platform. And we know that the shorter interval also increases perceived accuracy. We know the content is coming from a wide variety of individuals. We have medical professionals, the traditional media, the wellness industry, influencers, celebrities, telemedicine companies, and the line is sometimes blurred. And so it can be very difficult to separate financial influences from true educational influences, and where does the bias begin and end? It can be very, very challenging. And the accuracy of this content is also really largely unknown. The other thing is our digital ecosystem is completely unregulated, but it has a massive impact on how it shapes knowledge, beliefs, and decision-making, and how this is influencing what women believe about menopause hormone therapy, safety, what they believe about the benefits of transdermal versus oral estrogen. All of these things, we just don't really have a good impact, but I think a good understanding. But I think if you asked anybody delivering menopause care in the office, they would say absolutely. And we heard a little bit about the increased burden of undoing the medical information online in the office. And when you sort of consider the broader sort of medical misogyny of the fact that women need more access to primary care, and so shorter visits and less access uniquely disadvantages them, and you have a 15-minute or 20-minute appointment, and there's also all this disinformation to correct, that can not only set up providers for conflict in the office, but erode from the time for giving good care. And I think another really important piece of the puzzle that people have to understand is that all of the algorithms really are favoring, fear-based content, and that once you start building an algorithm, that contributes to it as well. So there was an interesting paper published a few years ago that looked at over 900 women who described themselves as being in perimenopause. And the attitudes going in were, 61% were neutral or accepting, but a third of them were dreading it. And obviously, many people have terrible symptoms, but if you have very little information about what to expect, then things are going to be scarier, absolutely. 90% of them said they had not been taught about menopause in school. And I think that we're going to see this recurring theme of where should education begin and how early. And I'm going to say it should begin as soon as we can. A very, very small percentage said that they had good information about perimenopause or menopause. And I think this is really interesting, is that, 84% of women felt that they should have been learning about menopause in school, and 65% felt that they should be learning about it in the doctor's office. And there's a big theme of anger in their lack of education and frustration about how they've been treated and the difficulties in accessing care. And again, if we think about the reasons why people go online and enter the information ecosystem, they're curious, or they've been dismissed, or both in many cases, or they have questions that simply can't be answered. And again, I think it's really important that we understand that gaps create, this interest in needing to look elsewhere. When people feel really well informed, they're going to be less likely to go to certain places. And I think it's really interesting that a lot of people didn't start looking for information until their symptoms started. And we don't know how much of that is just it's not on people's attention, or that the link between menopause and aging and the negative connotations for women are so strong that people aren't interested in looking for it beforehand because of how it makes them feel in a patriarchal society. And so I think that we really have to kind of think about how we're going to be introducing the concepts of education about menopause earlier without reinforcing ageist stereotypes and negative patriarchal ideas. So, what are the impacts of using digital health technology? And this is, I think, a very interesting study where they took women and they asked them to seek information from websites, podcasts, and online groups. And 4 themes really emerged. And what they did was the women were required to do a 30-minute web search, listen to 2 hours of podcasts, and spend an hour in an online group or forum, which is probably much less than most people do. And out of that, sort of 2.5 hours of time, then there were interviews afterwards to sort of create the themes and to get the narrative reviews from the women. And there were really 4 main themes, which I think are very important for all of us who are interested in menopause from an education standpoint, is that the information is overwhelming. And I think that all of us in science know that there's a glut of information, and how then that gets translated into clinical guidelines and practice, things get weeded out. But when the information is sort of just blasted out there, that doesn't happen. There's no curation. And so content that is bad is out there, content that is good, content that we recognize as conflicting is out there. But if science is conflicted about something, and then how is the general population going to think about that, right? So that makes scientists look like they don't know what they're talking about. So the information itself is overwhelming. That there's such an individual nature of menopause, that people have different experiences and different symptoms, and we all have different biology, but we're also shaped by how we've lived our life in the world, and the supports that we have, and socioeconomic factors, and racism, and poverty, and so many other factors come into play. So this individual nature. And I think that also reflects why probably a lot of people are online, because it's hard to truly get individualized care in a short period of time. That evaluation of the resources is complex. Really, that how do you decide what has good content and what doesn't? When people don't have tools on how to navigate information, it gets overwhelming. And I often think back to, if you think about just a library and you walk into a library, think about if you have to find information on a topic and you don't know how to use the library system, versus there's a librarian there and you ask her a question or him a question, and then they help you access information, that having that guidance makes a big difference. And that digital resources were really only part of the picture. And I think another interesting topic that came out was that a lot of content providers, and I think that includes everybody, the media and anybody making menopause content, were sort of taking advantage of a hot topic. And that's something obviously that we see, but scaring women about reproductive health is also something that seems to be really quite popular, really quite profitable online. Now, what about the accuracy of the information that people get? And I think that this is a big concern that many of us have, is that, how accurate is the content? And anybody who's seen somebody in the office who spent time online, that it can range from being incredibly informed with highly accurate information, to things that we would consider to be very non-evidence-based, for example, like a belief in compounded bioidentical hormones. And this is a study from last year that was in the UK that looked at 180 top social media posts on menopause hormone therapy. And it's interesting that a significant percentage of these posts came from healthcare professionals, but lay people and the media as well. I found it very interesting that the media did not do well from a popularity point with the posts, and that 67% of the claims were outside of the official guidelines in the UK. So that clearly there's a divergence in a lot of content, and that 77% of claims were linked to conflicts of interest. So whether it was a private practice, pharmaceutical companies, or retail menopause products, but there was a big conflict of interest. Although interestingly, the conflict of interest didn't seem to impact whether the content was accurate or not. And there was also a study a few years ago, although I suppose in the digital ecosystem world, 4 years ago is a long time, that only 48% of the top menopause sites had good or excellent discern scores. So meaning that the more credible they were from a scientific standpoint, the harder they were to read. And so this really sets up this paradox that the most trustworthy sites are the least accessible. And so we really have to figure that out in how we are translating information to the general public in a way that's accessible, because the greatest information that's out there is of no value if people can't read it or understand it, or if it's not interesting. And so good content is clearly there, but if it's not accessible, then that's a big issue. So there are a lot of different ways to combat misinformation. And I think there's going to be another talk on that in a little bit. But I just wanted to review some of the major themes that emerge in the combating online misinformation and how that might apply to what we've just discussed. So accuracy prompts, have you read through the whole thing? Friction, making it harder to share. Lateral reading, which is checking other sources, debunking, correcting information, which is a lot of work that's being done in the office by healthcare professionals. Media literacy tips, social norms. That means advertisements that say like 50% of doctors recommend this, source credibility labels and warning labels. Now I want to talk about inoculation or pre-bunking. And that is basically having people have correct information up front and learning how to recognize what correct information is. In the themes of all the work is women actually want to get healthcare information from their medical care professionals. They want to get that in menopause. And in fact, when you kind of look across the board at health information in general, that's not actually unique to menopause. People are actually interested in getting their health information from physicians. The problem is the system is not set up for that to occur, either because the office visits are so short, physicians aren't providing the majority of the credible content online, the endemic misogyny of having incredibly short visits, or physicians aren't trained to make content that is accessible and legible and something that people actually want to learn from. And so I think that, you know, the theme that I would say is that people want to learn from healthcare professionals. We have to figure out how to make that happen, whether it's providing time, whether it's how we heard from the amazing menopause model of, disseminating care out earlier and having group visits so people can get access to timely care much faster, get access to information much faster. And so I want to end with some recommendations and have some discussions about this. So clearly we need to develop evidence-based educational tools about perimenopause and menopause. And obviously this is both for healthcare professionals and the public. Although I would say that we have to be mindful that we've done this before in sort of associated areas and it hasn't had an impact. And I just want to draw people's attention to the fantastic document that was produced several years ago. I think it came out right at the beginning of COVID on compounded bioidentical hormone therapy from the National Academies of Science, Engineering, and Medicine. And it was an incredible document that, you know, every physician who's interested in menopause and prescribing hormones should be reading and should be using to guide their clinical care. And yet we're still seeing a large percentage of prescriptions for compounded hormone therapy. We really need to study how digital platforms are shaping women's knowledge, attitudes, and treatments decisions. And, you know, are these just spikes that aren't really having, you know, when there's a podcast that goes viral, is this just a spike that doesn't have a long-term impact? Or is this really changing beliefs long-term? We really need to evaluate the connection between misinformation and conflicts of interest and give people tools so they can also identify that. I really think also we need digital health literacy tools, consumer-facing tools to vet accuracy and identify conflicts of interest. We need, guidance to promote transparency. And I think that we also need to equip providers with strategies to really correct misinformation, as well as encourage evidence-based public campaigns to normalize perimenopause and menopause experiences. And I think that, you know, if we're talking about, again, this central theme of women want to get information from their medical care professionals, they're interested in getting it in the office, that we really need to be, you know, taking a page from our pediatrician colleagues, you know, who start, you know, talking about milestones very early on. And I think many times in women's health, we've been focused on, you know, contraception and pregnancy and STIs. We've been focused on very specific things as opposed to how reproduction changes, how reproductive health changes over the spectrum over the years, and as sort of incorporating in curriculums how to talk to women about how things will change, I think will have an impact. And so I hope this gives people ideas and tools for moving forward. And I'm looking forward to having a robust discussion with my colleagues. Thank you.
That was fantastic, Dr. Gunter, and all three of the speakers really gave fantastic, compelling, and thoughtful presentations. And I just have a couple comments that I just want to elevate again, and some comments specifically from the speakers, and that is menopause is not a disease. Menopause is not a disease. It is not all doom and gloom. It is actually a liberating time. And we have the opportunity to help women navigate that perimenopausal transition into a space where they can thrive and be their very best during this liberating time. As I think about the menopause and the menopausal transition as a reproductive endocrinologist, I think about the times in the lives of couples and women when they're most vulnerable and when predatory activity is most rampant, and that's pregnancy, infertility, and a menopausal transition to perimenopause. People are getting information coming at them from all over the place, and it's really hard to navigate and understand who's actually looking out for me, who's really giving me information that's meaningful and thoughtful, and who's helping me move forward in a way that I can actually be successful. So this is an opportunity for us to really think about how advocacy, community engagement, and the empowerment of patients can make a difference. It really does take a village for us to think about how we move forward and how we move forward in a way that's most impactful. So I'm having a little bit of a problem with moving my slides.
Would you like me to advance them for you?
Yep. Yeah. Oh, yeah. Okay. Got it. Yes. Yeah. Not moving forward.
Okay, I'll do it for you.
Thanks. So I have a couple of disclosures, but I will tell you none of these activities impact my discussion today. Next slide. And my goal is to help us all understand the role of empowerment, community, and advocacy in menopausal care. And we'll talk really briefly around some knowledge gaps and opportunities. And again, I want to reiterate, you will hear some things that you've heard already, and that really just reflects the importance of that knowledge. You want to make sure that when you walk away today, that you have that fundamental knowledge as you think about how you provide care, how you think about building programs in your research programs. Next. All right, we talked about that there's a significant number of women that transition into menopause in the US. And I would even say, in what other situation when you have individuals, when you have 50% of individuals potentially having adverse outcomes, that we're not interested and really committed to making a difference. And then when we think about women, we compose about 50% of the population. And so that the impact of their experience is meaningful. And we've already talked about the economic impact, and that it's not just the individual who's impacted, but it's their family, it's the workforce. There are multiple areas that are impacted when menopausal symptoms are debilitating. Next slide. So, when we think about vasomotor symptoms, and that's one of the more common reasons that individuals will present, it's important to remember that they peak around the final menstrual period. The duration on average is 7.4 years, but it does vary based on your race, your ethnicity, your socioeconomic status, and that about a third of women will experience hot flashes. About 25% will seek medical care, and they will have concerns about quality of life, worsening mood symptoms, and anxiety. Next slide. And it's important to understand what may modify some of these experiences. So people who have pre-existing stress, anxiety, depression may have a worse menopausal transition. Individuals who've had life adversity, we heard yesterday about individuals who've had sexual assault, may have a worse experience. Social determinants of health, such as having a lower education, can impact your experience. Cultural expectations. We live in a society where fertility is really just uplifted and put on a pedestal. So when individuals are no longer considered fertile, there's this perception that maybe they're not as worthy. And so we're not investing in the same way that we might invest in trying to help someone achieve their fertility. Really important to understand that individuals who have symptoms before they're perimenopausal, if they're young, that they're more likely to have worsening symptoms and they last longer. Next slide. Next slide. Yep. All right. So as I kind of alluded to, and you have heard that your race and ethnicity can define your experience in terms of the menopausal transition. Next slide. Excuse me, next. So you've heard that Black and Latina women can experience more hot flashes that can last longer, and there are implications for this. There are implications around body adiposity, muscle mass, and as well as risk for cardiovascular disease. There's risk for osteoporosis. Next. And you've already seen this. And so it's really important to understand that women of color may have symptoms earlier, they have symptoms longer, but they're often misdiagnosed or dismissed when they seek providers. And this has an impact on the level of trust. And this is why engaging communities so that we understand what the concerns are in a way that we can actually address them is so important. Next slide. All right, so we spend a lot of time talking about hot flashes, but again, the symptoms are not monolithic. Women may complain about joint pain, weight gain, cognitive concerns, and oftentimes they're just dismissed or not recognized as part of this menopausal transition and menopause. Next slide. Okay. Super important, not monolithic, experiences vary. And as we do research, we need to think about that the experiences vary and not assume that everyone has the same expectations or the same experience. Next slide. All right, so this is a call to action. How do we actually help women and their families and individuals going through the menopausal transition actually navigate and actually have an experience where they feel empowered? Well, there's opportunities for us to transform their care through education, through empowerment of the providers as well as the patients, through community engagement, and through advocacy. What I want you to take away from this is that menopause is not just a biological transition. It is a health equity issue and a systems opportunity to improve the lives of women and their families. So we have many opportunities to modify the experience and to improve the quality of life. Next slide. So the menopause ecosystem and framework, the way that we want to think about it is that empowerment means that we have informed patients. With the community, we want trust, and we want to be able to reach out and embed and integrate within the community. Advocacy in terms of systematic and policy changes that are meaningful, and that we have research and evidence in terms of the innovation, and that what we do is framed in that context. Next slide. So the case for empowerment. Next slide. So there's a lovely paper by Martha Hickey et al. In Lancet in 2024 that really talked about empowerment in menopause. And the intent is to shift away from a passive patient to an active participant and to move away from symptom management to whole person care. And so the question is, how do we do that? It's going to involve shared decision making, creating an environment that's menopausal friendly, as what was described with the University of California in LA, having tools that support decision making about treatment, access to realistic and balanced information, access to support, and realizing that support is different for different people, and really challenging the stigma and the gender-based ageism and how that influences what we think about and how we introduce policies. Next slide. So the impact of empowerment. There is data that empowerment improves symptom recognition and treatment uptake. So if women or individuals understand what it is that they're likely to experience, they're more likely to trust in terms of which treatments make sense for them, and they're more likely to seek intervention sooner rather than later. It reduces unnecessary suffering. It enhances adherence and satisfaction, and really has been shown to improve long-term health outcomes. And again, this is based on the fact that there's earlier, they're seeking care earlier and interventions are sooner. So the key concept is that the empowered patient will seek care earlier and receive better care. Next slide. So as Dr. Nini actually alluded, there are barriers to empowerment. There's information, there's mistrust, there's implicit bias, there are assumptions that you should just, menopause is natural, yes it is, and that you should just suck it up. When in fact we know that women who have more severe hot flashes have more long-term health consequences. So no, it's not ideal for everyone to just live with it. If it's bothering you, you should seek care. You should understand when to seek care, how to seek care. And if that provider isn't providing you with the information that you need, to seek care elsewhere. Next slide. So some system barriers in terms of why women don't seek care: financial constraints and insurance coverage limitations. There are insurance companies that require providers to prescribe medications that are not FDA approved before patients actually have access to FDA approved treatments. This can result in patients choosing not to pursue care because they haven't had the intervention that they want and that they need, and so they just give up. Access to care and therapy. Similarly, there are some individuals who don't have access to therapies that we know that work. They don't have access to providers, and this will result in a lack of support, gender inequity, and lack of safe spaces to really discuss symptoms at home and work or in healthcare, because people feel that they don't have an environment where they can do this. Next slide. So reframing menopausal care, we want to be proactive rather than reactive. We've talked about how to integrate education into care delivery. That's both for patients as well as for providers. Creating the multidisciplinary center of excellence where women can go to one place to receive their care. So when we think about menopausal care, we're thinking about preventive, we're thinking about personalized, and we're thinking about patients who participate in their care and giving them the vehicle to do so. Next slide. So let's talk a little bit about advocacy and policy. Next. So when we think about menopause advocacy, we have some goals in mind. That is advocacy that drives awareness and research and policy change. So we've talked about the challenges around awareness. We've talked about gaps in research. And so we need policy to help us address these things. We've talked about the importance of normalizing conversations about menopause, how to improve access to evidence-based care, and to promote inclusive policies in healthcare workspaces. And this is truly important because many of the studies that have been done around menopause often exclude some of the patients with the greatest burden. Often women who have a BMI greater than 40 are excluded from studies that are focused on menopause, and they have one of the greatest burdens, as you heard earlier in the week. Similarly, there is not necessarily a good distribution in terms of racial and ethnic diversity when we know that there are variations in that experience. And we need research funding that supports innovation and that really requires and demands inclusion. Next slide. So levels of advocacy can happen at many different levels. There is the individual who can advocate for their own care, and one of the ways that you do that is empower them with knowledge. There are clinicians who can be champions in terms of evidence-based care. We need processes that make it less difficult for patients to do that make it less difficult for patients for clinicians to get the care, to get their patients the care that they need. And then there's the institutional level of advocacy in terms of health systems building menopause programs. But we also have to appreciate the cost that comes with this and being able to have the funds to do so. And then there are policies around funding guidelines, workplace policy and access, and understanding what type of policies do we need in order to improve outcomes. And also appreciating, as was previously indicated by Dr. Nini, that women who work in white-collar environments may need something different than women who work in a blue-collar job. So really being comprehensive and thoughtful as we think about policy. So who is on the kind of ahead of the game in terms of thinking about policies? Most of the policies that are happening at the level of the state. Rhode Island, actually in 2025, introduce a state policy about reasonable work space accommodations and explicitly prohibit discrimination that's based on someone's symptoms associated with menopause. In 2027, the city of Philadelphia has policy that's focused on accommodation around the perimenopause, menstruation, as well as menopause. And so as we think about it, it's time to really reframe how the menopause and the menopausal environment. And we need to do it just like we did for pregnancy 10 to 15 years ago. Next slide. So as we think about policy, we want to ensure that there is equity in the programs we build, understanding the experience about Black and Latina women, but also recognizing that rural populations face similar limitations in terms of access. They have transportation barriers and the significant impact of your socioeconomic status, your education on your experience and how interventions may improve that. Next. So in terms of advocates and agents of change, clinicians can help to normalize the conversation, bring up the conversation when your patient is sitting in your office before the average age of menopause, combat misinformation, lead program development, engage public discourse around the topic. Healthcare systems can develop centers of excellence, integrate clinical research and education as a unit to help advance care, really expand telehealth access, and invest in community partnerships. Next slide. And community engagement. This is a critical piece of this process. Next. So why community engagement? Because we know that most menopausal care actually happens outside the healthcare system. And it is the peer networks that actually shape beliefs and behaviors. And this is how social media actually works, right? It's about those communities where people are sharing their experiences and sharing what they feel has worked for them. If we have community engagement, we can understand where there may be provider and patient misalignment, and so that we can reduce those barriers and improve trust. And it's the community really can help us understand what's best needed. And so principles of effective engagement is to meet women where they are, whether it's the community, workplace, the digital space, to co-create programs with community partners. So not just go into the community and say, this is what we're going to do for you, but to actually create a partnership of trust so that information is shared in a bilateral way. Next slide. In terms of community engagement, it is essential. We need to build shared understanding and reduce stigma, create a safe place for learning and support that's culturally sensitive and culturally aware, encourage the diverse voices and lived experiences, and really use that collective voice to strengthen our goals and move forward in terms of action. Strategies for engagement, again, is to host these workshops, support groups, and listening sessions. We need to listen first before we actually implement, before we act. We need to use social media to amplify stories and resources that are trusted and truly engage in community workers and peer educators to ensure that we're meeting the need of that specific population in that community. Next slide. Okay, so we've talked a bit about group-based centering models, but my question is, does it work for everyone? Should we have different models for different groups? That's why community engagement is so important. There may be opportunities to partner with employers, with faith-based organizations, but building trust is at the core. We need to be transparent, we need to be visible, and we need to sustain a presence, not just episodic engagement. That's based on when you're funded. Next slide. So knowledge gaps, research opportunities, and key recommendations. Next slide. So I have a list here, but really want to stress the evidence to practice gap. We have to build an evidence base that is inclusive, decision-informed, and scalable. We have to deliver clear, accessible, evidence-based information tailored to the community that we're serving. We need to treat advocacy just the way we treat other research, and that there should be rigor as well as clinical interventions. We need to shift from an outreach to a co-creation with rigorous evaluation and develop infrastructure that allows for continuous, scalable, and community integrated care. So with that, I'm going to say thank you for your attention, and we're going to move to the panel discussion.
So I'm just going to jump in just for a second. Dr. Neil Perry, thank you so much. And thank you for such an insightful session. Wow, thank you to all the speakers. So I'm going to invite all the panelists to feel free to turn their cameras on so that they can join Dr. Neil Perry for the discussion session. And as a reminder, we're going to first address questions from the independent panel before moving to address any of the questions that the audience has posed. And Dr. Neil Perry, just a reminder to view your chat box because we sent you some questions there for the discussion session. So I'll turn it back over to you.
All right, yeah. You know, each one of your talks really, really, really compelling. And, you know, there are a couple of things that came to my mind. And one of them was around wealth gaps and how I think it was Irene that was talking about the costs that individual women may spend for their care related to menopause. And I was curious as to whether there's any data that shows that the women who experience the perimenopause in a more severe fashion, whether there's more work loss in terms of wealth gaps, whether you're seeing any wealth gaps in that population.
In that particular study with UVA and Flow Health, no, and they didn't necessarily look at the wealth gaps, but there have been some studies that have been looking at the work life and economic impacts. And it's starting to take hold. I know there's some work that the Mayo Clinic has done and the not the Menopause Society, formerly NAMS, the work that they're doing as well to highlight the economic impacts.
Yeah, because one could imagine that if people are not able to go to work and they're paying more for care, that could actually move you into a completely different socioeconomic status.
Yes.
And you know, the importance of wealth for that individual as well as their family, you know, I can imagine that can be quite impactful.
If I can add as well, these years are often what are considered the sandwich generation years for caregiving, which poses challenges particularly to women who are 60% of informal caregivers, which has additional financial impacts of taking care of others, but then also the health impacts when we're going through navigating that perimenopause transition, having to make so many medical appointments or seeking care in a very unregimented way to manage your symptoms, but also having to do it for others that you're providing care for, that there's a fatigue and a potential for your health to also decline even more so than if you were just having to take care of yourself. It's already a challenge. And many women in this time frame of midlife are also caregiving. And so we have to also consider how that impacts their health and their wealth.
Yeah, thank you. Dr. Patel, I did have a question for you. And one of the things that you said was the value of CME and how it can actually help in terms of bridging that gap. And one of the things that I actually thought about was just the cost of CME, because my faculty also participate in CME, and the cost is not cheap. What are your thoughts about how do we bridge that, right? Because you're right, there is more education needed, but how do we increase that access in a way that it's not cost prohibitive?
So, yeah, thank you. So I think that actually within our system, for example, we don't use, we do offer a CME that we have locally that is at cost and discounted for our for the group of physicians at UCLA. But really the best way for this education to kind of percolate through the system is truly to invest in just simple things like noon conferences, morning lectures, dedicated sort of really small things that go a long way. So we spent a lot of time, all 6 of us, just going around to the different departments and giving them a grand rounds or giving them a small little tidbit of information. Meeting with our collaborators also gave us an opportunity to educate them as well as them educate us. So I just feel like it doesn't have to always be in such a formal environment. I think that's truly the best way to do this. And it's also within the work hours. So I really feel it's, to make people go outside of their time and spend their own dime to go do this, it's just a barrier. I think another way that we should really be, and this is not necessarily up to me, but I do think that incentivizing physicians for the CME that they have to do on a yearly basis, even through when we have to take our, every year we have to read a bunch of articles. It would be very nice to have more articles on menopause. And so I think like championing those kind of efforts. The other thing is a lot of people do go to conferences once a year. And so I think these conferences, these societies have to have, besides just the Menopause Society, there has to be more presence of menopause within other national conferences that people attend. And that doesn't have to be just the American College of OBGYN or the Menopause Society. It should be really throughout even some of these other disciplines, like endocrinology and sleep and internal medicine. And I just think that there needs to be more presence of this topic in general. I don't know if that helps to answer.
Yeah, and I think there's probably an opportunity for funded education programs that are then made that are available freely to the public, both providers as well as patients, because I think we do need a platform where it is just free and people can do it whenever it's convenient for them, right? Because this is really such an important topic, and in many ways, there's so much urgency that we need to kind of approach this in multiple ways in order to achieve this goal. Dr. Gunther, how do you strike a balance between accuracy and clarity when communicating nuanced information?
Yeah, so it can certainly be challenging because especially when you have a diverse audience, because there's some people who really want for example, when I write content, I have lots of MDs and PhDs who follow me and lots of people who are just looking for general information or information about menopause and everything in between. And so I think that we can take out the fancy terms. And I think that what we really also need to do is to encourage researchers to have sort of translatable sentences in their work. So for example, I'm writing today about a paper that uses hazard ratios, and it's a very that concept doesn't sort of translate very well to discussing it in the office and having a real world to be able to say, oh, there was a difference in 4 years. And so I think that we really need to, while that those of us who write a lot of content really do our best to try to strike the balance, that there are definitely some researchers that are including kind of real world applicable ways to describe their research. And I think that should actually be something that is a requirement in journals. also because we see sometimes an overstretching of what, you know, a paper might actually say. You know, what can a retrospective, you know, small cohort study actually tell us of 22 people? So I do think that that one thing that could also then be folded into grants is that, you know, any publication that comes from, you know, this federally funded, you know, menopause project, there has to actually be translatable ways to get that information to the public.
I think that's a really important point, right? We need to, again, that's part of the advocacy, that's part of the community engagement, is meeting people where they are and recognizing that, you know, while we have you know, this high level of understanding about menopause and what to expect and what's evidence-based and what's not, many people don't, right? We need to use the language that people understand. We need to use different vehicles, recognizing that people learn and you know, take in information in different ways. And so we need to be really innovative and thoughtful about how we share information and really try to empower our patients so that they can actually get what they need out of each one of us. Dr. Patel, for can you talk a little bit about your program? Some of, you know, right now it sounds like, oh my God, it's wonderful, but I'm sure there were some challenges that you encountered along the way. And so it would be great if you could help all of us and share, like, you know, if you could do it all over again, what wouldn't you do?
Well, I mean, number one, this program was built with no money or anything. It was purely just a passion project of mine that really it was a lot. It's not possible, and no one should have to reinvent the wheel. And in fact, we're writing a paper right now that's outlining a blueprint around how to create a menopause program, because no one needs to reinvent this wheel. I think the hardest part was really proving to the university the business case around doing this, because people were like, you're just going to lose money. This is not a moneymaker. We don't need to do this. And the only thing that spoke to them was the fact that we were going to have research-ready data, and that they were willing to kind of allow me to create this program because they knew that research was going to come out of this, which it definitely is. But I think that it was really hard, you know, because most of the people just didn't feel the value of providing this kind of care and the system, creating a system for it. But I think that if I had to do it all over again, number one, I wish I had money. Number two, I wish you know, even now we're doing this all without even dedicated coordinators. It's just using within the resources of our department, which is now the value has been shown, and, you know, everybody's behind this effort across the UC system at this point. But I wish I had more support. I feel like we, you know, just the administrative support to do this would make things a lot easier from the get-go. I think this organically became what it was in regards to the tools that I created and all this stuff. But now looking back, like, this is why I don't want anybody to reinvent the wheel. Like, I know what's needed. We need these tools in the way that I sort of outlined. And I'm more curious now as to see how this translates in other systems, and to see if this actually is successful in other contexts even within the UC system, but then even beyond that. So I don't have a clear answer, because I did it all sort of one step at a time, and just not letting no be the answer, kind of moving around and finding my cheerleaders and my champions to kind of help me. I will say the one thing that made this very successful is that I was able to find leaders in every single department, whether it's sleep or mental health or bone endocrinology or cardiology, to really band together with me and say, yes, we care about this population and we want to work to make a better workflow.
Yeah, that's great. Actually, one of my had a big question mark was funding. So I'm glad you brought that up, because you're right, as in a healthcare system, they're looking at, you know, can we afford to do this? And being able to show that actually it is self-sustaining. Once, you know, the biggest investment is just that uplift, that upfit for the program, but once sustained, once implemented, it is self-sustaining.
Yeah.
The other thing is people are thinking about this, and I'm glad you brought up the research component, is that this is very much a wonderful way to integrate research into your care, as well as building out programs that are community focused, because your community of patients can help you understand where their where their perceived gaps are. And it's just a really organic way of just really providing comprehensive, thoughtful, evidence-based care. So thank you for that.
Yeah. I was going to just mention that the business case model, it does, I will say the reason why it's sustainable, and we outline this in the paper, but really what makes it sustainable is the downstream revenue, and then the focus on all of the prevention, which you can't see that right away, but the goal is to show that, we have less chronic disease over time because we're kind of addressing this multi-system.
Right. And as we think about value-based care, this is one of the ways that you get there, right? You help educate patients, you ensure that they have access to care before their systems are really advanced and they cost more to the healthcare system in terms of whether it's a disease process, whether it's quality of care related issues, right? Because if someone doesn't have good quality of care, guess what? They're going to utilize the healthcare system more frequently, right? So if they're not getting their questions answered, they don't understand. Instead of coming once or twice, they're going to come 10 times. And so there's a cost to that.
That's exactly right. They need a solution that's kind of at the end of 30 minutes, they have a care plan that makes sense instead of going down rabbit holes with different specialists.
I know I've asked questions. I want to make sure our panelists don't have questions for each other, but I have lots of questions, so that's never a problem for me.
Well, I just wanted to add in, what Dr. Patel brought up about, having to make the business case and so how hard it is, which again reflects the endemic misogyny that's built into the American and actually Canadian healthcare system as well. That when primary care and gynecological care are undervalued and under reimbursed, when office-based care is under reimbursed, it doesn't get taught because, there's less people who want to teach it. It doesn't get, support from institutions. It becomes a money loser, a loss leader. People don't want to do that. And it's really, so as we sort of change all these narratives, I think it's also really important that we also have pressure at a governmental level to sort of fix the funding inequalities, because, when things are reimbursed highly, there is a greater interest, and that's just a sad truth that we have to accept. But the fact that that women's health is uniquely disadvantaged by the funding model, and so that just becomes harder and harder to make a case. So it's amazing that you guys were able to do that.
Yeah, and you mentioned something, Jen, that I want to elevate, and that is policies. And when we think about providing care, insurance mandates is very much a part of this, right? At no point in time should a woman have to use 3 different non-FDA approved treatments before they actually have access to care. But this is what's happening to women who are seeking care, or they don't have access to transdermal estrogen when we know it works well. And for some women, that's actually a much better approach, but they have to try these other interventions before they can actually have access to care that we know is FDA approved. Irene, did you have a comment? I thought you were.
I did. As we talk about the insurance, and one of the pieces that I had touched on is the working with your provider. And maybe Dr. Patil, if you can speak to what would you recommend for smaller offices, medical offices, to do that paperwork load? Because I think there's also that when a patient's trying to navigate, they need the assistance of their provider. And so how can they work together to manage that paperwork load to get through the insurance coverage that they may need that might be behind certain walls?
I mean, to be honest, whether you're small or big, even like UCLA, this is a humongous problem because our back office spends on average 2 to 5 hours on prior auths for each person for things that we want to offer them, because not everybody wants hormone therapy. They might want neurokinin antagonists. They may not be able to use hormone therapy, or they frankly don't want to use it. And it is us fighting. It is every single drug like that is so much time and resources. And so, to be honest, the way that I'm advocating to like change this is at the state level, because we have been trying to get this bill approved to mandate full equal coverage for all FDA approved medications. And not have to go down, I'll give a good example. I mean, we have patients that are 80 years old that want to use S-string, right? Instead of having to place something twice a week in the vagina. And they physically cannot put those medications in their vagina twice a week, but we cannot get S-string covered. And so the insurance companies will tell us, well, you need to use these 2 vaginal products before you can get S-string covered, all of which are FDA approved and equal. And so it's those kind of ridiculous things that we're working against. And that doesn't matter if you're a small office or a big office, because the same paperwork has to be done and dealt with. And I don't really have this great answer, because one of the things I do is I really tell all the physicians, please bold and highlight every single reason why this medication is first line. And I will tell you that does help in regards to getting less hours needed for getting that approved. I don't really have another answer other than we have to change the policies around these kind of things at a higher level. I don't know if specifically you're talking only about medications, but that's the biggest thing that we spend our time on.
Hi, Dr. Neil Perry. I'm just going to jump in here. We have our independent panel as well that they have a couple of questions that they'd like to pose to the speakers. So if we could allow them to ask their questions as well.
Please.
I think Dr. Elizabeth Vasquez, she has a question, and also Dr. Teresa Walones.
I'll go first. Thank you. This is so exciting and so lively. And my question I put on the chat that is thinking about a lot of the solutions you have posed are solutions that can be implemented at the urban setting, like in an urban hospital, but in states where you have such a large rural communities. So I'm curious as to how you thought about it, because that's another group that usually may even have a digital divide. So I'm just curious to how do you see this? This can be aspirational, but how do we see us capturing those women that live in more rural settings?
Yeah, if I can answer some of that, and Regina, if you have some comments, appreciate it. Telemedicine is actually a great vehicle, and it is while it wasn't a big aspect of care before COVID, but I have to tell you, it has helped to break down barriers in a significant way. I think it was Regina who spoke about the centered care around menopause. You can actually use telemedicine to do that. And so you could create something that we've been talking about here at UNC, like a hub and spokes model, where you have your center where people, your providers have access to information, they're trained, and then they can actually deliver care where patients are, or you can use telemedicine to do that. So I think telemedicine has been a game changer, and it really has broken down some barriers. Now, there's just some care that you need to have in person, but a lot of the conversations around education and helping people understand what it is that they can expect to experience and what they need, I think can be done effectively with telemedicine. Regina, or...
Yeah, I completely agree. That would have been my number one first thing, is that really the concept that, in California, for example, we do see people from all over the state. Now, there is a digital divide. So there's that issue. And I think that's where telemedicine doesn't necessarily work. But part of it is outreach efforts. first of all. And I think that requires money and funding. You need some money to be able to go out there and really get into the communities. I think one of the things that I've always thought about is that if we had a good money to kind of expand our program a little bit more, I would love to have a community, like part of a board, like a community, like an advisory board where we have community members and patients to kind of help us with figuring out, like, okay, how do we get out there into the rural areas and really reach those patients, and what do they need? We need translation services. Like, what do we need to kind of get them engaged and get into a hub, whether that's UCLA or hopefully in the future UCSF, UCI, UCSD, all of these other hubs that we're hoping to develop, so that everybody in California can get that access. And I hope that's a model that can prove to be, possible in other parts of the country as well. But I do think telemedicine has really changed the world, and most of what we do in menopause care does not require an in-person visit.
And the other thing that we've talked about are patient navigators. Patient navigators are often used in the oncology setting because care is complex, and just helping patients navigate what they need to do, what's next. We've also talked about the idea of having patient navigators for menopausal women, so that they are actually directed to the places they need to go based on what their concerns are. And so that's another way to break down barriers, to have individuals who are kind of nested in different communities that can help patients navigate healthcare systems so that they get the care that they need. Other thoughts?
There have been the implementation of group interventions and mobile health. So I think in regions where you necessarily might be urban or some deserts, when you have the opportunity taking it to those communities in the outskirts, I know it means it's only spot treatment, but sometimes it's better than if that's a placeholder for the next 3 months for them to be able to get out to an appointment. It can be very effective. And then using that opportunity to do some peer support or group interventions to be able to get a larger volume of information out to more individuals in a shorter amount of time.
Keisha, were there other questions?
Yes, Dr. Walunas, I think she has a question. I think that she may have posted in the chat. Hold on, let me just read it out.
I didn't see
Okay.
it.
She said, Dr. Patel, I love what you are doing at UCLA. Yesterday, when we discussed the use of real-world data for research, there was some skepticism of its quality. However, you are using it for clinical decision support. Could you discuss what data you trust for this and what you would like to be better?
So number one, the research, the data we have is actually not based on for research specifically, right? We're doing it to give clinical care in an evidence-based manner. So the research, the data that's coming out of it is purely from all of the data collected in order to do so. So I'm not exactly clear what the question is, but the data that at least we have is I feel good data, because we're providing it with evidence-based guidelines and practiced and guidelines that are or frameworks that are have come together because of our collaborating specialists as well as our expertise. But I think that one thing that's missing, I think, is that, like, right now it just depends on, the data is really on who comes and sees us. And I think that there is a lot of probably missing populations, even though we're in an urban setting. We are still, not, I think the outreach to some of these to get some of the more marginalized populations are probably still missing. And we still have to do a lot of work. And I guess, yeah, I think that would be one thing. I'm not exactly sure otherwise if we're what the question was asking otherwise.
But I do think it's a start, right?
Yeah.
Kind of building that infrastructure is so important. building an infrastructure that's sustainable. And when you have that infrastructure, you can really think about how you approach questions, how you design your studies, so that you can actually be inclusive, and to allow you to also think about who's not included, and think about how to actually include individuals. So I see it as an opportunity to build up, as an opportunity to really think about, how do we create an environment where this work can happen, and it can happen in a way so that we're also kind of leading the way in terms of evidence-based medicine and designing thoughtful, meaningful projects that involves community.
Yeah, I think it provides an inherent framework of just there in itself, just with the amount of data collected, and it makes us consider all these questions that are already starting to happen within our group now that we've been live for about 3 years. And the good thing about the way that this is happening organically is that because we've enlisted our lead women's cardiologist, our lead, sleep specialist, they feel very invested. They're part of our team, and so they are asking questions. Now let's do this research project together. Let's recruit for this specific prospective study. So I think it's just starting to get like a lot of traction across UCLA and even beyond, especially as we go into the other UCs. I think now we can cross-collaborate our data. We can have data dashboards. We can figure out, even from like how far are we reaching the California people? I think it will help us show disparities. It will help us think of questions, collaborate together. There's endless possibilities.
Yeah, and the other thing is you're not looking retrospectively, right? You're not trying to pull data out. You can actually collect data. You can have, the questions where patients are filling out things or in real time. So it's really a different platform in terms of how you can design research and really collect meaningful information. So really, really appreciate this panel. I learned so much from each one of you today. As a menopausal woman, this is not just a research area. This is very personal. And I want to say thank you for your commitment and for really the delivery of such meaningful information. So thank you.
Thank you. Round of applause for this panel. Thank you so much for Dr. Neil Perry and your moderating it. Thank you all for a rich and engaging discussions. We're now going to turn to key question 2B, which focuses on the impact of system-level factors, including access to care, provider bias, and social determinants of health on the receipt of treatment. Our first presentation will be by Dr. Andrea LaCroix on system-level changes affecting the menopause experience and quality of care. Welcome, Dr. LaCroix.
Thank you so much, Keisha, and thanks for letting me have a go at changing the slides. I think this is the wrong question for this session. Can you just clarify that, Keisha? It looked like, because we're focused on system level factors in this session, and this is the first of our talks. We're peeling a basket of onions, and you'll see some of the same layers coming off in here as well. But I would say that another simple title for this talk might be The World We Live In. I have no industry relationships to disclose. I will disclose that I've worked on the Women's Health Initiative for over 32 years. I was one of the PIs in the MIS-FLASH Clinical Trials Network. The My Menoplan website that came out of the MIS-FLASH and other evidence-based sources I worked on with many of you, and we hosted at UCSD. And I also was so delighted to hear Dr. Goff mention our 2 studies on physical activity, sedentary behavior, and healthy cardiovascular aging, OPATCH and WISH, and we are constantly publishing from those studies new information about physical activity in aging women. I want to express my gratitude to so many colleagues who've spoken at this conference and compliment you for really bringing forward so much that we've learned. The first point here is that NIH has invested heavily already and over the long term in menopause research, as evidenced by all the studies we've been talking about today. I list here Swan and Miss Flash, but there's so many that you've brought to the fore. Thank you for your work on these studies. Thank you for summarizing them so well. And let us not forget that this is the new starting point, that we've learned a lot. So why is it that we continue to swim in an ocean of ignorance, even though we've learned all this? That's something I want to explore in this short talk. Much has been learned about the natural history of menopause, a whole host of associated midlife symptoms, and the efficacy of various treatments. And yet structural systemic barriers have kept this knowledge from realizing its full potential in improving midlife women's health. Let's peel that back a bit and first consider that we have this nice diagram from a recent paper showing the social health context of the menopause experience and at different levels. And we tend to be focused on the demographic factors at the center here, which are largely non-modifiable, although you could certainly argue about this, and then modifiable lifestyle factors, and then these semi-modifiable outer rings, which really reflect the world we live in. And I'm going to focus in particular, I definitely recommend ruminating on this picture if you have time later, or reading the paper, because it really puts in context all of the things that we've been talking about. Deeply embedded societal perspectives. So we heard Dr. Gunter say in the last session the words systemic or embedded, deeply embedded misogyny. That is one way to phrase what I'm getting at here. But it's basically the devaluing of post-reproductive women systematically. This is a happy hour talk. You have your own experience of this, as do we all. It is starting to be recognized, I think, that the situation that we're in, death by 1,000 cuts to menopausal women, is because of our biases against women growing older, women becoming post-reproductive, and all the jokes that are made, etc. So in this article, a journalist was reflecting on her role in making some of these jokes. You know, woman with head in the refrigerator, woman with steam coming out of her ears. You know, I loved hearing that menopause is not a disease, because, you know, the more we talk about how awful it is and how many people are suffering, which is certainly some truth, the more we forget to mention that women get through this. They don't die of menopause for the most part. And we have tremendous strength, even though we go through these hardships. So I feel like that's a double-edged sword. But I think this is the overarching ring, if you will, that is affecting the work that we do. So I wanted to raise the voice of women in this discussion to get their overall input. And I found this systematic literature review, which summarizes 21 qualitative studies about the menopause experience. So let's see what women say about the barriers that they experience to the safe discussion of the experience and management of menopause symptoms. What they say is they have 6 areas of thematic relevance to this question. They say that they lack support from friends and family. This includes partners, husbands, mothers, the whole gamut, their kids. I remember taking a walk with a dear friend in midlife, going through the menopause transition at the time. She and her husband are very highly educated professionals, and her husband said to her, "You told me you were going through menopause. It's been 3 months. When is this going to be over?" And, you know, that's a reflection of the sea of ignorance that we're in. Lack of workplace support, fear of menopause onset because of the stigma that it brings. I saw a comment in the chat foreshadowing this entire talk. So thank you for bringing forward those barriers, which we'll be talking about. Variation in the symptom experience has been discussed a bunch at this workshop. Sometimes women have symptoms and they don't attribute them to menopause. There are also ethnic and cultural differences, which my colleague will speak about in a couple of talks from now. There is a lot of poor quality information around, misinformation, lack of culturally relevant resources. These are all things that women mentioned in these qualitative studies. And then there's the societal judgment about being in menopause. So these are the voices of women telling us what they perceive to be the barriers. And I want to focus in particular on a couple of aspects in the rings here that pertain to education and health literacy, which have already been mentioned. But just to put a fine point on this, what are the gaps in the educational system? Why is it that Dr. Stunkel says that women reach midlife and need to have this talk because they don't know about menopause, they don't know what's happening to them? Are we to go through our entire life in ignorance and then suddenly, when we're in the middle of that experience, come to understand something about menopause? My students and I have identified that teaching the facts about menopause and learning about the menopause experience should really start in middle school at the latest, when you learn about what it means to have puberty and what it means to be reproductive. We should also be learning about menopause. And you can imagine the value of, at that time, of talking to the women in your life, your mom, your aunts, whoever is in that stage of life, about their menopause experience, so that it becomes normalized, so that you have this open conversation with somebody you love who's going through this and you can support them better. And so that you go through your entire life being able to understand this phase of life and support the people in it. And this goes for girls, it goes for boys, it goes for everybody. So inadequate access to evidence-based information about menopause and treatment options produced without commercial or political bias. So this is a big gap, and it's already been mentioned in the previous session. We need to have reliable digital resources. We need to have a way for people trying to learn about menopause to be able to separate what's true from what's not so true. And that is the third box. We developed My Meno Plan not as a perfect resource, but as a starting point, as a demonstration that it is possible without commercial or political bias to at least try to present the most relevant information that women may want to know about, and to process it in the context of their own values, their own priorities, and their own symptoms. So I'm hoping one day that there will be beautiful digital materials without commercial or political bias that women can trust and use, and not have to wait for the talk when they reach menopause. I want to go back to something that Nanette Santoro said on the very first day, which is that we have an overemphasis on hormone therapy in this whole area. And I would argue that that constant arguing about hormone therapy, constant controversies, constant, dismissing of clinical trial evidence across the board is holding back the field. It's holding back good clinical practice and the ability of women to make informed decisions. What you see on the right is a very reasonable translation of the cumulative evidence by the American Heart Association about menopausal hormone therapy, who would be at low risk to take hormone therapy, who would be at intermediate risk, and who would be at high risk. And this is a very reasonable translation. I did not work on this. This is not my product, but I think it's a good product. And what it shows is that that total dismissal of all the evidence is not necessary, that you can translate this evidence and that women can use tools like this to understand who can very easily take hormone therapy without worrying about risk and where the risks start to climb. But the main thing, just to say it again, is we need to have women understand that they have more than this option. So when I hear the summation, which has been really common over the last many months, the WHI was misunderstood or just plain wrong, and it's okay for you to take hormone therapy if you're in the menopause transition, and it's safe and it's the most effective. That is what I'm hearing on Oprah. That's what I'm hearing on the morning news, and I think that that kind of summary keeps women from understanding all of the options that they have and where they are in this sort of personalized choice realm. This comes from a study Dr. Stunkel participated in. It was a survey of the way that physicians were practicing. They mailed out close to 800 surveys, and they got back somewhere in the 180s. And this is posing clinical scenarios to physicians and asking them to say what they would do in those scenarios. So this scenario shows what the survey said about the treatment approach to vasomotor symptoms that recur after hormone therapy discontinuation for any reason. That was the scenario. And what you can see here is that if a woman has recurring symptoms, the most common thing, there's not really a lot of counseling about the alternative therapies for managing menopause symptoms. The most common thing for women to be told is that they should change their behavior, increase their exercise, and lose weight. I can only imagine how wonderful it feels for the woman sitting in front of that doctor to hear that she should exercise more and lose weight to manage her menopause symptoms. I think that might be perceived as, yet again, putting the burden on me for my menopause symptoms. It's not enough help. And we now know there's actually a decent body of evidence that losing weight does reduce the burden of vasomotor symptoms, and that many women would like to lose weight. We've also heard at this workshop how easy it is to gain weight in the menopause transition and how hard it is to lose it. Dr. Jaffe talked about that yesterday. So when you say that to a woman who's been trying to lose weight and has trouble doing it, and who's bothered by her expanding waist and the fact that she's heavier than she wants to be, it's got to be pretty discouraging. I would say that it's low-hanging fruit. I do think it's an evidence-based recommendation, but I would say that one of the low-hanging fruits before us now is that women in the midlife are more and more turning to GLP-1s. There's a growing evidence base about how GLP-1s affect midlife women's health with respect to cardiovascular risk factors. There's one recent paper from the Miami Mayo Clinic suggesting that hormone therapy interacts with one of the GLP-1s to improve weight loss. What I don't see coming out of this literature yet is how does this improve menopause symptoms? So if you lose weight with a GLP-1, do your menopause symptoms improve? That's something we need to know that would be easy to find out. And I just want to draw your attention to the many things that could be talked about, especially SSRIs and SNRIs, which have been studied, and just a host of other things that might be talked about. I think it's too much to ask doctors to talk about all this, and therefore these reliable digital resources are super important. This is to make the point that the way we counsel women about the amount of relief from vasomotor symptoms and the amount of improvement in quality of life falls far short of reality. So this slide comes from the data that was presented by the Institute for Clinical and Economic Review, which came out with a report after the fezolinetant registration trials were published. And they asked myself and Chris Enzer to write an editorial about that report. And what they did was they summarized the evidence at that point in time from randomized trials from a great many different kinds of menopause treatments. And so what this shows is that the change in vasomotor symptom frequency for the two fezolinetant doses on the left Misflash-03, which was low dose estradiol, and Misflash-01, which was escitalopram. And these are number of hot flashes per day that are being reduced. They thought that, you know, in the context of clinical trials where the average number of vasomotor symptoms is something like 10, which Dr. Pinkerton showed us from one of these trials, you know, they thought that the minimal clinically important difference would be a decline in 3.5 hot flashes per day on average compared to placebo. And none of these interventions met that mark. You can talk about this slide in a number of ways. I don't think that with respect to number of vasomotor symptoms, that women would agree that the difference between low-dose estradiol and fezolinetant is clinically important to them. We're talking about a quarter of a hot flash on average. Escitalopram was a little less effective, but again, it almost made it to 1.5. So we're talking about the difference of 1.5 to 2.5, one hot flash a day. We don't talk to women about, in any kind of quantitative way, about the relief they can expect from these therapies and how they can compare across the trials. We just say this is safe and it's the best. And I think we women are very capable of understanding on a deeper level the comparative effectiveness of these agents. I also want to make the point that they were able to make these comparisons in a rigorous way without doing one trial that had all these agents in them. So from the comparative effectiveness point of view, if we standardize a minimum data set in randomized trials for treatments for menopause symptoms, we will have the ability to compare treatment effects, acknowledging population differences and things like that. We're never going to have a perfect evidence base for everybody, but we still need to be honest and straightforward when we talk to women about the relief they can expect. When it comes to VMS severity, arguably there was a tiny benefit greater for low-dose estradiol. But you know, look, the severity data show a lot of equivalence, and so do the Menopause scores for these agents, almost identical improvements in quality of life. And I think this enables women to say, okay, I'm going to look at lots of things that are important to me, knowing this information. 2 minutes remaining. Thank you. Just to make a few more points. The cost of menopause care is prohibitive for many. This comes from a very recent survey of 1,500 women in the United States in the perimenopause or menopause. You can see that many women are paying for menopause treatments with their insurance, but a good portion of them do not have full insurance coverage for menopause prescriptions. That's a quarter of them. 12% have had to cut back on essentials to afford care, and 21% have skipped treatment due to financial concerns. So this is particularly inequitable for the newer agents, and I'm a big fan of the fact that we have newer agents and that this is another choice for women. But if it's going to cost them $6,000 a year, it really cuts out a huge proportion of the population. Cost is an important structural barrier. So I was asked to comment on menopause evidence measurement and reporting challenges. I want to mention that industry-funded trials often use measurement tools and devices that are difficult to directly compare to trials of alternative treatments funded by the government. They have more resources than we do, and this makes direct comparisons more difficult than they need to be. The reporting of key trial metrics such as retention rates and the amount of missing outcome data or loss to follow-up can be deliberately obfuscated in publications, which it definitely was for fezolinetant. And this makes the outcomes of those trials look better than they really are. As the menu of effective alternative grows, it is key to be able to compare outcomes of the various treatments without doing de novo comparative effectiveness trials. And the inclusion of women representing the whole population of affected women is very important. Wrapping up here, this is just a nod to my institution, UC San Diego. They are at the moment giving us a menopause series. So I've never seen this in a workplace that I was at before. So you go UC San Diego. We have a workplace program, and we've heard a lot about the importance of workplace programs. I want to go into the knowledge gaps. Menopause lies at the intersection of aging and women's health and is stigmatized at the societal level worldwide to various degrees. There's too little education about this universal life cycle experience built into our educational structures from middle school to medical school. A large number of efficacious strategies exist to improve symptoms, but women lack trusted, reliable sources. There's, Keisha, just a couple things. Communication too often centers on use of a single treatment option, hormone therapy, and direct comparisons among treatments are hindered by a lack of standard measurements and transparent reporting. I will skip the next slide, which is bringing this together in the empowerment model, because we heard about that in the last talk, but I was privileged to work with Dr. Hickey on this paper, as were several of you. And I think this really does bring together the area that we're talking about. And I'm just going to end with this, Keisha, and then I'll be quiet. Identify effective strategies to reduce menopause and aging stigma is a recommendation. Design and evaluate modern educational programs at all levels. Reduce misinformation by providing unbiased, current, reliable digital resources for women and healthcare practitioners. Provide comparative effectiveness information using the data that we have on available treatments in understandable language. Conduct new long-term observational studies, we haven't heard this, that I've heard, of midlife women focused on contemporary medications to manage menopause symptoms, to learn more about their needs, choices, and the long-term benefits and risks from real-world data. Design and test new interventions using a minimum data set of outcome measures to facilitate direct comparisons, and insist on transparent reporting and trial reports, and develop multi-level interventions that test strategies to reduce the structural barriers that are impacting us in the effective management of symptoms common in the menopause transition. Those are my recommendations. And thank you so much. I just end with this quote from Vivian Pinn, who's been a leader of us all and an inspiration. Women and healthcare providers need trustworthy information in order to make responsible, informed decisions regarding health and well-being. And that is why we were here today. Thank you, Keisha.
Thank you. Thank you, Dr. LaCroix. Round of applause for Dr. LaCroix. Okay, so next we have, we're going to hear regulatory perspectives, opportunities, and considerations from Dr. Janet Maynard. Dr. Maynard, you may begin.
Thanks so much, Lisa. And I just want to say a huge thank you to the organizers for putting on this workshop, and also a huge thank you to everyone who is joining virtually. It has been wonderful to see the engagement, all the different reactions and the chats and the questions. It's been great. So thank you so much. So I am the director of the Office of Rare Diseases, Pediatric, Urologic, and Reproductive Medicine at the FDA and the Center for Drug Evaluation and Research, which we also call CDER. And I will be talking about regulatory perspectives, opportunities, and considerations. So I have no information to disclose. So for my talk today, we will go over the regulatory framework for drug approval and then talk about some mechanisms available to facilitate drug development. We'll then transition to labeling considerations, which are relevant given recent updates to menopausal hormone therapy product labeling. We'll then end with opportunities to support research and collaboration, which I think are really critical as we advance menopausal care. So I work in the Center for Drug Evaluation and Research, or CDER, within the FDA. And CDER performs an essential public health task by making sure safe and effective drugs are available to improve the health of people within the United States. Today, I'll be focusing on considerations related to prescription drugs. It's important to consider the regulatory framework within which drugs are approved. To be approved for marketing, a drug must be safe and effective for its intended use. In terms of efficacy, there must be substantial evidence consisting of adequate and well-controlled investigations that the drug product will have the effect it purports or is represented to have under the proposed labeled conditions of use. And importantly, a drug's effect must be clinically meaningful to patients. In terms of safety, it's not explicitly defined in the regulations governing approval. Recognizing that all drugs have some ability to cause adverse effects, The safety of a drug is assessed by determining whether the benefits outweigh its risk. Safety is considered in relationship to the condition that's being treated, the efficacy purported, and the ability to mitigate that risk. So this meeting is focused on advancing research to improve health during the menopausal transition. And clearly the availability of safe and effective drugs is critical to the health of women, including to treat the symptoms of menopause. At FDA, we really are dedicated to advancing the development, review, and approval of safe and effective products to treat menopausal symptoms. For drug approval, the data must support that the benefits of the drug outweigh the risks. Benefit can be assessed by whether the product has a positive impact on how a patient feels, functions, or survives. Being able to describe the clinical benefit is essential to make a decision about the favorability of the benefit-risk profile of the specific product. Benefit risk assessment considers the extensive evidence of safety and effectiveness submitted by a sponsor in an application, as well as other factors, including the nature and severity of the condition the drug is intended to treat, the benefits and the risks of other therapies for the same condition, and if there's any ways that we can manage the risk associated with the drug. Benefit risk assessment is FDA's regulatory way of making an informed decision about whether the benefits with any of their uncertainties of the drug outweigh the risk with any of their uncertainties and abilities to manage those risks under the conditions of use described in the labeling. So clinical studies provide important information on the safety and efficacy of a drug. Clinical studies at different phases of development have different goals. So phase 1 studies represent the earliest phase of drug development and include the first time a drug is studied in humans. Phase 2 studies focus on dose ranging assessment and may provide additional or initial evidence related to efficacy. Phase 3 studies are the pivotal studies that provide the efficacy and safety data needed to evaluate the overall benefit risk profile of a drug. And then phase 4 studies are post-marketing studies that are conducted after drug approval. So FDA is dedicated to advancing the development of safe and effective products to treat menopausal symptoms. And as we've heard throughout this workshop, menopausal symptoms can really have a significant burden on women and adversely impact quality of life. While they are not life-limiting, it is clear that they profoundly impact women and their families. Current treatment options focus on vasomotor symptoms and vulvovaginal atrophy, which is also referred to as genitourinary syndrome of menopause. As we've heard, FDA has approved numerous safe and effective hormone therapy products, both estrogen alone and estrogen plus progestogen. These products have been approved for vasomotor symptoms, vulvovaginal atrophy, and osteoporosis. They're available in multiple formulations and routes, such as oral pills, transdermal patches, topical creams and sprays, and vaginal products such as vaginal rings. They're also available in a range of doses. And I think this is important because there are many personal considerations that might influence a woman's choice to utilize a specific product. It's also important to note that women might combine different products, so there can be complexity in clinical decisions, which is an important factor as we think about developing and researching these products. As Dr. LaCroix just mentioned, it's also important to highlight other non-hormonal therapy options, and FDA has approved 3 non-hormonal products for the treatment of moderate to severe VMS. So now we'll transition to some of the mechanisms utilized to facilitate drug development broadly. The first mechanism is meetings. Meetings between a drug sponsor and the agency are frequently used to resolve questions and issues that arise during clinical development. FDA encourages such meetings to the extent that they aid in the development of the drug and help resolve scientific challenges during development. The second mechanism is guidance documents. FDA's guidance documents explain the agency's interpretation of or policy on a regulatory issue. The FDA prepares guidance documents for industry, its own staff, and the public. FDA uses these guidance documents to explain the agency's thinking on a variety of topics, such as recommendations on clinical trial design, to assess safety and efficacy for a specific indication. Guidance documents are not roadmaps, but they can offer helpful information to facilitate drug development. The third mechanism that I really want to emphasize is incorporation of patient voice. The incorporation of patient voice is important throughout drug development and decision-making. For example, patient input can help identify and measures for outcomes and burdens that matter most to patients. I want to express my sincere appreciation to the women who've provided their personal experiences throughout this workshop, and to say that's sort of helpful as we think about incorporating patient voice. In addition, patient input facilitates designing better clinical trials, recruiting potential patients, and retaining study participants. Patient voice can be integrated into patient-reported outcomes and patient preference information and can add to the benefit-risk assessment. Patient voice supports communication between patients and providers to make sure that there is informed decision-making. And the fourth mechanism I wanted to mention is expedited programs. And FDA does have specific programs that help facilitate and expedite the development and review of new drugs to address unmet needs in the treatment of serious or life-threatening conditions. So as we've talked about, clinical trials really have a crucial base of evidence for evaluating whether a medical product is safe and effective. So in addition to some of the strategies we've just discussed on how to facilitate drug development, such as the importance of patient input in drug development, we are utilizing strategies to facilitate innovation in clinical trials, which promotes efficiency in drug development. Use of innovation includes innovative trial designs, such as using decentralized trials, and innovative design analyses and assessments. For example, digital health technologies may make it easier to enroll in clinical trials, and FDA has issued guidance documents to assist in the use of innovation in clinical trials. I also wanted to mention that CDER's Center for Clinical Trial and Innovation, or C3TI, which is a hub to improve the efficiency of drug development through innovation in clinical trials. So we'll now transition to considerations related to labeling, which I thought was relevant given the FDA's recent updates to the menopausal hormone therapy labeling. So labeling for prescription drugs is FDA's primary tool for communicating drug information to healthcare professionals and patients and their caregivers. Labeling for prescription medications includes the prescribing information, carton and container labeling, which is the outside packaging that is on prescription medicines, and labeling specifically for patients or caregivers, such as medication guides, patient package inserts, and instructions for use. Labeling for prescription medicines is required for all FDA-approved prescription medicines. Such labeling is proposed by the drug company, then reviewed by FDA, and if it's found to be acceptable, it's approved by the FDA. If the labeling for a new medicine is found to be unacceptable by the FDA, the medicine would not be approved by the FDA. So prescription drug labeling contains specific information in a specific order. We're going to focus on FDA's recent changes to the menopausal hormone therapy labeling, and thus I'll focus on considerations related to box warnings and warnings and precautions. A box warning is ordinarily used to highlight for prescribers that there is an adverse reaction so serious in proportion to the potential benefit from the drug, such as a fatal or life-threatening adverse reaction, that it's essential that it be considered in assessing the risks and the benefits of that drug. Or there's a serious adverse reaction that can be prevented or reduced in frequency or severity by appropriate use of the drug, such as appropriate patient selection, careful monitoring, or avoiding certain concomitant therapy. Or an FDA-approved drug with restrictions to ensure safe use because FDA concluded that the drug can only be safely used if distribution or use is restricted. If there's a box warning, the details are included in other sections of the labeling, including the warnings and precautions or the contraindications section. The warnings and precautions sections describes clinically significant adverse reactions, including those that are potentially fatal, are serious even if they're infrequent, or can be prevented or mitigated through appropriate use of the drug, other potential safety hazards, including those that are seen in the pharmacological class or those that might result from drug-drug interactions, limitations in use imposed by them, and steps that should be taken if they occur, such as dose modification. The warnings and precautions sections provide details regarding these adverse reactions, such as information on their frequency. Drug labeling is revised when there are changes in the information available, such as modification to add new information if a new safety risk is identified. With this background, we'll transition to recent changes to menopausal hormone therapy labeling. So in November 2025, FDA requested labeling changes to better clarify the benefit risk considerations for menopausal hormone therapies. These proposed changes were following a comprehensive review of scientific literature, an expert panel in July 2025, updated drug utilization review, and public input about menopausal hormone therapies. The changes apply to all menopausal hormone therapies, including and local vaginal products. The changes include the removal of risk statements about cardiovascular diseases, breast cancer, and probable dementia from the box warning, the agency's most prominent safety-related warning. For all menopausal hormone therapies, specific changes in the box warning include removing the language related to cardiovascular diseases, breast cancer, and probable dementia, removing language related to endometrial cancer, except in the systemic estrogen alone drugs, and removing the recommendation to use the lowest effective dose for the shortest amount of time. Also, in the labeling as a whole, the changes included removing the probable dementia warning. For systemic products, additional labeling changes include adding consideration of starting hormone therapy for moderate to severe VMS in women less than 60 years old or less than 10 years since menopause, adding data from the Women's Health Initiative in women 50 to 59 years old, retaining the box warning about endometrial cancer in the systemic estrogen alone products, as FDA is not seeking to remove the box warning for endometrial cancer for these products, and retaining information about cardiovascular disease and breast cancer in the warnings and precautions section. For local vaginal estrogen products, we condense safety information and prioritize information most relevant to the local vaginal formulation. At FDA's request, drug companies have submitted these proposed changes. In February 2026, FDA approved labeling changes for the first batch of 6 products. These products are from each of the 4 categories of menopausal hormone therapy, including systemic combination therapy of estrogen and progestogens, systemic estrogen alone therapy, progestogen alone, and topical vaginal estrogen therapy. I wanted to highlight that on Thursday, April 23rd, 2026, FDA will hold a Grand Rounds webinar presented by the Office of Women's Health on the rationale for FDA's request to update the menopausal hormone therapy labeling and to describe the labeling changes in each of the 4 product categories. This webinar will be an opportunity to hear more detail about the recent changes and the considerations for these. And I'd be happy to put that information in the chat after my talk. So now we're going to transition to considerations related to supporting research and collaboration. So regulatory science is a field of scientific research focused on developing the tools, standards, and approaches needed to generate the data and information on which FDA assesses safety, efficacy, quality, and performance of FDA-regulated products. Regulatory science research is important to advancing FDA's mission by helping ensure that we can translate discoveries in science and technology into safe and effective products. To spur innovation in the field of regulatory science, FDA funds extramural research for external stakeholders using various contract mechanisms and grants to address broad challenges within FDA's scientific priority areas. Since 2012, FDA has been soliciting proposals to advance the state of art within these areas through specialized contract mechanisms known as FDA's Broad Agency Announcement, or BAA. excuse me, something in my throat. Thank you. So in addition, FDA partners with stakeholders to advance our public health mission. Oh, the allergy season. Sorry about that. So we have partnerships that address our public health priorities and bridge the needs and scientific gaps, stimulating innovation and in the products that we regulate. CDER, or the Center for Drug Evaluation and Research, is also engaged in a number of public-private partnerships and consortia with other government, academic, scientific, patient, and industry organizations to foster scientific collaborations to advance regulatory science. I wanted to highlight the critical path innovation meetings, because these I think are an important means by which CDER and investigators from industry, academia, and scientific consortium, also patient advocacy groups and governments, can communicate to improve efficiency and success in drug development. The CPIM is a forum for FDA and stakeholders to discuss potential scientific advancements in drug development. And these meetings discuss a variety of topics, such as innovative approaches to clinical trial design and analysis. I also wanted to highlight FDA's Office of Women's Health, or OWH, which is within the Office of the Commissioner at FDA. So OWH works with FDA centers and with external partners to advance women's health through various mechanisms, including funding research to advance regulatory science. The research evaluates a broad range of topics, including examination of sex differences and conditions that uniquely or disproportionately impact women. Recently, OWH updated their Women's Health Research Roadmap. The roadmap incorporated cross-agency input to create strategic direction by outlining priority areas to help maximize the impact of their research initiatives and ultimately promote optimal health for women. The updated Women's Health Research Roadmap reflects current and future women's health needs, priorities, and regulatory research questions. The roadmap outlines priority areas where new or further research is needed and will serve as an important catalyst for research collaborations, both internal and external to the FDA. The roadmap creates strategic direction for OWH to help maximize the impact of their initiatives and ultimately promote optimal health for women. The priority areas are listed on this slide, and they include advancing safety and efficacy, improving clinical study design and analyses, advancing biomarker science, expanding data sources and analyses, improving health communications, promoting emerging technologies and methodologies, and combating emerging technologies, combating emerging health threats. So in summary, drug development can definitely be challenging, and I truly think collaborations between all of us, being regulators, academics, patients, researchers, and industries, is really needed to help facilitate drug development. As I've emphasized, patient input and innovative strategies are critical to helping to advance drug development. And research, I think, bridges a lot of the important knowledge gaps that we've discussed over this important workshop and advances regulatory science. Education and communication through various mechanisms such as labeling help inform benefit risk considerations, and I think also support some of the conversations we've been discussing in the various sections. So my key recommendations are to continue to accelerate drug development. So it's important to have additional safe and effective therapeutic options. We also need to foster collaborations between regulators, academics, patients, researchers, and industry, utilize innovative strategies to advance clinical trials, incorporate patient input throughout drug development, and support research and education, bridging these important knowledge gaps. So I greatly appreciate your attention, and I apologize for the frog in my throat. Thank you so much.
Well, thank you. Thank you to Dr. Maynard. So give a round of applause to Dr. Maynard. Our final presentation in this session is Social and Cultural Context on Menopause, presented by Dr. Yamnia Cortez. You welcome, Dr. Cortez.
Thank you. Okay, so good afternoon, everyone. As mentioned, my name is Jamnia Cortez. I'm an associate professor at the University of Iowa in the College of Nursing, and it's my pleasure to discuss social and cultural contexts of menopause. Here are some of my disclosures. So as you know by now, day 3, the biological underpinning of menopause is the same, but the experience differs across social and cultural contexts. By social and cultural context, I mean the beliefs, values, and social expectations that shape how menopause is perceived, discussed, and managed. Importantly, these contexts intersect with environmental factors, health behaviors, and the healthcare system, influencing access to care and whether symptoms are recognized and treated. And so I have various things to discuss today. So where do we start? In order to identify who is left out of our current conversations about menopause and to provide personalized care, it is necessary to understand how women define their menopause experience and who is more likely to seek care. Here are quotes from qualitative studies among women across various racial and ethnic groups and geographic settings. So one study using an online forum found that Latinas view menopause as el cambio de vida or change of life. The change of life, which I have always heard it been called in Hispanic culture, is like entering a new phase in your life. Your body is going through changes, irregularity, or end of periods, and your way of thinking changes. So this quote exemplifies a theme I've noted in other focus groups among Latinas, and that is that menopause is sometimes spoken about in a matter-of-fact way. It's just something that happens, you go through it, it's not necessarily viewed as a priority. Similarly, African American women in the same study viewed menopause as something you have to bear. One woman stated, as African American women, we are always expected to be strong women who aren't supposed to whine about anything. You just take life as it comes and do what you have to do. If you are having troubles or problems, you should just pray about it and keep going. I don't think that my culture believes that menopausal symptoms are something that you would have to run to the doctor for. This research further found that non-Latina white women may be more likely to seek advice from their providers for menopause. As one participant stated, I went running to my general practitioner when my symptoms first started. She calmed me down a little and referred me to an OBGYN. He diagnosed my disorder as menopause and discussed it with me at length. And so these experiences and perspectives offer critical insights into who is more likely to seek care, the type of management strategies people will implement, and who is excluded from conversations and research. We can also note where targeted efforts are most needed, particularly given evidence of greater symptom burden, as we've heard in some groups, such as Black women, yet less likelihood of seeking care or discussing that. As the quote suggests, attitudes towards menopause are important to consider. In our focus groups, nearly 80% of participants, and this is among Latinas, viewed menopause positively, often as freedom from menstruation and contraception. However, attitudes towards hormone therapy were much more negative, with about 60% expressing reservations. The figure below are early findings from the SWAN study, which showed that attitudes towards menopause may vary by race, ethnicity, acculturation, and life context. So though the differences are small in this study, they were significant. In this figure, I showed the overall attitudes towards menopause in SWAN, but what they actually found is that, for example, African American women tend to report more positive attitudes, while Chinese and Japanese American women reported less positive attitudes towards menopause. And there was also a difference, as I mentioned, due to acculturation potentially between Chinese American women who were preferring Cantonese versus English speaking. And so some of the evidence suggests that less acculturated women report less positive or more negative attitudes towards menopause. And among Latinas, I've actually noticed the opposite. These attitudes don't just reflect how menopause is viewed. They change whether symptoms are recognized as needing care, whether treatment is trusted, and ultimately who seeks support. In addition to attitudes, menopause knowledge shapes how women interpret symptoms, as many of you already know, and how early they engage with prevention and treatment. What we see here is that many women report limited knowledge about menopause overall. 57% of Latinas in my research report little knowledge about menopause. In another survey illustrated here, there were 60% of women who felt largely uninformed about perimenopause and menopause before age 40. And as mentioned earlier in this session, there are reports of interest to learn about menopause earlier, even in school. These gaps in knowledge can delay care, they can normalize distress, whereas earlier knowledge can support prevention and strategies that can maintain long-term health. So it's important to consider the range of contextual factors that contribute to attitudes, knowledge, and experiences of menopause. Socioeconomic status, including education, income, and occupation, might influence access to information, health literacy that was mentioned earlier, and the ability to engage with the healthcare system. Cultural beliefs, race, ethnicity, and cultural beliefs can play a role in shaping how women understand menopause, discuss it, what's valued, as well as how symptoms are interpreted and managed. Global acculturation levels, again, as I mentioned, are associated with viewing menopause as taboo or a private matter. And so that might influence lower symptom reporting. And then finally, geographic setting matters. Where someone lives affects access to care, exposure to menopause education, and availability of supportive resources. Most of our research has focused on urban settings, and there is emerging evidence showing that rural women may have higher symptom burden, and as we know, less access to care, with even less than half of the number of OBGYNs in rural areas than in urban areas. And I talk a little bit more about environment later. So I found that just 24% of Latinas report seeking health information about menopause from a health provider, going back to the earlier session about where people are seeking information. As I've mentioned, access may be one reason. However, even among individuals with access, we see that the expectations are not being met. One person in one of my studies said, for me, it would have been better if the doctor told me about all this menopause before I went to ask about my symptoms. And so providers expect that patients will ask questions, and sometimes patients, particularly depending on their background and culture, won't bring it up unless the provider brings up the topic. They might think that, well, if they're not discussing it, then I guess it's not that important. Yet data show that clinicians feel unprepared to manage symptoms. And so additional studies found that healthcare providers may be reluctant to share menopause information, particularly among immigrant women, individuals that are not English speaking, due to limited time, lack of knowledge, and lack of confidence in culturally competent communication. So the other thing I wanted to say before I move on was that the lack of access to providers and culturally appropriate care may contribute to some of this mistrust that we've also heard about earlier in terms of hormone therapy and other management strategies. So far, I've focused on some of the factors that impact knowledge, attitudes. Next, I'll present some findings on differences in symptoms and how the intersecting social, structural, and biological factors that can shape some of the different health trajectories that we spoke about yesterday at Midlife and Beyond. So this figure illustrates a multi-level life course framework for understanding menopause health and health inequities. It's adapted from the NIMHD and NIA health disparities research frameworks, and it highlights how factors operating at multiple levels, so not just the individual. A lot of what we've discussed has been the individual level, shape menopause experience and outcome. And so these include some of the things I've already mentioned. So social cultural environment, like socioeconomic status, language, exposure to discrimination, but also the importance of the physical and built environment, behavioral factors, and the healthcare system and how these operate across the life course. It's not just in isolation of what's happening at midlife, but how these things also intersect with your experiences across the life course and how that can then impact health. And so in terms of menopause-related symptoms, I won't spend too much time on the next several slides because we have all seen many of these, which are that there are racial and ethnic differences in terms of menopause symptoms and experiences. And this is an early publication from SWAN. It was a cross-sectional report that found that Japanese women were consistently reporting fewer symptoms, but we do have the longitudinal data that you have already seen demonstrating that in SWAN, there are differences in the age of menopause and duration of vasomotor symptoms, with the mean age at menopause among Latinas being about 2 years earlier, and then the duration of vasomotor symptoms being longest for African American women. However, it's important to note that a lot of these differences were attenuated after adjusting for socioeconomic status and lifestyle factors. So we know that there are racial and ethnic differences, but we need to go beyond that in order to understand these other factors in the stage for these differences that we are noticing. And these are these system level factors. SWAN also showed differences in management strategies. So with the majority of women overall reporting not having tried hormone therapy or complementary alternative medicine, as you can see, it was 92% among Latinas, consistent with some of my own work where the majority said that they weren't trying anything. And while it is possible that attitudes, access, patient-provider communication, and culture may contribute to this, we need to assess further. These are different gap areas. Yesterday, we also heard great presentations on well-being and mood during the menopause transition at baseline, and that there are racial and ethnic differences as well in this. When evaluating depressive symptoms across 15 years during the menopause transition in SWAN, Latinas were more likely to follow this pattern of consistently high depressive symptoms. And factors related to that trajectory were financial burden, having more frequent vasomotor symptoms and sleep disturbances. That's not surprising, and we heard about that yesterday, as well as experiencing stressful life events and lower social support. So while more research has emerged on the impact of stress and trauma, we heard from Dr. Thurston yesterday, there's still a need to understand the role of some potentially protective factors, such as social support. Low social support was related to worse depressive symptoms. What about social support, social cohesion? Some studies have shown that lower social support and fewer networks are related to more frequent or more severe menopause symptoms and quality of life. But right now, I am talking about acculturation. So let's take a step back. Hold that. I'll do this one and then I'll go back. And so what I forgot to include here when I'm talking about social support and social networks is also the impact of shifting social roles. So not only few social networks, or some studies are also assessing loneliness and the impact of that on midlife health and beyond, but social role strain has been investigated, or family obligation stress, where how these can further contribute to some of the mood and sleep changes. So we're currently analyzing data where women report that they feel like they carry not only their financial and work-related stress, but they're also carrying the stress of their children, who are either they're still raising their children, or they left the home and have to come back, or now looking for a job, caring for parents, as well as some of them reporting the stress of family members in their home country. Furthermore, living in communities with high crime, limited access to public services, we know from other research that these things can contribute to higher stress, depressive symptoms, and sleep disturbances, but there's limited research on how this impacts women during the menopause transition. And you've already heard about the impact of childhood adverse experiences and trauma on vascular health. So I did want to go back to something that I mentioned before, which was acculturation. I won't spend too much time on this, but acculturation is the process by which individuals adapt to a new living environment and are adopting the values and norms of this new society. We've seen in the literature that there's inconsistent findings about acculturation in relation to menopause symptoms and outcomes. And one of the reasons may be just the way that we measure acculturation. Many studies use this linear or unidimensional assessment, which assumes that everyone with length of time in the US will acculturate the same way, or a lot of studies use one item measures for either where you were born, number of years in the US, or what is your language of preference. And so I think we need to, just like with some of the other measurements that were mentioned earlier, we do need to dig a little bit deeper with some of these measurements so that we can better determine some of these associations. So there is growing evidence that discrimination represents a chronic stress exposure with physiologic consequences relevant to menopause. And I had the pleasure of collaborating on this project using SWAN data to examine whether everyday discrimination accounts for the increased risk of vasomotor symptoms among Black women. And we found that higher levels of discrimination were associated with concurrent report of any vasomotor symptom. And chronic discriminations was linked with persistently high symptom trajectories. However, discrimination measured in midlife did not fully explain Black-white disparities, particularly in that pattern of persistently high discrimination over time. So going back to something I said earlier, where there are multiple factors. It's beyond the race, ethnicity having to do with some of the differences that we're seeing, and here discrimination, but then additional system level factors that are also playing a role. So the financial strain, where people live, things like residential segregation, which we have looked at in other studies and in other fields. Interestingly, environmental factors have also been linked to menopause health. So living in greener neighborhoods is associated with older age at menopause, while long-term exposure to air pollutants is associated with a younger age at menopause. And so this is another area that warrants further research. We know that these environmental factors may have biological impacts, but they also play a role in terms of health behaviors. And then again, these environmental exposures also differ by geographic setting. And so again, thinking about rural and urban exposures and how they differ and how that might differentially impact women during the menopause transition. And so that leads me to this next point. We already discussed on day one, a lot of the health behaviors. But in addition to focusing on individual behaviors and individual level interventions, we do need to consider how the sociocultural and built environments impact behaviors. So, your access to foods in your neighborhood or access to safe places to exercise is going to impact why you are or not participating in these activities. But then also, thinking about interventions at the interpersonal and community level. So a lot of participants that I've spoken to prefer family-based interventions or additional group intervention in the community, or how we can shape communities in order to enhance people's ability to actually perform some of these health behaviors. So what can we do? That's where I go on to my review of what we don't know and what we do know. So far, what we may know is that menopause experience differs widely despite shared biological processes. As I mentioned, this is shaped by social, cultural, structural, and environmental contexts. Racial and ethnic differences exist in symptom burden, as well as treatment use, low and seeking care as well. Low menopause knowledge is common, and most women do not receive anticipatory guidance from providers. Social stressors matter. So financial hardship, discrimination, neighborhood conditions, and social support can influence symptoms and quality of life. And then what we don't know, how these human system level factors impact how, which structural and environmental exposures to focus on. And then I'll actually just move on to the key recommendations then. And so in terms of research, I think there's a need to expand representation of women and menopause research in various contexts. So not only race and ethnicity, but also socioeconomic status, rurality, comorbidities, explore the impact of system level factors on physical and psychosocial health during the transition, identify the structural and environmental barriers that limit behavioral and lifestyle strategies. We need to design scalable interventions that are culturally tailored, as was mentioned earlier today, and multi-level to address not only lifestyle interventions, but also thinking about access to menopause care. And then in terms of policy, again, focus on the access to care and how that's important, as well as thinking about supporting community health workers and patient navigator workforce. And that's it.
Thank you, Dr. Cortez. Round of
Thank you.
applause for Dr. Cortez. What great information. So now we are going to, I want to thank all the speakers, and I would like to invite you to turn on your cameras and join Dr. J.D. Smith, our Vice Workshop Panel Chair, who will moderate and lead the discussion.
Thanks, Keisha. That was a fantastic session. We're a little tight on time, so I want to jump right into some questions here. The first one is kind of an observation and then kind of directed towards Dr. Maynard. There were several questions about FDA's removal of the black box warning, not unexpectedly. Just curious if you have anything to add about the process, as well as FDA's thinking about this different approach.
Yeah, thank you very much for following up on that. And I did expect that there would be questions on that, and I didn't want to spend the whole session talking about it, even though I know it's really important. So just to clarify one thing about labeling changes. So labeling changes can be initiated by FDA or a sponsor. FDA, of course, reviews labeling before it is approved. And for the menopausal hormone therapy labeling, these changes were requested by FDA, but that was after a very rigorous review of the information by FDA. And we did look at various data sources, but we really emphasized looking at the scientific literature and sort of updated analysis and longer-term data that's currently available. And we did have input from other sources, such as there was a public docket for public input about the considerations related to menopausal hormone therapy. So this was an incredibly rigorous and scientific review, really thinking about the issues. And I know it's very important and something that probably folks want to hear more about. And that's why the timing was sort of perfect that this FDA grand rounds is occurring to really focus on those labeling considerations, both sort of the scientific evidence to support the changes and then what the actual changes are. And that is just coincidentally happening next week. So I hope folks are able to join that or listen. There should be a recording available too after that session.
Great, thanks so much. And Dr. Miller, there are several questions in the Q&A and the chat if you have time during the rest of our session to answer those. A question directed for Dr. LaCroix. Can you say more about the risk-benefit difference for menopause hormone therapy from your risk stratification figure? Is it based more on the risk side, meaning greater absolute risk of disease for older women, or more on the benefit side of reducing menopausal symptoms?
I wasn't part of the group. I think it's based on acknowledgement of the different risks for cardiovascular events, depending on your underlying risk factors. It doesn't seem to incorporate that much about age, but I'd have to go back and look at it. So I think it's a useful clinical translation of the clinical trial evidence on who's most likely to have cardiovascular adverse events if they take hormone therapy. And, that question was about compared to oral contraceptives or hormonal contraceptives. And I think the risk-benefit equation for contraceptives is much different. The women are younger, and there are a number of possible things that can happen to you if you become pregnant as well. So I don't compare the two.
Great, thank you. And a question for Dr. Cortez. So you did discuss a lot of studies, and several of them reported that some minority groups reported either, quote, less severe or just fewer symptoms related to the menopausal transition. For example, Latinos and Asian Americans. I wonder whether some of these may be related to cultural differences. For example, lack of equivalent vocabularies related to the symptoms themselves, or different perspectives on menopause and what it actually means within that cultural group.
Yeah, that's exactly what I think as well, in terms of even when we're discussing like the attitudes towards menopause and how that impacts whether or not you're going to report symptoms. But then also in my research studies among Latinas who are Spanish speaking, we'll have like 4 different words for certain menopause symptoms just because of dialect differences. And so depending on tools that you're using, if they're culturally tailored, if you have the language, people can perceive symptoms differently or not recognize what you're asking them based on that. So I think that it's important that we do have culturally tailored tools, as well as not only tools, but there is a lot of value in qualitative studies so that you can get more of that information from participants. They'll answer one way on a survey, and then when you ask them differently in an interview, you'll get a different perspective.
Certainly a need for that culturally competent approach, both to our research and our practice. So this is kind of directed for everyone on the panel. I'll preface this by saying I'm coming at this as an implementation scientist, so really trying to understand how do we change practice, what are the barriers and challenges to actually doing so. The FDA changes to menopausal hormone therapy certainly changed practice. It's probably a slow change, given that that black box warning was on there for decades. Can you discuss other structural and system factors that directly impact practice and care during the menopause transition? We heard a lot about misinformation, industry, some commercial pressures, insurance-related factors. What other things are happening in the world that we live in that impact how clinicians approach care during the menopause transition?
Well, we talked about so many things, structural factors. Let me just reflect on some new things from this session. Dr. Cortez, I think, draws attention to the fact that women's preferences differ across the different cultures. So not everybody wants to take hormone therapy, and it was always the case that a lot of women didn't want to take hormone therapy, even when we thought it was good for prevention, back in the early 90s. So I appreciated the point today that that the absence of treatment doesn't mean that women have been ignored or not listened to. It could mean that, but it could just be their preferences, that they don't want to medicalize their own menopause. So that's one reflection. You've asked a question that would, which the whole talk was about. So reflecting back, for example, on the talk we heard about the program at UCLA, I commented that, if we have to rely on someone to completely champion these programs out of the goodness of their heart, it's going to be hard to have adequate menopause care very many places. It needs to be part of an institutionalized expectation. Women shouldn't have to go, outside of their healthcare system to boutique expensive practices to get menopause care. This should be part of their regular medical care. And I don't think the doctor should bear all the responsibility for the education. I think that's asking way too much. We need to have reliable sources for women that are already at the time of menopause, and we need to start the whole education process, back in middle school. So those were the points that I was making. Ignorance is a big structural barrier, Dr. Smith.
Yeah, great point. Dr. Cortez or Dr. Maynard, would like to add any other reflections or kind of bring some of these themes together?
Well, I think I was also thinking about barriers, yes, in terms of training, of course, which we didn't say, which we did mention, in terms of feeling your comfort in discussing menopause and feeling prepared as a clinician. I think it's also across different disciplines. So we do need multiple health providers at different fields. So, OBGYNs and endocrinologists, nurses, nurse practitioners, psych, so various people being trained, anyone who's dealing with a midlife woman being trained in menopause. And then the other thing in terms of where you live and how that plays an impact in transportation, in thinking of alternative ways like telemedicine, expanding that to increase. I mean, yeah, one of the major things that we all said was access and different ways of access.
Yeah, it's a great point about location. I know I'm here in Salt Lake City, in the middle of the West. We talk about distance as a health disparity. Really causes a lot of challenges for care. Dr. Maynard, anything to add there?
Another reflection is just that, I mean, we can make this sound so complicated that it feels like we can't do anything to improve the situation. And I think that that is fundamentally not true. I hope that we won't come out of this saying we have to be so individualized and so attentive to 100 details that we can't do anything. It's just too complicated. There are very easy ways to improve this situation, which is the endemic ignorance about menopause. So I hope we'll focus on things that are doable and not get lost in the rabbit hole of possibilities.
And I guess I like Dr. LaCroix, I like your positive outlook. So I would echo that I think it's so important to say there are challenges and we recognize their challenges, but we're going to work together and really advance the health of women, that we can do this, right? We just need to come together. And I think sort of workshops like this are so critical in advancing that, really talking about what are the challenges and how can we move forward.
I would love to end on this positive note. I fully agree with Dr. LaCroix that, there are easy things we can do. And even though it's a complex system and a potential complex solution, there's a lot we can do without having to go down that route. So rather than eat into our break too much more, I'll turn it back to Keisha, I think, here to transition us. Thank you, panel.
Thank you. Thank you, Dr. Smith, and thank you to the panel. So our final general session for the day explores innovative approaches to symptom prevention and management, grounding innovation and evidence. To begin, we are joined by Dr. Melissa Wan for her moderator perspectives. Dr. Wan, welcome.
Hello, everybody. I am very excited to be here. Looks like I have control of the slides. Fantastic. All right. Really happy to be here. I will be kicking off our final general session 3 here, which I've kind of loosely titled Walk Before We Run, Grounding Our Innovation in Evidence for Menopause Care. So I'm going to start. Uh-oh, things got weird there. There we go. All right. So I'm going to start here with our disclosures, which are that I have no financial, emotional disclosures. I will disclose that my day job has relatively little overlap as a maternal fetal medicine physician with menopause, other than the cessation of menses. The reality is that I'm here because I'm a bit of a data nerd. So a lot of my work is around artificial intelligence and developing data models and how we can do so safely to mitigate bias rather than potentiate it. And I think that it is particularly salient today. I think AI is really everywhere, and the promise of AI and really personalized medicine in general has been really this, right? This going from this sort of question of individual patient and rather broad population-based care to sort of an individual approach, taking into account traditionally acquired clinical data, maybe adding biomarkers and molecular features, underlying physiology or clinical history, coupling that with perhaps computationally driven analyses of their imaging or wearable information, analytics, adding in a little bit of omics data, all of which is going to then inform this larger information commons, allowing provision of this precision care for not only this person, but for maybe all of those like her thereafter. The reality, I would make the case, not just in menopause, but honestly broadly in healthcare and medicine, has been very different from this. And I think the reason for this comes down to 4 concepts, very simply, that I'm excited for our panelists to help us sort out today. And the first is this, that menopause centrally has a data problem, I think, as we've heard over the last 3 days now. Because very much this is what artificial intelligence or any of these models, this is what they want, right? AI really requires these clear definitions and simple correlations. It can be a million simple correlations, but the data really has to be there. That says sort of like click on light switch A and the following will happen to light bulb B. And I would make the case that we unfortunately simply lack the data to be able to say this in a way that's consistent, reliable, reproducible, and generalizable. In fact, really at baseline, our definition even of menopause itself is difficult. The most nationally representative data that we have is the NHANES survey, and yet we even lack a basic sense for the prevalence of menopause by age. And even the nature of how the questions are asked, I would say, further confuses it. As we have understood over the last few days, while hysterectomy will indeed result again in the cessation of menses, it does not tell me whether the patient is menopausal. Similarly, while an oophorectomy would be a surgical reason for both the cessation of menses and a reason for menopause, it has oftentimes not been one of the multiple choice options. We lack further even an understanding of the full spectrum of menopausal symptoms for both strictly data and even cultural reasons, nor has there been really any significant uptake of the ICD code such that even administrative data is lacking. The idea then of being able to personalize therapies is really aspirational. And for medications, I think we've certainly heard that it really has been entirely sort of the Wild West out there. We don't know what people were on leading up to menopause. So was a progestin IUD the reason for the cessation of menses, and they just left it in because of why wouldn't you? We know disturbingly little about the modern preparations in terms of their sort of long-term outcomes or formulations of HRT, and we know little about the safety data on the FDA-regulated therapies, let alone those sort of sold out of a wellness shop. We know further, of course, as we've heard, that there are significant disparities in HRT use, despite an inverse correlation to the symptom burden, which raises the question for me, again, as an AI and data person, this is honestly the type of stuff that keeps me up at night, that if we then code in less treatment for those where access had been the reason for less treatment in the past, when we now code that in, it becomes sort of this historical and structural racism limiting that previous access. That now turns into essentially algorithmic bias about whether they need, quote unquote, that treatment in the future. And so as we recognize that sort of all of these gaps exist along that, click on light switch A, turn on light bulb B pathway, I'm strongly suspicious, frankly, of any application of AI today to menopause management, that it represents really little more than an obfuscation and overfitting of these really tenuous lines of evidence to an ill-defined goal. Second, menopause has a care delivery problem. And this is, put simply, what people are finding whenever you Google personalized care for menopause management. Chatbots that advertise as though they're providing personalized medicine. However, when you really look to how much randomized controlled data is driving these AI-driven agents, I think you can probably guess based on past slides, it is somewhat lacking, 0, in fact. And in some ways, this is a bit of a problem of our own creation. So our own policies have left our patients to, in many ways, fend for themselves. There is truly little to no regulation, and the distillation of fact from fiction, from advertising, is near impossible, particularly when they come up with such clever naming conventions. I mean, Madame Ovary, who wouldn't want that very clever. And if anything, the most compelling thing I found involving AI and menopause at all was, in fact, this personalized air conditioner, which is, well, at the very least, inarguably cool. Sorry, just had to add in a pun. And finally, I will add that menopause broadly has a bit of a truth problem or a dissemination of accurate information problem. And so we must recognize that our correction of this misinformation or even really overt disinformation is acutely critical, particularly in the era of AI, when we consider that health and healthcare is really perfectly primed to propagate these algorithms, which represent what Dr. Kathy O'Neill calls weapons of math destruction. So all of this information has a very easy ability to scale, particularly in an environment where a small group of companies hold vast majorities of the market, where these algorithms further can be masked under proprietary considerations or HIPAA, and then finally, where they can either by force feeding or our natural human desire for confirmation bias can create these positive feedback loops in which this bias is not only drafted, but potentiated and amplified further. And so with these considerations in mind, I am thrilled to hand over the virtual podium to the next group of speakers who, good news, have solved it all for us. So Dr. Stephanie Fabian to speak to her work on granular data collection for menopause assessment and management. Dr. Lindsay Harper to share her experiences creating an evidence-based sexual health intervention delivered and tailored directly for patients. Dr. Barbara Levy to draw on her experience in the health and public policy arenas and which levers might be needed to change the trajectory of the menopause narrative. And finally, Dr. Jevin West, an expert in all things misinformation, to help us understand how to help craft this narrative effectively for our patients, friends, family, the, 50.05% of us who might be privileged to experience the menopausal transition. Thank you.
Hi, good afternoon. I'm Stephanie Fabian. It's a real pleasure to be with you here today. I'm an internist and I am at Mayo Clinic in Jacksonville, Florida. I'm also a medical director of the Menopause Society. So what I'd like to talk to you today is about data gaps. I will be talking about the DREAMS registry and a few other data sets and really kind of how we're still pretty limited in terms of being able to look at menopause. I have no relevant information to disclose. So let's talk about a few different things. First of all, you've heard a lot from these last 3 days about how women are having a problem. I totally agree with the concept that menopause is not a disease, but some people do have some struggles with the menopause transition and need some help with management. But wouldn't it be great if we could just have women raise their hands and say, I'm having trouble with menopause, I'm in perimenopause, I'm postmenopausal, here are the issues. But instead, we know these women cost the healthcare system quite a lot, and they cost the healthcare system more than pretty much anyone else. It's somewhere in the range of $1,500 to $2,000 per woman per year during this time. And it's not that they're really in the OBGYN's office seeking care for hot flashes necessarily, but they might be in the rheumatologist's office seeking care for joint pain, or in the urologist's office seeking care for urinary leakage, or they might be in the psychiatrist's office seeking care for mood issues. So they really might end up in a bunch of different places. And wouldn't it be great if we could just query the electronic health record to say, gosh, why don't you tell us who's having a problem? And we could maybe then help them put this all together, because I can promise you their clinicians are not putting it all together either, because we've already heard about the tremendous gaps in clinician education. So we're going to talk about the gaps in terms of the electronic health record as well. And then there's the whole coding system. So I found out recently that it doesn't matter if you code menopause, perimenopause, symptomatic, asymptomatic menopause, it all ends up in the same code. So as a researcher, I can't go in and say, gosh, tell me who's perimenopausal, and I want to study those women. And if you use just a blunt age instrument and say, let's just classify everyone 55 years and older as postmenopausal,
very blunt instrument, and we're missing a lot of women who experience menopause earlier. And we know there might be different consequences for women who go through menopause early, as in between the ages of 40 and 45, or prematurely before the age of 40. So I'm going to go over just a couple of studies that we've done recently. And in fact, this one was just published this year. And we looked at the accuracy of self-reported menopause stage in the DREAMS registry. And we compared it with clinician-determined stage. So we had both patient and clinician-determined menopause stage in our cohort. So we use the DREAMS registry. It has self-reported questionnaire data from women who are coming in to be seen at a women's health clinic. So keep that in mind, from 3 different geographic locations in Minnesota, Arizona, and Florida. We chose to look at women between 50 and 65 years of age who came in for care between 2016 and 2019. The reason we picked that time frame was because we had data from both women and their menopause clinicians on their menopause stage. So what we found was there was agreement between women's self-reported stage and clinician-reported menopause stage in only 57% of our cohort. This was quite disconcerting because we use this information all the time to say premenopausal women think this or say this or experience this versus postmenopausal women. And turns out there's a whole lot of confusion here among women about where they are in terms of menopause stage. So specifically, among these 3,400 women that we had this dual reporting on, over a third of them, almost 40% actually, reported being unsure of their menopause stage. That's quite substantial. And there are a lot of reasons for that. And you've heard that sometimes we can't rely on the menopause or the menstrual cycle to be able to help us with whether or not women are postmenopausal. And, you know, we have things like the progestin-containing IUD, or women might have had an endometrial ablation, or they might be on an oral contraceptive pill in perimenopause, or they may have had their uterus out but still have their ovaries. There are lots of different reasons, but I would submit to you that women are confused, even if those situations aren't the case. So 76% of women who were unsure about their menopause stage were determined to be postmenopausal by their clinicians. So this shows us that the biggest point of confusion was whether I've hit menopause yet. 76% of women who were unsure were determined to be postmenopausal by their clinicians. So clinicians classified about 389 women, or about 11% of this cohort, as they were unknown. They were unsure. So clinicians were unsure at some point too, and those were probably due to reasons that I just mentioned. So not being able to use the menstrual cycle as a cue. 55% of the women in that group of 11% of the ones that the clinicians weren't sure also agreed that they were unsure where they were. So there's probably some legitimate confusion in here, but for the most part, I think a lot of women who are postmenopausal aren't sure that they're postmenopausal. So the level of agreement on menopause stage was low across the age groups. So but it didn't matter if you were 40 or 64, that the confusion was still there. However, after the age of 50, agreement got better. But look at this. After the age of 60, self-reported postmenopausal stage was about 60%. So really, technically, pretty much everyone over 60 would be postmenopausal, but there were still 40% of women who were really not sure that they were postmenopausal. And clinicians reported women over 60 to be postmenopausal about 90% of the time. Okay, so this study really highlighted discrepancies between patient-reported and clinician-determined menopause stages. It speaks to a lack of awareness among women regarding their menopause stage. It might also lead to an under-recognition of symptoms. If they're confused about whether or not they're peri or postmenopausal, they're probably also confused about whether their symptoms relate to menopause. And we have some additional data that's about to come out that shows there's significant uncertainty, especially around the perimenopause stage, about whether symptoms relate to perimenopause or to something else. All of this may result in delays in care, missed opportunities for timely interventions, or interventions rather, and it adds to confusion with regard to research because it makes it much harder unless we have true laboratory data or really good menopause or menstrual cycle tracking to really be able to determine menopause stage. Okay, so here's another study that is also recently published, and it's documentation of menopause-related ICD codes in the electronic health record in midlife women with menopause symptoms. So the objective of this study was to assess documentation of menopause-related ICD codes, which were ICD-10, in the health records of midlife women who we know were having moderate or greater menopause symptoms. And then we were looking at whether there was an association between the use of an ICD-10 code and actual menopause treatment utilization. So we used a different data set for this. It's the Hormones and Experiences of Aging cohort, which was really designed to capture menopause experiences of midlife women. And we included the women in that study if they had a higher MRS score. So the menopause rating scale measures menopause symptoms, and we only looked at those women who had a score of 12 or more, indicating moderate or higher symptom burden, and if they sought care in the past year for menopause-related symptoms. And the primary outcome was documentation of an ICD code within the 12 months before the survey completion. So here, this gets down to it. So for the Harris study in general, we sent out surveys to all of the women who were 45 to 60 years of age at all of the Mayo systems who were receiving primary care, who had primary care at our system. And so that was almost 33,000 surveys went out. We got a 15% response rate, which is fairly typical. So almost 5,000 women responded. Of those, we looked at about half of those who had an MRS score of 12 or higher. So that's about 49% of the whole group. Interestingly, about 63% of them told us that they sought care for menopause-related symptoms, which actually sounded pretty good to me. But only 345 or 23% actually had a menopause-related code in their record, even though they said they sought care specifically for menopause symptoms. 77% then did not have an ICD code. Okay, so if they had an ICD code in their records for menopause symptoms, what were the codes? Postmenopausal bleeding was in there, and this just goes to the confusion. I want you to look at N95.1, which is menopausal and female climacteric states. So that could mean symptomatic, hot flashes, night sweats, etc. There's also an asymptomatic menopause state down there, Z78.0, which about 9.9% of the women had. Okay, I just told you that these women only got included in the study if they were symptomatic. So it's interesting that the ones who actually did get a code, a lot of them got a code that said they were asymptomatic. But then there's also this other confusing code, N95.3, disorders of menopause and perimenopause. I wouldn't know what the difference between N95.3 and N95.1 are supposed to be. And I'm a menopause doctor. So very confusing and interesting that a lot of these symptomatic women got a code for asymptomatic menopause state. Okay, so women with menopause-related ICD codes in their records in general had higher total MRS scores. That kind of makes sense. So if you were more symptomatic, you were more likely to get a code. And the differences were primarily driven by higher somatic symptom burden. What does that mean? That means the somatic burden score is hot flashes, night sweats, and sleep disturbance, the more classic menopause symptoms. So if they had symptoms in the psychological or the urogenital domains, they were less likely to have an ICD code. Kind of makes sense because maybe we're not so sure that the mood symptoms related to menopause, or they might not have been recognized as relating to menopause. Same with the genitourinary symptoms. The women with the menopause-related ICD codes were more likely to use some sort of menopause treatment and did in general report better physical and mental health. And despite seeking care, only 35% of women reporting vaginal dryness and about the same with hot flashes had a menopause-related ICD code documented. So again, we've got some gaps in our system here. Even when women are having symptoms related to menopause, they're often not documented, even if they are seeking care for these symptoms. So the conclusion for this study is there's a discrepancy between menopause symptoms experienced and their clinical documentation in the record. Again, it makes it difficult for me, either as a clinician or a researcher, to go in and say, let me find some menopause codes. I'll be able to find the women who are really experiencing some symptoms. So what could be impacting this? I think clinician knowledge gaps are still an issue here, but I think patient knowledge gaps are also problematic. But if clinicians acknowledge and document a menopause status or symptoms related to it, it may influence the likelihood of treatment. But you can also think of this conversely, and maybe it's a decision to treat menopause symptoms, increase the likelihood of an ICD code to be there. So we need improvement in identification and management of these menopause symptoms in clinical care. Okay, so quick notes on ICD-10 versus ICD-11 menopause coding. We are going to transition to ICD-11 codes at some point, and looking at, again, today, I see that's still pretty unclear on when that would be. The WHO has designed ICD-11 to be a little more digitally friendly and clinically relevant. It supposedly has greater clinical granularity, improved alignment with women's health conditions. They're now menopause related conditions are now under two main categories: 6A51, which is female endocrine disorders associated with the menopause, and GA30, which is menopausal or certain other perimenopausal disorders, which may facilitate more accurate documentation of the shifts here. So here's a list of some of the titles. I still honestly would be a little confused as to whether I would be, for a menopausal woman in my office reporting hot flashes, would I code her 6A51 or GA30? Still not entirely certain about that. So if I'm confused, I would imagine that a lot of clinicians out there doing primary care are confused. Okay, so key recommendations here from my standpoint: clinical coding and documentation are a gap. We need to standardize EHR documentation and optimize use of ICD-11 menopause-related codes when they become available for use. Application of AI and machine learning algorithms may be the way to go here, although we're certainly not there yet. If I could just say, tell me who's menopausal and who's having a problem with menopause, and pick it up in the electronic medical record, wouldn't it be nice to notify their clinicians and actually the women that it seems like they're having issues here that could be treated? And we could integrate symptoms, age, labs, diagnoses, and medications in this algorithm. I think it can be done. I think it's going to be complicated, but I do think it's possible. We still have major gaps in clinician education and training. Everyone knows that. We need to improve awareness and early recognition. So even women who are going in saying, I'm having menopause symptoms, still didn't get it documented in the record. And we need to really integrate menopause education into CME and primary care and specialty training. And then we need patient education because, again, women are confused as to what's happening to them and where they are in the menopause transition and can't articulate where they are. Clinicians aren't a lot better in many cases. So we need to normalize symptom reporting and reduce stigma. So thank you with that. I look forward to the discussion.
Thank you, Dr. Fabienne. Round of applause. Next, we have Dr. Lindsay Harper. Lindsay Harper, sorry.
Thank you so much. Really happy to be here with you all this afternoon and share my passion, which is about women's sexual health and also direct-to-consumer approaches to hopefully address some of the concerns that we've been hearing about from so many of the other presenters as well. My disclosure is that I am a shareholder of the company that I started named Rosie. We'll talk briefly about that during this presentation. I do want to start by giving a plug for women's sexual health. It hasn't been talked about a lot. It's been mentioned a few times, but I do want to just overview the scope of sexual health as a problem for women, particularly during perimenopause and menopause. 43% of US women report at least one sexual health concern, including low desire, difficulty with arousal or orgasm, and sexual pain. And that number does rise during perimenopause and menopause to about half of women, 50% of women reporting a sexual health problem as either a new issue or an exacerbation of an existing issue due to the many hormonal, neurological, and other physiologic changes that you've heard about. And these problems can result in other issues down the line, including significant depression, anxiety, relationship distress, personal feelings of incompetence and loss. And so, these are issues in and of themselves, right? Sexual health is a human right for both men and women. And so we want to make sure to recognize that these issues are problems on their own, but they also have other effects on women during this time of life as well. So I want to talk a little bit about the gaps for sexual health when it comes to women. We have, a dearth of research. There are smaller scale studies, and we're just now starting to understand basic anatomy and physiology of female sexual function, but that is missing from so many different parts of a woman's healthcare experience. The full clitoral anatomy was first described in 1998. So I think probably most people on this call were born after that, before that happened. So that's an abysmal place to be as a woman in the world. Patient understanding of normal sexual function, problems, and opportunities are a huge issue, as well as normalized conversations around sexual health. So if we don't even have the language or the modeling to have a sexual health conversation in a medical setting, then we're definitely not going to make it very far down the line when it comes to addressing a problem. As we've discussed, provider and healthcare professional training is extremely limited. So we think it's limited in menopause. It's even more limited in women's sexual health. I didn't start my women's sexual health education until after I was already in private practice. And it was self-initiated when I realized what an issue this was for so many of my patients and how limited my training has been. I like to tell the story that I spent 2 weeks in an erectile dysfunction clinic at the VA as a medical student and really had, 1 to 2 hours as an OBGYN as a resident on women's sexual health. So the discrepancies are really, really vast. And most people, when it comes to talking about women's sexual health, think you're talking about sexually transmitted infections or contraception. But really, there's so much more to sexual function, just like we understand for men, including desire, arousal, orgasm, lubrication, and pain. There is an emphasis on men's sexual health because it's perceived to be more straightforward, and women are considered to be more complicated. And just like Dr. LaCroix was pointing out in our last session, sometimes conveying that something is complicated can reduce it to the realm of we can't handle it or we can't tackle it or it's too much. And I really think that that's a harmful narrative around women's sexual health and around menopause as well. There's so much to be done, but there are very easy next steps that we can accomplish in both of these fields. As I mentioned, from a provider perspective, but also from an insurance coverage perspective, women's sexual health is not viewed as a priority or standard of care. The reimbursement is extremely limited by both government organizations and commercial payers. And this applies to reimbursement for the visit, so for a clinician interacting with a patient about a sexual health problem, and also from a pharmaceutical intervention perspective. What happens here is this leads to cash clinics, as we've heard, or no, the patient's not addressed at all, which further widens those inequities that we're seeing across the board for women's health. So I wanted to just give an overview of how these gaps trickle down and actually continue to perpetuate these cycles that we're seeing. So because we have limited historical funding of research, of basic science knowledge, that leads to limited, training of myself and other healthcare professionals. That combined with the lack of insurance reimbursement and prioritization leads to major gaps in these treatment of our patients. And so what happens there is it further breaks down this relationship between the healthcare provider and her patient, because really we want to do the best we can for our patients. And sometimes our patients are trusting us with this information. But if we don't have any resources for them, then those patients feel unheard. They are unheard. Their real issues are unaddressed. And as a result of that, we continue as a country to incentivize these pop culture personalized services that skirt FDA and speak to patients' pain and disappointment. So it really is on us as a collective to start to understand that we're missing these huge issues for women, both when it comes to menopause, as we've been discussing the past 3 days, but also when it comes to sexual health and perimenopause and menopause, to really take those things seriously so that we can take ownership for these things that our patients are experiencing. The next topic that I wanted to touch on is the product development when it comes to sexual health. Unfortunately, we've had extremely limited FDA-approved pharmacologic treatments for female sexual dysfunction. There are many arguments around the medicalization of women's sexuality that men's sexual health didn't face. And there are cumbersome monitoring and warning requirements for these patients and these drugs. The commercialization of these innovations is hampered by lack of healthcare professional training and coverage, as we've discussed, as well as the limited training about conversations around women's sexual health. And investment is needed across the chain of events to discover and bring promising interventions to market to answer these needs for our patients. But it's hampered by the lack of basic science, commercial adoption, regulations, and financial success of these interventions. So this next chart just kind of overviews that as well. So, you know, we might have an exciting moment where pharma takes a bet on a new women's sexual health intervention, but then unfortunately they're met with cumbersome FDA requirements, lack of insurance coverage, mixed adoption, meager commercial success, and then that further de-incentivizes private investment to go the FDA route. So then once again, we're finding, you know, other things pop up that are incentivizing those pop culture personalized services that are going outside of FDA and speaking once again to those patients' pain and disappointment. So the next slide is going to kind of go into the digital health aspect of this talk. And really, you can hear probably my frustration around sexual health for women. And there are many, you know, issues to tackle here. The first, obviously, is education. The second is this clinician time. And the third is getting the information and the resources that are evidence-based to the patients when they need it. And so that led me on my physician journey to create a platform, a digital health platform, to try to do those things in an evidence-based way. So the name of that platform is Rosie, and it was built around the biopsychosocial model, recognizing that sexual health, but also, I'm going to make a correlation to menopause because it's exactly the same. It's shaped by biology, psychology, social context, and education. And in order to address something that comprehensive, we have got to take it out of the hands of the 15-minute, if we're lucky, office visit with our healthcare professionals. We cannot expect that to happen in the office. And if we want it to happen in a way that is evidence-based and that can be monitored and overseen, then that's going to have to be off social media as well. We're going to have a place that patients can trust and that can be monitored for these evidence-based recommendations. And that allows for the framework to be integrated and for it to address certain, you know, aspects of care delivery that we were discussing in the talk before. The platform supported more than 9,000 healthcare providers across the United States, including 15% of US OBGYNs and more than 250,000 women in the country. And as I mentioned, the same whole person model can guide menopause management. We can think of ways to create ecosystems that are scalable, that can get patients and women the information that they need when they need it, and take the responsibility, as Dr. Fabian mentioned, out of the hands of the healthcare providers who are really, you know, just trying to see patients. In order to do this, in order to achieve digital health approaches in a responsible way, the funding has got to be aligned. And this is where things really go wrong. You know, a lot of digital health companies are funded privately through venture capital or otherwise, and pretty quickly things become misaligned because, you know, maybe the patient care or the patient outcomes are not at the foremost of the importance of the investors. So we really have got to figure out how to scale healthcare responsibly without misaligning incentives. We have to have clinician involvement from the very beginning. Unfortunately, this is not the case for many of these companies, and then they're trying to sort of rewire as they continue to grow. Digital health should support the ecosystem, and instead of creating further silos, which is unfortunately what's happened over the past few years, we need to create solutions that integrate the system to make it easier for everyone, including women and their healthcare providers. And as AI evolves, as Dr. Wong mentioned, we have to address bias, transparency, and data sharing to strengthen that trust and evidence quality, because otherwise, as she beautifully illustrated, things will continue to go awry in ways that we cannot foresee. Some recommendations would be to support both basic science investigations as well as large-scale prospective trials evaluating interventions for sexual function in perimenopausal and menopausal women. There are, several interventions that exist that need to be studied at scale before they can move forward. Another recommendation would be to convene an NIH working group with members to review definitions, instruments, and endpoints for sexual health research as defined by many professional societies and others to support further standardized investigation, so we can address these coding and billing issues so that they can be extrapolated into research, but also into market evaluation. If we are not capturing these menopause codes, if we're not capturing these sexual health codes, whenever we go in either from an insurance perspective or from an innovation perspective to try to capture the market, what could this possibly mean from an investment perspective? Those numbers do not align with the actual opportunity. And to create a national research consortium and data infrastructure. This network could link academic, clinical, and digital health partners to share anonymized data so that we can take what's happening in these individual places and combine them. But this would require that we are adopting a consensus framework to standardize that data across these groups. A key point here would be to give a designation and incentive for participating groups, because otherwise most of these private companies are going to opt out in the name of keeping that proprietary information to themselves. Another recommendation, as we've talked about ad nauseum, is to expand clinician training, but particularly to include sexual health as part of this conversation, to strengthen those FDA women's health specific regulatory pathways, including accelerated and flexible approval pathways. We have a lot of catching up when it comes to women's health to do, and we obviously all want to do that in a very responsible way, but it needs focused, undivided, and expert attention. And then also ensuring meaningful reimbursement for existing menopause and sexual health visit codes. As we have discussed, these are complex visits and they are important visits, and providers need to be reimbursed appropriately so that they will continue to invest in their own understanding of these things, invest in novel pathways to deliver that care, and invest in their patients' future and health. Thank you so much.
Thank you. Thank you, Dr. Harper. Now we have Dr. Levy. You may begin.
Thank you so much. And it's such a privilege to be here with all of these amazing people and all of this incredible research. I'm Chief Medical Officer at Visana Health, which is a 50-state virtual women's health company that was actually founded to try to meet some of the needs, especially for rural women. I'm also a consultant for Natural Cycles, which has a perimenopause app. So those are my disclosures. I was given a daunting task, which was to talk about policy and policy gaps. And I think one of the key issues here is the under recognition in health policies and inadequate support for resources for women. So Kaiser Family Foundation did a study, and what they found was that women's health concerns are deprioritized. They're not considered important. And when we look at the workplace, what we find is that women in their most productive time in life, or what should be their most productive time in life, are being hampered by menopausal symptoms. And so there's been a limited investment in conditions that are specific to women, and an underrepresentation of women in research and the decision making, which is part of the issue. Workplace support measures are beginning to happen, but there's a huge gap here. Many respondents describe a lack of support at work, specifically the stigma around menopause and around aging for women. It's a taboo subject, and without that support, women are reducing their hours, they're leaving employment. It's a huge cost to our healthcare and our workplace environment in general. So Catalyzing workplace support is really, really important. An overarching concept for all of this is follow the money. Dr. Harper just mentioned investment in innovation, but when we can't wrap our hands around what the true cost of menopause and perimenopause is, then it's very hard to drive the investment. Dr. Fabian mentioned $2,000 to $2,500 cost for menopausal women to the healthcare system in a year. Actually, in our company, we found over $3,000 in 6 months, with women going to multiple specialists to try to connect the dots instead of looking at women holistically. So there's very little education. We've talked about this over and over the last couple of days, and that limited knowledge limits policy, right? It limits the direction that policy will take. And therefore, there are a lot of gaps in reimbursement, gaps in payment, gaps in research, because we don't have the policy and we don't have the data to be able to drive the policy. And that's such a key issue. If we only have one ICD-10 code that describes both perimenopause and menopause, we're describing 10 years of a life course in a single ICD-10 code. And do remember that people only have to use ICD-10 codes to get paid. And so if they're addressing depression or anxiety, they may not use those codes. So there's no training of us in medical school or residency about how to use ICD-10, as Dr. Fabian so eloquently told us. So what about women's digital health? There's a significant underrepresentation in digital solutions. Women's health needs are often overlooked, and so there are fewer solutions tailored for women. When you look at femtech, so-called femtech funding, there's a huge mismatch between current digital solutions and the complex needs of women. And what you see when you look at the entire environment is a skew towards fertility and pregnancy, while areas such as menopause, but also chronic pain, which is much more significant in a female population, autoimmune disease, 80% female, these remain significantly underserved. Data privacy is a huge issue for women. McKinsey reports that data gaps in women's health burdens lead to underestimation of the market and underestimation of the social impact. And that depresses investment. Dr. Harper mentioned this. And innovation is very difficult to achieve when outside investors don't see a pathway to making money. So it really is follow the money. We do need targeted strategies. We need policy. We need gender sensitive technologies for equitable digital care for all women. And we need to be able to protect that data so that women feel comfortable using the technology. We have huge regulatory gaps, and we have heard this all morning, all day today, and throughout the several days. There's insufficient oversight. So because of the gaps in traditional healthcare and the lack of training of our providers and the lack of trust that our patients have in the care that they're being given, and frankly, they're feeling dismissed by us, they're seeking other things, right? They're seeking what's out there in the environment and social media. And so we've got supplements, we've got unapproved compounded hormones. We have many, many things out there that are potentially quite harmful, but there's certainly concern about the safety and effectiveness of these things. And women are flocking to them because they perceive that we are not responsive to their needs. There are huge unverified claims out there, and I think Dr. Gunter talked about this quite a bit, but FDA and FTC have struggled to police these misleading health claims. And that has created a huge black hole, a huge space for social media, influencers, people talking about scream cream and estrogen face cream and all kinds of products, marketing to a population of people who are desperate. They're desperate for care, they're desperate for help. And despite the fact that the professional societies have come out very, very strongly against and in opposition to the use of compounded so-called bioidentical hormones. Obviously, the bioidentical rubric it's a marketing term that's been around for years, and the safety is being promoted without any data to support that whatsoever. There are oversight gaps in terms of products in telemedicine. So some telemedicine companies are selling or prescribing products that are not approved by regulatory authorities, and that risks patient safety. It also risks service integrity. Dr. Harper talked about closing the loop or keeping this whole environment as a holistic way of caring for women. But when women are getting care outside of the traditional healthcare system, then there's no wraparound. There's no opportunity for her to get a comprehensive view of what's going on in her care. Claims of effectiveness are not based on valid clinical trials. So we do need stronger policies and regulations to protect our patients, to protect safe products, and to support industry in going to FDA. So if there's no pathway to making money and getting safe and effective products out there on the market, then that creates the gap for all of these other things to play out. There's also a lot of gray zone. So there's an overlap between wellness and medical device applications, and that creates a very unclear regulatory boundary, and it's quite complicated. And as a consumer, it's very hard to understand the difference between something that's permitted to be on the market because it's a wellness device versus something that's truly a medical device. And we saw that yesterday in the discussion about lasers and radio frequency devices for GSM, that it's not clear to the public what sort of regulatory approval or clearance has been given to many of these products. And that leaves the opportunity for them to claim an awful lot of things, just like supplements claim that they support menopausal care. They support the transition. It doesn't mean they care for it. These device companies also use language like that in order to promote often ineffective treatments. So that unclear classification makes it really hard to evaluate and approve digital health solutions appropriately, especially when we don't know exactly what it is we're treating. And that delays market entry for many of them. So we've already had quite a long conversation about ICD-10 coding, and I won't go into that, but the reimbursement systems are really a problem. So both providers and innovators really struggle to receive consistent payment. Partly that's due to the fragmented reimbursement system, but partly it's because actuaries and others in the insurance companies, they have no idea what menopause actually costs, because as they bucket things in women's health, they have a bucket for pregnancy, but they have not aggregated all of the different ways that women in menopause transition will be receiving care and costing the system. And then there's limited Medicare coverage. And I think Dr. Harper brought this to mind very, very clearly, that there's much better coverage for male-related conditions than there is for perimenopause, menopause, and female sexual disorders. So how do we solve all of this to try to bring it around to a more positive note? One is consistent data collection to standardize definitions. It's very hard if the definition of menopause is 12 months without a period, but somebody has a levonorgestrel IUD and hasn't had a period in 6 years, she's not menopausal. We need codes and outcome measures that make menopause research data more comparable and help to unify those things. We need evidence-based interventions, and we've talked about that for the last 3 days, so I'm not going to dwell on that. We need comprehensive health insights, and we've had a lot of discussion about randomized clinical trials compared to real-world evidence. We need to aggregate all of the evidence. We really need to combine evidence from digitals, from wearables, from EHR, from claims data, and bring that all together into a comprehensive view of the data. And then we need to get effective interventions to link that diverse data stream into targeted interventions that make sense. So menopause is an opportunity. It's a prevention opportunity, and we could use the digital technologies to really integrate the data. What we need is policy change to support proactive education, both public and medical education, and payment strategies to drive those policies, right? Things don't happen unless there are incentives in place to make them happen. So I think we need, and we've talked about this already today, inclusive stakeholder engagement to establish guidelines that gather a wide variety of stakeholders. That includes industry, innovators, digital health companies, EHR companies, advocacy groups, researchers. Bring us all together so that we can integrate the evidence and look at equity, adaptability, and create guidelines based on a much more comprehensive view of women's health. So my key recommendations are an inclusive health definition. Let's all agree on what we're going to call perimenopause and menopause, diverse stakeholder engagement with broad data input, absolutely advancing medical education, both of the medical profession, but also the public, and much better regulatory oversight of what's out there currently. And I would propose that we think about creating something like a national comprehensive women's health network that brings a broad alliance of stakeholders together, dedicated to data-informed excellence in preventive health and care for women. We can combine real-world evidence, digital technologies, published and high-level data to be able to build algorithms that are effective and include what's important to the people that we're serving. And then recognize the need for increased funding for the research into perimenopause and menopause and how they impact health and well-being across the lifespan. And I thank you very much and really appreciate the opportunity to participate.
Thank you, Dr. Levy. Our next and our final presentation for this session is the etiology of online medical misinformation, presented by Dr. Jevin West. You have the floor, Dr. West.
Thank you so much. There we go. Perfect. Thank you to the organizers. Thank you all for hanging in there for this last bit of the session. So I'm going to talk about medical misinformation more generally, but try to really bring it close to this issue of menopause. I've spent the last probably 10 to 15 years studying this issue, mostly online, but also offline in many different respects, using computational social science methods, using mixed methods, qualitative methods to try to understand this problem. And as you can imagine, it's a very, very challenging problem. And where I focus most of my efforts on this issue of misinformation is around health and science. I have, here's my disclosure statement. I have no information to disclose, no financial interests, and doesn't include any discussion of unlabeled use of products or under investigational use. All right, so there's been a massive upsurge of research on misinformation over the last 10 years. And I've been a part of that wave as a researcher, a reviewer, a consumer of this information, of course, as a teacher. And there are some things that we do know. There was a report that I was a co-author on for the National Academy of Sciences, Engineering, and Medicine. It's a NASM consensus report. I recommend for those interested on this topic of misinformation in science and health issues to look at that report if you're interested in incorporating some of these ideas it does, as good a job as you can in a year or two's worth of work to try to figure out what we know and what we don't know. And there is a lot more that we don't know, of course, but there are some things that we do know. This is a growing problem. There are certain things about interventions that we know, which I'll mention. There are certain things about what kinds of design and algorithmic modes you could use for addressing this issue, but there's a lot more research gaps. And of course, there's way more than I'll list here, but I just want to mention a couple. And one of them is that we don't know a lot about exposure. So that is the kind of information that lands in your individual post. And we don't know whether the individual consumer of information has read that, what it does to them. And so there's work going on right now to try to get at that individual level exposure, but it's very difficult. And that's a very important link that we have missing. Another thing is we really don't know the aggregate effects across the many different media channels. Most of the efforts that have been pushed forward over the last 10 years or so have been on social media because it's easier to get data, or used to be easier to get data. It's not so easy anymore. But we need to do a lot more work on television, radio, podcasts, etc. And so there's lots more on the media channels. And there's many other kinds of gaps as well. But I just want to really emphasize that we do know some things, but there's a lot we don't know. But I do want to mention the one thing that we do know, especially as it relates to what we're going to talk about today, is there are a lot of studies in individual labs, in real settings, that look at different ways of correcting information and just strategies to teach the public to become better consumers of information. Things like lateral reading. That's this idea that we need to teach consumers to open many tabs, to look across many different sources as a way of corroborating evidence that they think they have found. Accuracy nudges, friction, things like that are effective at the individual level. The main point is there are corrective measures that seem to be helpful in some ways. But we also have to be very careful in our current environment, given the need to protect people's freedom to be able to post information and then to read the information that they want. So this is always going to be a sticky, challenging situation, but there are things that we do want to correct that are obviously incorrect, according to experts around things like menopause. I do want to start with a definition, though, just because when you talk about misinformation, it's important to come up with definitions. It turns out it's really hard. In fact, most of my studies now look at just studying disagreement, agnostic to the particular issue at hand, just looking and understanding the ways that people disagree, because I want us as a society, of course, to disagree in a healthy way. But it's hard not to avoid at least having to talk about misinformation and disinformation. The big difference there is that misinformation can be misleading information. It can be information that is accidentally posted or is well-meaning but incorrect, at least in this case, inconsistent with the weight of accepted scientific evidence. And one thing that we really emphasize in the report is that these things, the statement can change based on new evidence. That's how science works. We really want to emphasize that. But when we say misinformation at the time, it counters at least the weight of accepted scientific evidence at the moment that you study it. Now, disinformation is a whole different ballgame, and that's when there's intentional efforts to mislead, whether through financial means or propaganda, fraud, etc. These are the kinds of things we also look out for, but it is a different beast than misinformation itself. Now, as I mentioned early on, we are seeing a rise of misinformation online, especially with new technologies in front of us. Large language models and other things have just exacerbated the problems that we've seen on social media. And I don't see this problem going away anytime soon. I think this is going to continue to be a problem, and it's been an issue throughout the discussions over the last 2 days, I think, for this particular workshop. So we all know in the medical community, and also for those that study this, that this is something that we're going to have to contend with for a long time, and it's especially highly consequential in the medical space, and specifically on menopause. It's an interesting area of study for, like, my group, for example, because there is such a vacuum of information. There's a lack of proportionally, there's not as much of the good information as we want compared to the information that seems to be flooding this area because of financial gains that can be made from companies that are using this moment to take advantage of this. And so we need to recognize that menopause in particular is a vulnerable issue for the public because there's just not that much information. And so this is where we really do have to lean in anymore. It's not just because of algorithms and other things. And I found this one humorous. So this is actually a screenshot I took from Gemini, just to show you how much Gemini even knows that it doesn't know anything, yet it continues to tell me all sorts of things about things like menopause. It says here, large language models, including Gemini, this is a screenshot from Gemini, show that Gemini gave incorrect answers to about 40% of menopause-related issues. The error rate was higher for questions aimed at clinicians than those for patients. And it goes on, saying all the ways which, and telling the public, please don't listen to me, but here, listen to me, because I'm the first thing that lands on my Google slide. So this shows where we're at right now. At least these LLMs have a hard time hiding their own flaws, and they can reveal them just with their own snippets. But that's the state that we're in with LLMs. And what's interesting about the rise of LLMs, my PhD students and I and colleagues have written many different posts about how search is changing. And one thing we emphasize is that LLMs are not, they're not how most information retrieval researchers would define search. And yet we're using them now as our default search engines. And it doesn't mean we can't use them to some degree as a tool for search, but they're really problematic for many ways. And I'll mention one. One of the things they optimize is semantic similarity, not accuracy. So what happens is that you will often get medical advice that describes the whole medical conditions fairly well, not completely off, but it's doing a good job there because that's what it's optimizing, but then gets the important part wrong, whether you should take this particular pill or not, or whether you have this condition or not. The binary of yes or no is not something that it's optimized for, at least at the core part. Now, when you do reinforcement learning and other things, you can get to that, but it's one of the many reasons we have to be careful for using them as default search engines when it comes to medical advice specifically. I'll give some examples. So I've spent, like I said, most of my career in sort of the darker corners of the internet, studying the ways in which rumors get amplified. And by the way, some rumors can be true. And I always tell the public this when I talk to the public more generally, rather than medical experts and researchers, that sometimes rumors are true, and we have to be aware of that. And it's not that they're bad things, but we have to recognize the kinds of dynamics that surround rumors in particular. So what can we do about it? Well, we can, I have this center that I co-founded with my colleagues where we spend most of our time working on this. And there's a whole bunch of things that I wish I could tell you if I had an hour, but I only have a few more minutes. So I just want to go through some quick 5 lessons for online medical misinformation in particular. And one of them is that there's infinite evidence on the web. As researchers, we really look to evidence-based decision-making. We look to evidence. That is the thing that we're always striving for. And consumers have gotten better at that themselves. They do their own research. And I encourage that. I want people to do their own research. But the problem is there's infinite evidence, and you can always find an answer to anything on the web. In fact, we have this game in my class where we say, come up with a question that Google won't give you an answer to. It's very, very difficult. So we want to change that conversation when we're talking to patients in the public and ask them, how did they come about their evidence? How did they compare that evidence to something else? Basically a conversation about epistemology. Of course, we don't use the word epistemology, but we want them to change. We want to change that conversation. And just to give you an example, I asked kind of, one of the more preposterous kind of questions about menopause, is it contagious? And so would I get anything on Google that would even address this? In fact, yes, this was just a few days ago. Like the very first one that comes up here is that there had to be a website that mentioned, not just this, but other things, that menopause is also not contagious. Now, that's where we're at, is because there's essentially infinite evidence on the web. And when we talk about evidence, by the way, there's so many different typologies. We've been studying this for a long time, and there's way more than even I've listed here in this slide. But we have to recognize that too when we engage the public, that it's not just the scientific journals that we're dealing with when we're talking about evidence or a study. We're talking about unsourced science, self-published science, podcasts, government science, and they all intertwine in different ways. And I think trying to understand that is an important step in addressing this. Now, one of the things that we do know is there's always going to be a trope. There's lots and lots of tropes about all these different issues. So what do I mean by that? That's the kind of trope that you see in a movie that comes every time like a bomb. Well, we see that all the time, whether it's a hurricane. So there always is going to be an image of a shark swimming in the street after a hurricane. I can guarantee it. Pay attention to it in the next hurricane. You will find rumors about sharks swimming in the street. And we see the same thing with medical misinformation. And what that tells us is that we can pre-bunk those rumor tropes, or at least make those aware to the public so then they can take that into context. They see it again. And when that happens, we need more than just fact-checking now. Fact-checking isn't enough. We need better frames. And so when, for example, with menopause, a kind of false narrative that we've even talked about here and that I've seen in looking at this more in the studies is that it's a sort of menopause is equal to decline and deterioration. The false narrative here would be that menopause marks the beginning of physical, cognitive, and social decline, essentially this downward slope in health and vitality. And it sticks because of this narrative about aging and especially gendered aging. So the strategy here would be not just to fact check everything, but to come up with a better narrative. For example, menopause is a physiological transition with heterogeneous outcomes. And we talk about this phase change and endocrine function, and risk increase of bone density and things like that. And many report, all sorts of different kinds of findings, but we need to change those frames. That's more effective. And then I'm almost done here. And then also lean into expertise. One of the things we have found in our studies on various different medical issues is that, let's say, groups that are maybe counter to some of the consensus, it's not that they don't like experts. They very much appreciate experts. And that is something that's, I think, a misinterpreted narrative within the research community and sort of the community of maybe the actual experts. So we think, oh, those that are counter-narrative don't believe in experts. They do. And we have many studies to show that they just are hesitant for the various reasons that I've mentioned before. And then the last thing I will say here is that we need medical training for patients, for sure, and we need better information out there, but we also need it for doctors. I've realized over the years working now more with the medical community is that I think doctors are busy, medical professionals are busy, and I think we can do a better job in helping them understand the kinds of dynamics that exist, the different platforms, the different kind of affordances that exist on these new like information technology platforms in general. And so I'll end here by also saying that, for example, I'll just say that most of the people don't know about these 3 dots. These are just so many design interventions to help people identify misinformation. It's something we pushed Google to do. It took us many, many years, but now you can click on 3 dots if you go to Google and you can get metadata on a website. So you can see, did it just get created a few days ago? That's not a good sign. It can give you information about these things. So here's North American menopause. You can click on that, and you can do that for that shark swimming in the street. And if you click on that on the images, you find these 3 dots that it's been debunked many, many times in the past. So with that, I would say we do, of course, need to lean into better education for medical professionals and patients. And then my recommendation here, among many, of course, is that it would be really helpful as someone a little bit more outside the field of menopause, and I'd be happy to help as a researcher, so please reach out, how we can identify these rumor tropes specific to menopause, how we can help try to come up with better frames, and how we can come up with resources for improving. So lean into that expertise, build better frames, pre-bunk those rumor tropes, and be aware of that infinite evidence. And with that, I'll end. Thanks so much for listening, and I think I'm turning it over to the moderator.
Thank you, Dr. West. Round of applause. We see a lot of applause for you. Thank you to all of our speakers. I'm going to invite you to turn your cameras on at this time. We'll now transition into the discussion moderated by Dr. Wong.
These were such far-reaching and fantastic talks. And so thank you everybody so much for being here. Dr. West, since you are just fresh on our minds here, I want to start by coming back to one of those pieces that you mentioned, this idea of around better frames and not really just better facts. So, recognizing that there hasn't been research specific to menopause, and also recognizing, I think that inherently, as we'll kind of come back to on the data piece, this is a space where the evidence is fairly incomplete and the evidence is inherently evolving. So it feels like a degree of well-intentioned misinformation is inevitable. how do we reframe these menopause conversations like tomorrow? Like I'm gonna, not me, but somebody's gonna see a patient tomorrow. How do we build that frame tomorrow so that we can share sort of accurate information that'll actually resonate with patients?
Well, it's a great question. And by the way, you started off this session so well, the way you summarized it. So thank you so much for that. Building effective frames takes time, and it evolves like evolving evidence. And so as much as I'd want it tomorrow, and I would for sure, I think it would take some time to come up with what some of those frames are, because if they do stick, they're incredibly effective. This has been shown in many different contexts outside of medicine, certainly in political realms and propaganda realms, but even within medicine. And so I would say, if you force me to say, okay, Jevin, you have to have it by tomorrow, I would start with something, I had given this one example here, a replacement narrative, to counter the sort of decline and deterioration false narrative that exists on this issue, is that menopause is a physiological transition. So really talk about that transition with heterogeneous outcomes. Now, there's other things that we could sort of address on false narratives, like all women, for example. I think this is one that I'm starting to see too, is experience menopause in the same way, and trying to say it's highly variable. So all the messaging comes there. So then as the evidence evolves, as you say, as it comes in, because it is an evolving landscape, just like science is, then we can take evidence and we can fit the different evidence into these different narratives. And so I think what we have found is that by doing that, you actually get like collaboration from the public, because they see those narratives and then they have something to look for, rather than being stuck on these false narratives and then finding evidence to fit those. Because as I went through that slide really quickly, but when we have these frames, it's just by nature, we fit evidence into those frames. And so when we're looking for new evidence, especially if it's a false narrative, and we find evidence that fits into that frame just gets more and more stuck. So I guess my point here is that we do need to take time. I have some ideas but I would really want the experts to come up with the correct narratives, and then focus a lot of effort on that. And then the evidence that rolls in seems to be more effective. But anyway, I'll just stop there, because I want to allow others to chime in.
Yeah. I'm going to borrow from actually the point that you made around the heterogeneity of the experience of menopause, and sort of swing back to one of Dr. Fabion's points. I was really intrigued by the data that you shared, that I think only about just over half the time was there agreement between clinician and patient regarding even whether the patient was menopausal or what stage of menopause they were in. And so my question is sort of, how do we reconcile this appropriate broad push of centering the patient reported experience with data suggesting that their description may be uncertain or inaccurate around their menopause stage? What do we actually sort of conceive then as, from a data standpoint, what do we conceive as a ground label truth?
Gosh, I wish I could answer that question. I think we kind of have to look at this from two different directions. So one, I think for patients, does it really matter if they're peri or postmenopausal women if they're having symptoms and they're bothered by them, right? So it doesn't mean that we can't treat them if we don't know exactly if they're peri or they're post. It might matter if we have to use contraception, for example. But so I think from a patient standpoint, does it really matter, and does it have to be defined? Probably not. From a research standpoint, that's a different scenario. And I think as researchers, we need to be able to figure out what is happening during that perimenopause timeframe. We already know so many changes are occurring during that time. I think it's much more critical for us to be able to look at these big data sets. And we're not going to have laboratory tests on everybody. So the answer is not that we go get an FSH and an estradiol level on them. We cannot do that. We're going to have to figure this out in a different way. And we're going to have to set some sort of big data criterion for being able to determine if a woman is in the transition or not. And I think it's going to be different from what we've used in the past. We've used the straw criteria for many years. And I think when we look at big data criteria, it's going to be different. But I don't have the answer to exactly what to do with that yet. I wish
So
I did.
I do think that wearables will help us to some extent. There's a lot of data that we can collect, both self-reported, but also some physiological data that we could incorporate into our research and our definitions. I think those will be useful and helpful. Recognizing, of course, that we're seeing a skewed sample of people who can afford those things. So that's a really important caveat. I think the other thing that's really important is that the symptoms that people experience are sort of a final common pathway to many different physiological conditions. What she may have is prediabetes and not any disruption in her sexual and reproductive hormones at all, but the symptoms seem to her like they're menopause. And what we're seeing is a lot of mistreatment, because if the only tool you have is a hammer, everything's a nail. So everything's being attributed to perimenopause and menopause when it may not be.
No, that's such a
100% agree with that.
Yeah, that's such a great point. So to swing that, then I think also, Dr. Harper, you have such a great insight on particularly the patient voice in this. So how do we sort of reconcile, and I think as Dr. Levy is also alluding to, like the data that can come in from these sort of direct to consumer platforms, whether it's wearable data, whether it's sort of directly from a patient voice, or how do we sort of reconcile that, in your head with the clinical data, especially in the context where they do very likely represent really different patient populations, really different behaviors, different degrees of engagement. If you're able to buy an Oura ring, you're a different patient than 90% of the patient populations. If you are, downloading an app about menopause, you are just inherently, more mentally engaged with your own physiology than, the average person. Sort of. I think you mentioned a consensus framework, in your talk. What does that sort of look like to you in reconciling those?
Yeah, I mean, it's such a big question, obviously. I think that, the easiest way to start to, and I wouldn't say it's reconcile, but to start to walk in that direction is for companies to publish the data that they have and to share that with these communities at large. I think it's challenging because, once again, when the companies are incentivized in one way, sometimes those efforts may get stifled because they are not contributing towards profitability in the minds of the powers that be. And so that is why there does have to be clear incentivization by the community at large to say, hey, if you share your data in these ways, that we would have to spend a lot of time deciding what that looked like, or if you are willing to publish and help us to add to the greater body of knowledge rather than keeping it all to yourself, then you will be incentivized appropriately. Whether that is a mark from a professional society or a mark from the government in some way, like, hey, this is an approved organization that protects and shares data responsibly, right? There need to be ways where we can organize and communicate that incentivize these companies to do so in that way, because it does exist. I mean, I will speak for my own company. I think we probably have the largest data set that is available in women's sexual health. Have we ever been capitalized in a way to share that effectively? No. And, what are the ways to go about doing that? Applying for grants? Well, guess what? That requires personnel to write those grant applications and the sustainability to get to the end of those applications and through the projects themselves. So there's a lot out there that is sitting there waiting, and that needs to be activated appropriately.
Such great points. So I believe we actually do have some questions from our independent panel. So I will turn the mic over to the panel, please.
Why don't I start? Hi, I'm Cheryl Anderson, the moderator of, well, not the moderator of session, the chair of the panel. And I know that we also have questions from Dr. Shelley and Dr. Wellness, and so I'll kick us off. This was a brilliant set of presentations, and so thank you all so very much. I'm struck by the repeated theme around data collection, and I really love the distinction made. I think it was by Dr. West, about data that we need for patient-centered care and data that's needed for research. And my question for you, as the panel think about next steps, where do you see opportunity for data harmonization and data collection in both of those spaces? I offer this to all of you, but perhaps Dr. West, you could start.
Well, since I know this area less than my fellow panelists here, I may push that to them about where the opportunities are specifically to this area. I can speak to some other examples in other areas of medicine, but maybe I'll start with my panelists because they'll have a little more knowledge about how to do that, because I think it's a really important question that we should definitely address.
I don't know if I count as a panelist or not. I'm just going to jump in for fun.
Yes, you do.
I would say that in general, in any sort of data collection space, particularly whenever you're talking about model development, the general rule is that the closer that you can get to less of judgment and more of proximal to objective data, the better. I.e. that if you, a wearable, for example, obviously you take into account like subgroup analyses for like those who do and don't have access, but that is fairly objective. Once you get to a direct, like a lab report, again, fairly objective. Once you get to symptoms assessment, more objective, but you are still like there's one sort of step removed. And then when you get to clinician assessment, you're really getting out into the weeds. And then once you get into administrative data, i.e. what oftentimes gets grouped into real world evidence, I always say that that's just like the best branding ever, to call that real world evidence, since it is about as far from the real world as you can get and much closer to my vibes of what happened and whether or not I'm going to get paid more if I write down my vibes of what happened. I would say that, as we approach the data, we have to take it at that granular level. And then the size of the grain of salt sort of correlates to how close we were to that most upstream of data.
Yeah, I couldn't agree more that administrative data, which is what claims data from insurance companies, is so flawed that it's what we choose to code in order to get paid. It doesn't really tell us anything specifically about what's going on clinically with the patient. And I see this in training my own nurse practitioners. Like, they forget to write that the patient's obese. They forget to write, in their list of ICD-10 codes, they forget to write about the bipolar disorder that's complicating the patient. So if all you have to do is create one code in order to get paid, the likelihood that you're going to include very granularly all the things that are going on with that patient that holistically come together, I think is very, very low. So I couldn't agree more that we need to be able to capture clinical data, patient-reported data, wearable data. I mean, it's a daunting task, but we have to stop looking at things like administrative data, because I think they're more obfuscating than helpful.
All right, and thank you very much for your responses. I'll invite Dr. Shelley.
Hi, my video is not working, so thank you so much. That was incredibly interesting and helpful. My question was really about how do we communicate the limitations of AI and sort of to our patients. The data is confusing, which is why AI is confused, and sort of other search tools to empower patients actually to manage their own care and also come into their doctor appointment with knowledge or questions that they want to ask ahead of time. So how do we support patients that way? Are there AI literacy or these kinds of literacy programs for patients that are growing or beginning? And because I'm concerned about sort of the increasing gap and increasing disparities in terms of access to knowledge as these fields evolve. So yeah, just wondering if someone could address that question.
I can jump in on that because I have some courses that I've developed that are free to exactly address this. I can put the website in here. Let me see if I can post it after I make this response. But my colleagues and I are developing free resources to help the public try to understand where these things are useful and where they're not. In fact, the title of the course is Modern Oracles or BS Machines, because they're really good at BS because they don't have labels to the truth. I mean, philosophers like Harry Frankfurt talk a lot about what a BS era is, and they're quite good at that. I can post that website, and also we're going to be developing specific resources for things around medical issues as well. But I'll just mention a couple really important things. One of the reasons they're so engrossing and they've really just taken over, I think, and become kind of default search engines for a lot of people on their phones and on computers, is that they are anthropomorphic. So a lot of people talk about being careful not to anthropomorphize these, and that's true, but they are already anthropomorphic, meaning they are already human-like. It's very difficult to tell behind a closed curtain whether it's an AI or a human in many ways, because they are, and there's studies that have shown this, more persuasive and better at character switching, et cetera, and all these kinds of things that make it difficult. In fact, they have passed the Turing test, which is a test by computer scientists. This has been this tough test since, for half a century, and they passed it because they're really good on the communicative side. So we call it, they're seductive. There's this anthropomorphic seduction about them, and we need to teach the public about what that is and what they're really good at. And then the other thing is very specific things about how to utilize them as search, and really to not sort of downweight the effectiveness of those blue links that we get in the old traditional search. I can't believe I'm even calling it old traditional search of Google, and even prior to Google, that we need to help patients understand the difference between sources. And sources are really what they're after. Yes, you can get started with a conversation with an LLM and come up with maybe the search terms and get started in figuring out what you're trying to ask to help narrow that question. But ultimately, we need to teach them to go to the kinds of primary sources that are going to be more reliable. But I will post in this little link just one of the free courses that we have. We have many of them, and we're going to be adding more, but this will get you started. I don't know if it'll get posted out, but I'll post it here.
I think one of the challenges is the lack of trust in the medical profession that's really accelerated since COVID. Our collective lack of humility has driven people to trust influencers more than they trust us. And so even when we present to them a trusted source, that's problematic.
And it seems like we should have more information about perimenopause and menopause than we actually do. So when we come back and we say we don't know, that's a discouraging answer, and they think that Gemini or ChatGPT are going to know more. I've had patients actually come back to me in the patient portal with what is clearly derived from a chatbot in some way, and it's the solution for what we have been struggling with clinically, over the last couple of months. But they think they can find the answer there. And, we just published on this recently about the inaccuracy of LLMs for menopause management. What it does it answers yes, no questions well. Like, is this a symptom of menopause? It can do that. What it can't do is complex decision making. And where it routinely failed was if you give it a mishmash of a complex person coming in and saying, for example, should I use hormone therapy? You could bury in there an absolute contraindication to the use of hormone therapy, and it would miss it in the whole mishmash of other symptoms. And then for perimenopause, it completely flailed. You know why? Because we don't have any guidelines out there on perimenopause. So it has nothing to search. So it's just going to make it up. So I think there are a number of reasons. And part of it is because we have an incomplete set of knowledge about menopause and perimenopause and what to do for women.
And I think, Dr. Fabian, to your point, they don't, like when patients come to us about perimenopause, or say, the medical community generally, and we say we don't know, but the LLM says, here you go, here's answers, except for it doesn't know. So there's the perception difference we're really struggling with. But I think the data that you present, Dr. Fabian, about measuring it against actual, algorithms and processes of care is super helpful to communicate to patients.
I think it's the LLM's social desirability bias that as physicians we seem to lack. Sorry.
Yeah.
And then I think we have one more question from the panel, so I'm just going to interject for that. Dr. Walunas has a question.
So first of all, thank you all. It's fascinating to listen to all of you. So full disclosure, I'm a medical informaticist. So when the moment you all started talking about ICD codes and how good or bad they are, that got me starting to think. And so the question I have, and I think probably all of you could address it because you raised it almost all of you raised it in different ways, is I totally get ICD is horrible as it is now. Even ICD-10, which was supposed to be much better than ICD-9. But what I would love to hear is like, how could we make it better? Or can we? I mean, because what I would love as somebody who loves EHR data and would love to be able to do more with it to hopefully make things better for patients and clinicians as they're doing their work. Like, how could we adapt it so that it could be a better tool? And that's probably the first part. And then if you have a few moments, I guess I'm also curious about what other data standards y'all think we might need to make the data source better.
Yeah, Dr. Santoro wrote, break down N95.1 into multiple subcategories. Absolutely, we need to know the phases of perimenopause. We need to know distinct perimenopause from menopause. The fact that there's only one code and it brings everything together, whether you're 44 and early premenopause, perimenopause, or you're 56 and postmenopause, that's definitely problematic. But I think that my problem with using EHR data is that whatever's entered there has already been filtered through the brain of the clinician who's writing the note. And that's where patients' perceptions are dismissed, right? We've already filtered out those things we don't think are relevant, and yet they may be incredibly relevant to her experience of perimenopause, menopause, or any other condition. So that's my problem with using EHR data, is that it's already pre-filtered by the clinician who wrote the note.
Well, unless you get to things that are a little more objective, like an electrocardiogram is going to look different in a woman who has hormones versus a woman who doesn't have hormones. So I think you can get some objective data from the EHR that is not opinion. I totally agree with it. You're only as good as the person entering whatever it is. If it's an ICD code, then you have to have a clinician who actually can recognize menopause or perimenopause and put it in there. So I don't think that's ever going to be perfect data, but I think in combination with words that, for example, end up in a clinical note that maybe a patient mentioned that end up in there, that's going to help with the appointments that they have with the cardiologist, with the ECG, with CT data that we can get visceral fat measurements on. I think we're going to be able to put this together that way. But if you're relying on people to input data, it's always going to be problematic.
Hopefully the new era of audible AI will change that a little bit too.
I agree.
I think part of what bothers me a little bit about it too, though, is that there's inherently like sort of a temporality problem to it. And this, I mean, honestly, in analogy, the same way there is with pregnancy, right? Like you might call your doctor and let him know you're pregnant, but like you don't actually know it from the moment that you're pregnant. And sort of the same for menopause, where you're even less likely to call your doctor and be like, hey, just so you know, I believe that my FSH is rising, and then call them like months to years later and say like, I just want to let you know I had my last period. Go ahead and drop that in my chart. Here thereafter, do note me as postmenopausal. Right? It's just not a thing that's going to happen at an EHR level. And like from like a columns and rows standpoint, right? We would want all the rows thereafter to now like flip from 0 to 1, and they won't. So I think there's a part of that just sort of inherently worries me about the EHR for menopause as a problem. Not that it's a problem, it's transition, but for using it for diagnosis cuts.
All righty. Were there any other comments from you, Dr. Wong?
No, I don't
No,
believe
just
so. I just really want to thank this panel. Just such a wonderful group of speakers, and what like an invigorating way to end sort of our formal speaking general sessions. And excited for the closing.
Thank you. Thank you
Thanks so
all. Round of
much. Thank you
applause.
so
We
much.
really appreciate it. Our final session is a roundtable on what we learned. Our closing session on what we learned, what comes next. Moderated by Dr. Sarah Timken, with a fabulous lineup of invited discussants, including Annette Santoro, Karen Giblin, Genevieve Neal Perry, and Melissa Wong. Dr. Timken, please begin.
Hi, thanks everyone for having me here today. And I just want to start this session by really congratulating the Office of Disease Prevention on putting together what's been really truly outstanding workshop. And I feel very honored to be here to moderate the summary and closing session. It's been really affirmational and nourishing to my soul, really, to be in this virtual room with so many people, not just sharing insights into where we are with menopause research today, but imagining where we should be. And so I don't know if I can have my slides. I don't see them. I have a few comments to make to start.
Catherine, can you advance the slides?
She has control.
Okay.
I'm happy to advance.
Yeah,
No
that would be
problem.
great. Yeah. Thanks. And then the next slide. So we've had so much conversation, and a lot of it over the last 3 days has been around the Women's Health Initiative, and this is for good reason. This trial is still today the largest NIH-funded study to ever be explicitly centered on a women's health need. And what makes it even more remarkable is the fact that this trial started enrolling patients in 1993. And this was the same year that Congress mandated inclusion of women into federally funded clinical research. So the next slide. So in the early 1990s, really, to get this kind of a project off of the ground, we needed a champion. And that really was Bernadine Healy, who was the first NIH director who was a woman. She courageously took on the cause of menopause research and assembled a team that included Vivian Penn, who was the inaugural director of the newly formed Office of Research on Women's Health. And when she went to Congress in 1991 to gain support for this initiative called the Women's Health Initiative, she called this a moonwalk for women. And I think this framing is really something to think about today at the end of this workshop, because this represented menopause research as something courageous that required coordination, and it also required sustained investment. And most importantly, I think in 1991, this conveyed how just simply researching women's bodies was a new scientific frontier. The next slide. So in the 20 years since the intervention arms of the Women's Health Initiative were terminated, a lot has changed about menopause research and the delivery of menopause care. And we've heard about that over the last few days. Estrogen is now delivered transdermally. IUDs can put progestins right into the uterus. And there are newer non-hormonal therapies that are available to treat symptoms of menopause, particularly vasomotor symptoms. And what was initially a dramatic decline in hormone prescribing that happened after these results were made public has changed course. And in the last few years, we've seen this really pretty dramatic rise in prescribing of hormonal therapies. The next slide. Over the last 3 days, we've also heard a fair amount about not just the volume, but the heterogeneity of symptoms that women experience throughout the menopausal transition. And so these variations in prevalence, although they are associated with social and demographic factors like race, ethnicity, education, socioeconomic status, my big takeaway from this is that menopausal symptoms are common. And according to this study that I have up here, nearly all women, almost 90% of women, experience at least one symptom of menopause throughout the transition. The next slide. We've also heard a little bit about some of the symptoms that are really overall stigmatized, like abnormal uterine bleeding. Oh, sorry. Oh, can you go to the next slide? Sorry. I went backwards, and then I'm going to ask you to go backwards, unless I can control them now. No, I can't. We'll go here. We'll start here. Although these symptoms are the next slide. Sorry about this. Although these symptoms are very common, we see from this data that very few women, and according to this one chart, less than about 5% of all women ages 45 to 64, so those women who are in the midst of the menopause transition, are receiving treatment. And then the next slide. We've also talked a little bit about some of these stigmatized conditions that occur during the menopause transition. And so I want to give some kudos to the SWAN investigators who captured, these very high rates of abnormal uterine bleeding that occur during the menopause transition. They're as high as, 90% of women experiencing at least one abnormal bleeding episode. And it's really striking how little we talk about the symptom and how little data exists on the prevalence or treatment patterns for this almost universal thing that happens. And as we heard in the evidence review for KQ1, there's essentially no evidence for the effectiveness or harms of treatment for this and many other common symptoms. The next slide. When we start to put together this lack of evidence and the lack of availability for treatment and treatment for something that's just so common, I think this really reflects the reality that today the experiences of women continue to be minimized and dismissed. We have heard repeatedly during this workshop about the lack of consistent definitions, insufficient data, gaps in care delivery. This idea that a lived reality goes unacknowledged in broader society is what the philosopher Miranda Fricker defined as epistemic injustice, a wrong that is done to someone in their capacity as a knower. And I'm always struck when we discuss this topic how we do talk about menopause as a physiologic normal transition, but we don't have words or language to describe abnormalities in this process. And this lack of language is really a subset of epistemic injustice that's referred to as a testimonial injustice. The next slide. Our current research systems really reflect this mismatch between the health needs of women and our priorities. Last year, the National Academies published this report on the status of NIH research on women's health. They found that a small minority, only about 8% of the NIH budget, is directed towards women's health research, and that percentage has been declining over the last decade. When we look separately at what the NIH has reported for spending on women's health, we can see that in FY24, which is the most recent available data, 7% of the NIH budget went towards women's health research. And Dr. Dutta mentioned in her opening the very, very small percentage of money that goes towards menopause research. It's 0.1%. You can hardly even see it on this slide. If we want to close some of the evidence gaps that we've been discussing, we're just going to simply have to do more. The next slide. If we want to make progress in our understanding of the menopause transition, we may need to shift a little bit the way that we think about researching women. Over the last 30 years, our research agenda and policies have really focused on inclusion. In 1993, the NIH Revitalization Act mandated inclusion of women into clinical research. If you could click again, it was 2016 when the sex is a biological variable policy encouraged inclusion of female preclinical models into basic science research. And these are important steps that had to be taken. But this week's workshop at least to me, really revealed some of the limitations of a women's health research agenda that's focused on including women and female mice into research, and then using that data to identify and what's different. The next slide. If we really want to understand the physiology and pathophysiology of menopause so that we can design interventions that alleviate suffering, we need to understand what is unique about the female hormonal, physiologic, genetic environment and how those things influence the health of women. The next slide. Oh, next slide. Women are not small men. And simply comparing them to men is an insufficient framework for how to do women's health research. To truly advance women's health, we have to invest the time and energy that's needed to understand female-specific biology. And I actually think this is what Bernadine Healy had in mind when she penned this piece in 1991 in the New England Journal of Medicine entitled The Yentl Syndrome. This was really the goal when the NIH initially designed the Women's Health Initiative. We wanted to understand how estrogen and progesterone influence long-term risks of chronic disease in postmenopausal women. The next slide. Menopause is just one window of opportunity to change the health trajectories of women as they age. Bone loss accelerates, cardiovascular disease and cancer risk rises, cognitive shifts happen. But to understand menopause, we also have to understand what happens before menopause in women during adolescence and young adulthood. We heard this week a little bit about some of the shared pathophysiology between PCOS, endometriosis, premenstrual syndrome, and the symptoms that women experience during the menopause transition. These are shared biologies that have to be investigated. And to understand menopause and aging, we have to pay attention to the entirety of the female life course. Otherwise, evidence gaps start at menarche, they accumulate during pregnancy, and then they build upon each other during the menopause transition. And we just continue to see that women spend larger percentages of their life in poor health than their peers. The next slide. So that's really my main points, but this is just to open up the discussion. I just want to encourage everybody. I think we still can have a moonwalk for women and menopause. Essentially everything in this space remains an opportunity. And I've just outlined a few thoughts on this slide about what the research agenda can look like. We need to understand the risks that lead to symptoms in the menopause transition. This includes an understanding of normal and abnormal functions of the gynecologic organs. We can innovate around how we diagnose menopause. There has to be a better way to diagnose abnormalities than retrospectively assessing menstrual history. We can create clinical trials with capacity and expertise to study effectiveness, comparative effectiveness, and safety. We have to support implementation of best practices, which may require novel care delivery models. And lastly, we just have to evaluate long-term outcomes of women with varying experiences across the menopause transition. And that's it for my slides. So I just wanted to now encourage everyone in the audience, on the panel and in the audience, to think big and be courageous. And I'm going to start by inviting my co-panelists to join me in discussing what we do next. And right before we do that, though, I'm going to ask that everyone just really mention a gap that they think they have heard about over the last 3 days that they think is most urgent to be addressed. And maybe I'll start in the order that people were in the session. So Dr. Santoro, if you want to go first.
Okay, well, to just deal with the three questions from each day, what I took from day one is I think we are so badly in need of head-to-head comparative effectiveness trials of therapies. There's a number of therapies out there, and we really don't have a way of comparing them to each other, which makes it hard to give any precision to what we're doing with patients. So we wind up with a trial and error approach. I think some of this is a consequence that most of the things that are out there as treatments had to go through the FDA process. And this is not to criticize that process, but
it involves, certain criteria that don't really apply to the average woman. 7 hot flashes a day, that's not going to be necessarily everybody. And I think that provider education and comfort was an issue that really carried through every day, but it was there on day one, and it's there again today. I think we saw a little bit of the answer today, which was how we frame it. And I think for some of the things that are thornier, more difficult, that don't have clear solutions, framing how we give menopause care is an important thing. For day 2, what I took home and what I take home from the SWAN study every time I work with them is that we really need to have a model that has holistic management of menopausal women, that this is a preventive focus that needs to be done for everyone, even before we drill down on symptoms. We need to look at the health of the women. The cardiometabolic changes that we see concurrent with the late transition are staggering to me. And from day 3, I think we have a bunch of system barriers that really are telling us that we need to overhaul our model of care. I loved what UCLA has done. As a former department chair, I find it generally not super profitable to do menopause, so it's a little bit difficult to convince my hospital that they're going to get downstream revenue from doing this. So we probably need to look at a number of different models that will work in different places. In particular, I like the idea of applying centering. So we really have at every level of sort of implementation or clinical care, we have lots and lots of opportunities here.
We
I'm
essentially
going to
have
stop
to
there so other people have time.
change the world. Dr. Giblin, if you want to go next.
Yes, thank you very much. I'll identify a gap, and then I'll speak about the proposed research. And from a patient perspective, too. As a patient advocate, I've had the privilege of listening to thousands of perimenopausal women and postmenopausal women across the country through my work with Red Hot Mamas. Their stories reveal not only unmet medical needs, but also a shared determination to age well. Many aspire to live vibrant, healthy lives well into their later decades, yet they express deep concern about preserving their physical and mental health as they age. So let me begin by speaking about the gap. I'd like to share what women have told me regarding what they think are the biggest barriers in getting quality care during the perimenopause transition.
Karen, we're just going to do gaps, and then we're going to go around and do gaps, and then we'll do next steps.
Well, I'm going to talk about the gap, that women have shared with me regarding they think are the biggest barriers in getting quality care. Their biggest barrier is that they often feel dismissed or not taken seriously when they raise concerns about perimenopause symptoms. When visiting their doctors, they may leave feeling that their concerns were minimized or that their doctor was not fully responsive to their needs. This is often tied to gaps in menopause education because many clinicians had not had enough training to confidently recognize, evaluate, or treat perimenopause. As a result, women have received delayed diagnosis, fragmented care, and they feel they're being undertreated. To improve the outcomes in perimenopausal care, it will require healthcare provider education, not only GYN doctors, but to include other specialties and disciplines, earlier interventions, and more access to evidence-based whole person care, meaning looking beyond the main symptom that they may be coming in with, but recognizing how menopause can affect sleep, mood, energy, focus, relationships, and their overall quality of life. It's about understanding the full picture and not responding to each symptom as if they were completely separate. So that's the big gap that I feel.
Thank you so much. Dr. Neil Perry.
This was a fantastic 2-day for me, but I completely agree with Nanette's comment about comparative effectiveness data. And I would drill down a little bit more in that I think that we need to make sure that it is inclusive. Because as I stated earlier, women with the greatest burden of symptoms are often excluded. So that's our obese women. Many studies have fewer than 5% African American Latino women. And when we think about women with autoimmune disorders and other disorders that may reduce their eligibility for estrogen, these women are often excluded, and there aren't really great options for them. The other thing that really resonated with me is the concept of anticipatory guidance, and that's the idea of the centering of care. While we know that it works really well in pregnancy, we actually don't have the data in menopausal women. So do we know in perimenopausal women, do we know what impact it has on healthcare utilization? So I think there are real opportunities there. And I was very much aghast at just how little we really know about how to treat women with BRCA. Gene mutations in terms of what type of hormonal therapy, how long. And again, this is another group where, you know, the burden could be quite significant, but we don't have good solutions or good answers.
Yeah, I also was struck by like how the BRCA data is very granular in how they have captured estrogen and progestin use separately, which is different, I think, from the rest of the data worlds. And with that, Dr. Wang, what's your biggest data gap?
You know, I would say broadly, I think that we've recognized that we're really trying to answer these advanced clinical questions on top of data that really has not yet ever been fit for purpose. And there's really this absence of like really high quality standardized longitudinal data at all levels across the care continuum. So at their, even knowing the definition of it at their stage of sort of where they are in the continuum of it, at the clinician documentation level, at the administrative level. And so we lack inherently sort of this basic understanding of who is experiencing symptoms when they're occurring, what therapies are being used. And I feel like that without addressing these foundational gaps, all of these downstream efforts still are happening. They're certainly happening, you know, as was sort of alluded to in multiple talks, you know, at an industry level. Or, you know, from a research level, like without sort of addressing those foundational data gaps, I feel like we're going to keep coming back to the central question of like, but in their table one, did they even like, how did they even define it? And so I think that all of those sort of problematic inputs are going to continue to haunt us without addressing those.
It's like we have to go back to basics before we can move forward. On that, maybe we'll go the opposite way around for what we're looking forward to or what we think is the biggest opportunity in this space. Dr. Wang, I don't know if you're ready to go right after.
I mean, well, better data, I think is going to be the one that we've, you know, harped on so much. So, you know, that'll be super quick to solve. But then I'm going to actually highlight one more, even though it's not specific to that question, but I do think we really also, to bring back to Dr. West's talk, I do think we really need a really dedicated effort to understand how patients sort of seek, interpret, and act on health information. And while menopause is like what we're all here to talk about today, I think it extends, you know, even beyond, but particularly for menopause because the evidence is evolving and incomplete and hard and messy. It represents like such a great little petri dish of how we then navigate that. I don't know. I'm always like thinking in like the grants thing. It's like, yes, I'm having you focus on this, but don't worry, we get to care about everybody else too. Right. So I do think that this represents like just such like an exciting space because there is this broad public interest, right, in I deserve hormones in a very different way than there sort of ever has been before, and seeking information in very different ways that there have been before, that it represents a real unique place to gather that information around how they're getting at that, and then how we also create those structures to understand it and potentially help provide guidance in a really hard topic. So that's sort of actually where I would focus after we fix all the data.
It's like we're a canary in the coal mine.
Yeah.
Dr. Neil Perry, what makes you most excited for the future?
Sure, just so many things, so many opportunities. I do think we do need more longitudinal studies in terms of just understanding some of the non-hormonal interventions and how women progress in terms of some of the disease processes that we associate with not using hormonal therapy as well as aging. I think that there are opportunities around what's the best mode and most effective way to educate not just patients, but providers. I think we focus on old approaches to educating a new generation. And we really need to rethink and reorg how we do that. So we're really meeting the needs of both generations. So those would be my thoughts.
I love it. Dr. Gidlin?
Well, I was honorable. It was very honorable to serve as moderator for the general session 1 and 2. And my take from these sessions, the 7 clinicians generated some insights to new research, and also drawing from those conclusions of the speakers, I propose one key research program to address those urgent needs. And again, it's like everyone else here, a large longitudinal observational cohort study to follow a diverse population of women from the onset of perimenopause through the postmenopause. And the study would track the evolution of symptoms, clinical parameters, quality of life over time, and identify the long-term medical consequences of longevity. I propose, from what I heard from the first 1 and 2 session, the major focus of the study would include bleeding, anemia, consequences on fatigue, sleep interruptions on mood and cognition, cardiovascular parameters, the interplay between sleep disruption with the early onset of depression and anxiety, and the implications for treatment, the role of trauma history and psychosocial factors in shaping treatment outcomes, and flexible clinical sub-studies to evaluate the treatment responses in the symptom management in perimenopausal and menopausal women. That list of focus areas could, again, be further expanded. But these are what I suggest, okay, after moderating the first 2 sessions.
Yeah, that's amazing. I'm going to even push you a little harder and say, like, we need a whole clinical trials network for women.
I was just about to put that in the chat.
Yeah.
For women.
And Dr. Santoro? Oh, you're on mute still.
You're muted.
Nanette, you're muted.
It's only 6 years after the pandemic. What the heck? The Ms. Flash series of studies, just to echo the prior comment, I think was one of the very best clinical trial sets that was done in this field, and it was so informative. So bringing something like that back, I think, would be important. But to me, what I found most striking and what I didn't expect was the place where patients were coming from. So what I heard yesterday afternoon about where patients were coming from was so eye-opening that I am of the mind that our biggest opportunity is probably to just take our model of care, take a very careful look at it, and overhaul it 100% to accommodate something that is not, it's not a disease, but it causes a lot of inconvenience. And we need to make this something that's user-friendly for women, because it is so not user-friendly right now.
Yeah, I'm just going to say, like, it's not a disease, right? But there are disorders of menopause, and we don't have an ICD-10 code for any of them.
And there's no ICD-10 code for hot flashes. You can't pull that out of this is a database that you can find. Being bitten by a shark while water skiing, repeat encounter, has a code, but we don't have a code for hot flashes.
And so with that, I'm just going to open it up to all the panelists, and just see if there are any other points that people wanted to make, or any last questions that you wanted to pose for each other, because I'm just trying to be mindful of the time for the ODP folks.
I wanted to just make a comment about the outcome being hot flashes. That is not the only complaint that women have. And I think we need more studies that are looking at other things beyond hot flashes. And also appreciate that, maybe the reduction of 2 hot flashes is all that person needs, right? And so when we're doing studies, it's so stringent in order to say whether or not it's effective. To me, what's most effective is whether my patient feels better. Right, because the numbers are not necessarily reflective or informative if the patient doesn't feel better.
Well, I think that's why I put diagnostics into my list because, like, if to Dr. Wong's point, like, if we don't know when the menopause transition is beginning or where perimenopause starts, we can't actually assess like what's happening with that patient longitudinally or what's important to them. And especially at this time of life where people are getting diagnosed with diabetes also and are also being diagnosed with hypothyroidism or other autoimmune diseases. It's very confusing from both the physician side and the patient side to attribute things to menopause that may just be part of aging.
And 2 things can happen at once, right?
Right.
And so I think that that's really important because what often does happen is that there are these other aspects of healthcare that you can attribute symptoms to, but if they're not getting better, right, there's something else going on. And that's how patients wind up in the system with many visits because they don't feel heard and their symptoms haven't improved.
Absolutely. There's a question in the chat about whether menopause accelerates aging for women. I don't know if anyone wants to take that.
Well, it does seem to change some epigenetic aging markers, but what we don't know is, do they go back? You can look during perimenopause. It does look like there's stress there, but some of this may actually go back. You see this postpartum as well. So reproductive milestones for women are characterized by some of these changes.
Yeah, and some of the flexibility. Dr. Wong, Dr. Giblin, Dr. Santoro, any last comments or thoughts?
Just congratulations for a fantastic conference.
And I think we all bear a shared obligation to elevate menopause science and ensure that women all thrive through their later years beyond menopause. So I think we all share that obligation. So it's been really a pleasure to work with all of you.
Yeah,
absolutely.
Absolutely wonderful. There's a lot of work to be done, and I think that's what makes it exciting.
And with that, I think I'll turn it back over to you, Keisha.
Yes, thank you all. Thank you, our panelists, and thank you, Sarah, for moderating, Dr. Timken, for moderating the panel and for that thoughtful synthesis. We're now going to move to closing remarks. We thank you all for sticking around. We just have a few final things. I'll turn it over to Dr. Anderson.
My apologies for those of you who were expecting us to be finished at 4:30. You can tell there's a lot of enthusiasm here, and I'll just be very quick by first saying on behalf of the independent panel, I offer our thanks to the ODP team, to the NIH directors who gave us their remarks, to the EPC, as well as all of our esteemed presenters and moderators. What I took note of was a real history of women's health research and care that is strong. It's been impactful. It's been useful. And importantly, it's happened in the context of some really tremendous systemic and structural bias against this work and this effort. So kudos to all of you who've persisted in this space. I've also would like to note that a lot of what we heard today and yesterday and the day before reminds us that we really need to continue to figure out how to make menopause care easier to deliver with consideration for how we train the future workforce. And Dr. LaCroix this afternoon talked a lot about, and I thought very convincingly, that while we have a call for more data, we are also in a place where we've learned so much, and we really have to break down these systemic barriers that have prevented us from realizing the full potential of improving women's health. And so with that, I offer to you all the perspective as we think about the future as one of hope. I will commit to you, and I think I speak on behalf of our independent panel, that the work that we're about to do is going to be purposeful around transforming a landscape that, despite a lot of important work to date, is still being characterized sometimes as siloed, with gaps in the workforce preparation. It has resulted in fragmented care, and we want to transform that into a place where we can have a whole person model that's comprehensive, it's harmonized, evidence-based, and trustworthy. So thank you all again for this really amazing 3 days of workshop, and I look forward to the work that's ahead.
Thank you. Thank you, Dr. Arrington. And I'll be brief in my comments as well. As we come to a close, I just wanted to say this has been a very insightful, dynamic, and truly amazing workshop. Together, this workshop has showcased rigorous science, diverse perspectives, and meaningful exchange that will help shape the future of menopause research and care. So as a reminder, I just want to say on behalf of NIH, our Office of Disease Prevention, we are really grateful for your expertise, your questions, your perspectives, and shared throughout these sessions. And we have here, you should, as you log off, a post-workshop survey will appear as you exit Zoom, and it'll also be emailed to you. So your feedback is valuable, so please take time to give us that feedback. Thank you all for your engagement and your continued commitment to advancing menopause research. This concludes the NIH Pathways to Prevention workshop. We are now adjourned. Thank you.